You've got it locked right now. So yeah. Put it in the slides. All right, good morning, everybody. Thank you all for being here. This is our 4th annual Concussion Symposium, and I'm going to just go ahead for the sake of time. We really want to stay on time with our schedule today. We have a lot of different speakers, so I'm going to go ahead and get rolling, and people will trickle in as they come. We also have a lot of people, over 100 folks on virtual as well, so bear with us if we have to sort of take some pauses to make sure that they're hearing us okay, and so on and so forth. So thank you all for being here. Let's see if I can get through these slides. So I may have hit another snag here on the slides. Oh, wait, this is. We had it just a second. There you go. There it is. Okay. So some quick housekeeping things here. We do have virtual participants for you guys. Hopefully you're hearing me okay. Let us know if there's any problems. Make sure your name appears correctly on your screen. Please keep your computers muted at all times, so we don't hear your dogs barking. Use the chat box for questions. We will have a panel at the end, and we'll be saving those questions and addressing them all at that 3:30 time or 3:15 time frame. For all you guys in person, I think most of you guys know the situation. The bathrooms are in that direction, just outside the doors. We have the food out there. We will be taking a break at 10:30 and at noon for lunch. For those of you guys that are following our slides and trying to take notes, we will have all the slides up for you guys. So don't sweat it if we're moving quickly through slides. We'll definitely be able to get you all that. We'll have them on our website as well as the TMC website where you registered. So as far as CME, so you will get a QR code at the end of this symposium. It will also be emailed to you, assuming you registered with the right email. You will need to fill out the evaluation for the CME. THMEP is accredited by the Arizona Medical Association to provide continuing medical education for physicians. THMEP designates this live activity for a maximum of 6 CEUs. Physicians or CMEs, physicians should claim only the credit that commensurates with the extent of their participation. We're getting a little bit of flashing here, but shouldn't be a big deal. No individuals involved in the planning of this presentation or activity reported any relevant financial relationships. All right, so I'm going to go ahead with that, move into my talk about complex concussions. And I think this will set up the rest of the day very nicely because we have folks speaking on different aspects of this. So this is kind of a broader umbrella, and then we'll get into the details as we move through the day. Okay. No financial disclosures. I think most of you guys know me, so I won't get into this here. Our team, we do a combination of sports medicine and brain injury. We're just getting a little flashing here. And that's fine, we can probably work with that. You know, obviously for today, and the symposium in general, the focus is really on concussion and complex concussions and comprehensive concussion care. So this is our comprehensive concussion team. We pride ourselves on having a group of multidisciplinary folks that can not only address the patient directly, but also address therapy needs, rehabilitative needs, oculomotor needs, et cetera, et cetera. You will see some of these folks speaking today. We also have a pediatric sports medicine team. We are the only peds sports medicine group in all of Arizona, or excuse me, Southern Arizona. We have 5 different pediatric trained sports medicine docs. We're all non-operative, and so this is also a big part of what we do. And a few of us are really into the ultrasound guided interventions, and Dr. Ong will be speaking later today on how some of that applies to cervicogenic profile with concussion. We already reviewed this. Okay, so a quick roadmap for sort of where I'm going with my presentation today. So I usually like to start with some case reviews, sort of bring some context and relevance to what we're talking about. And then we will define complex concussions. And in many ways, it all starts there and ends there when you're talking about this group. We will talk about subtyping, the consensus summaries, and how all that plays into evidence-based optimal management for comprehensive concussion care model. Okay, so this is an 11-year-old high school gymnast who had a minor MVA, no loss of consciousness, was in a bit of a fog, had some dizziness, was assessed at school the next day by the nurse, and returned to class saying, I feel fine. Continues with school activities over the next 1 to 2 weeks as usual, doing all her normal things, including completing tests, computer projects, a lot of screen time, lots of note-taking. 2 weeks later, she was hospitalized for a severe headache, dizziness, and difficulty with her speech. She had so much trouble with the cognitive aspect of things, she was almost looking aphasic to her pediatrician. And of course, appropriately so, they admitted her, did some MRIs of the brain, spine, had an EEG. There were some concerns that other things were going on because this was a bit of an atypical presentation. And ultimately, this all her testing was normal. And after a migraine cocktail, she was discharged from the hospital, feeling a little bit better with the diagnosis of mild traumatic brain injury or concussion after about 48 hours. And she was referred to our concussion clinic at that point. We saw her at the clinic at 1 month and did some testing on her and a more thorough evaluation. Cognitive testing showed severe memory and processing deficits. Vestibular testing showed poor postural control and balance. Vision testing also abnormal, smooth pursuits, saccadic movements, and convergence at 14 centimeters, with the upper limit to normal being 6 to 8. So clearly a lot of abnormalities here at 1 month. So the question is, what do we do for this girl next? Where do we go from here? Here's a similar case. 13-year-old boy got elbowed in the head during basketball, no loss of consciousness, had some headaches and some dizziness, but no red flags, was assessed, had no red flags, didn't need to go to the ER for a CT, continued with regular school activities, but complained of ongoing worsening headache and new migraine development. 4 weeks later, saw a neurologist, started on a medication for migraines. MRI was normal. Symptoms continued to progress, however, no longer tolerating sports or even just light exercise. Struggling with academics and grades. This is a 4.0 student who all of a sudden is struggling to even pass, feeling depressed and hopeless. And at this point, no academic accommodations. 3 months out, we see this patient in our clinic. We do a more comprehensive evaluation, and he has severe ongoing cognitive deficits, vestibular deficits, exercise intolerance, as well as cervical spine dysfunction and migraine. So the same question, what do we do with this case? Okay, 3 months out, still suffering from a variety of neurobehavioral, physiologic, and other problems. Okay, so like I said, it all starts here, starts and ends here with complex concussions. I feel like there has to be an understanding of what we're talking about. And until there is, there really isn't going to be a good framework for how to deal with these patients or treat these patients. So from the get-go, complex concussions really, it's still a concussion, so it falls under the mild traumatic brain injury category. So we're talking about a mild traumatic brain injury with persistent post-concussive symptoms, or PPCS. And persistent, really the threshold there is 1 to 3 months. So, for the sake of this talk, I'll be using sort of that 1 month threshold, the more sensitive threshold for prolonged symptoms. So this, you do need some traumatic forces, obviously, just like any other concussion, can be caused by direct or indirect traumatic forces to the brain. You do need to have symptoms. So 1 or more clinical signs and symptoms. By definition, mild traumatic brain injury, your GCS is going to be 13 to 15, and 15 being normal GCS. And typically in this group, we see most commonly cognitive, visual, and mood clusters. I'll show you some of the recent data on this. And just point out that mood cluster, the psychosocial mood issues in this group are very common. So we've seen that 70 to 90% of this group will have depression, anxiety, PTSD, some mixture. So it's a very common cluster, but it's only the predominant cluster or profile about 20% of the time. So it's really important to understand, even though pretty much all of them have psychosocial mood issues, that doesn't mean they don't have other issues, okay? And as we look at sort of how the profiles look, in the research, we can understand that, okay, they may have cognitive, they may have visual, they may have cervical, they may have autonomic, and they may also have mood, but we got to be careful not to put them in the mood box, because if we do, then we're being dismissive of all the other issues they have. So it's really important that we have the experts in the different areas that can work with deficits that they may have in those other clusters or profiles as well. But ultimately, when we talk about complex concussion, it's someone who has a concussion with symptoms that persist longer than a month. And we call that persistent post-concussive symptoms. And from there, it's a variety of outcomes. And we'll talk about that. Some other complex concussions would be if somebody has an associated structural lesion, like a skull fracture, brain bleed, etc., but a very mild course. Right? If they have a more severe course, they're going to start to fall into the moderate brain injury category. But I've seen plenty of patients who have a small bleed and symptomatically are fine in a week. So that still would be considered a complex concussion simply because they had the structural lesion related to the trauma. Okay, so back in 1974, a couple of neurosurgeons in Scotland at the University of Glasgow put together the GCS criteria, all right? And that was the beginning of categorizing TBIs, all right? Mild, moderate, severe, you've all heard of this. The goal here was to define, to really look at the injury presentation and try to predict probable outcomes. That was the goal, right? Based on how patients present initially, what's the probable outcome for us to predict? Obviously, no certainty. So essentially, what the goal here was is to say that mild traumatic brain injuries rarely have prolonged or permanent effects. And moderate traumatic brain injuries commonly will have prolonged or permanent effects, or maybe even that's our expectation. The problem with the categorization is that TBI is on a continuous spectrum. It's not on a line spectrum or on a categorical spectrum. So what that means is that you have overlapping symptoms between mild and moderate TBI. And we know that from the research. We also know that mild traumatic brain injury can go on to have prolonged effects, even in some rare cases, permanent effects. So the bottom line, really, when you think about the continuous spectrum of TBI, and even if you're looking at the mild side, that not all mild traumatic brain injuries or concussions are created equal. These are very much case-by-case scenarios, and you have to approach it that way. Again, there's not going to be some box we can put these guys in with expectations. We have to follow their trajectory of recovery and recognize that everyone may be on a different trajectory ultimately and have different outcomes. So with that said, when we look at this range here, right, between moderate and mild traumatic brain injury, we recognize that these are the folks that are going to have prolonged symptoms and persistent physiologic and neurobehavioral deficits. All right. And so when we talk about this, we go to the evidence and look at, and the track study is a great one. If there's one of these, you guys, look at, it's that one. But really looking at papers that have looked at folks with mild traumatic brain injury at 3 months, at 6 months, at 12 months, and in some cases longer, and looking at what are ongoing symptoms, what are quality of life measures looking like, what are neurocognitive and neuropsych measures looking like. And with respect to persistent deficits, neurophysiologic, neurobehavioral, and if we're talking about imaging, such as MRI with DTI, which Dr. Snyder will get into later today, microstructural injury, not uncommon at all in these folks with mild traumatic brain injury who continue to have symptoms and signs of neurophysiologic deficits, okay? And a classic example, maybe we're doing exertional testing on somebody 6 months out, and they exhibit signs of autonomic dysfunction and can only get to 120, 30 beats per minute on their heart rate when they should be up at 160. So these are the examples we see of these persistent deficits as we move forward in this group that unfortunately falls in that sort of in-between category where they have a mild traumatic brain injury or concussion, but it's more complicated. And so over the last couple of years, we've really been working. This is a group out of Stanford. This is a recent paper, 2021 in Journal of Neurotrauma. And this is a group out of CHOP, Christina Master and her team, really trying to put together this spectrum of mild traumatic brain injury. We understand traumatic brain injury is on a continuous spectrum. But we can even hone in on MTBI and recognize, okay, this is more or less what we're dealing with in this population. There's the sort of the common group, right? Acute, days to weeks, they're better. Sports concussion often falls here. Then you've got the subacute group, weeks to months. And then you've got, and generally it's a hard line at 3 months. Once you're beyond 3 months, we're really getting into what we call a chronic group at this point. So, and that chronic group is months to years. So there isn't really an expectation that in 6 months or 9 months or whatever, it's really, again, going to be case by case. So here's the breakdown, side-by-side comparison of complex and simple, right? So you got your what we call your simple concussions. And these are the folks, 80% of concussions are going to fall into this group, give or take, right? So it's going to be less than a month. And these guys are generally going to do well. Their symptom clusters are usually more physical, headache, vestibulomotor, cervical. Could be anything, but those are the most common. And the management is, we don't want to put anything in a box, but if there's a box to use, it's probably for this group, right? Because the management, generally, the blueprint's pretty straightforward. Removal from play, make sure they get evaluation from a healthcare professional early. We've seen in the research, both of these things impact outcomes. We've also seen in the research that return to learn, return to play, and early intervention, which Randy will be talking about right after me, with sort of rehabilitative strategies and screening for the need for rehabilitative strategies, but in particular, the active rehab protocol become really critical to outcomes as well, okay? And an expectation that all these guys are gonna return to normal activities, again, typically in a matter of weeks. And then you've got the complex group, right? And this group, 1 to 3 months or longer, no expected recovery timeline. Luckily, it's the 20%, okay? But that's still not rare. That's 1 out of 5, okay? So, and we talk about sports concussion and athletes and them being more resilient in general as a population, and that's true, but the numbers are still around 20% even for them, depending, particularly if you're talking about high school athletes. So as you get to the higher levels, there's a lot of reasons why that number gets smaller, okay? More resilient athletes, much higher incentive to continue to play, et cetera, et cetera. This group tends to have more of the cognitive, visual, and mood clusters, like I talked about before. More complex workup is necessary in these folks. We're usually talking about MRI, pituitary tests, et cetera, neuropsych testing, et cetera. And ultimately, that complex workup is essential to rule out other things and then begin a multidisciplinary targeted treatment approach. And medications may be considered in this arm where they're rarely considered in this arm. Or in the second one. All right, so in 2014, UPMC came out with these concussion subtypes. Since that time, we've had a lot of research focus in this area because it's a critical area, particularly for managing complex concussion. I think it's critical across the board. And we subtype everybody that comes in starting day one. We want to know if they're more cognitive or more visual or more mood or whatever. But I think it becomes really critical in the complex concussion because you're much more likely to trigger the multidisciplinary resources that you need, right? Whereas early on, you're probably going to wait. But the information of how they're presenting is very important. So over time, these different papers that have come out with different suggestions of subtyping, the idea has been they sort of built on what UPMC put out, right? Sort of the original 5 and then 6, and then sleep has come in as another one. A couple of areas right now that we feel certainly could be subtypes as we move into the future. Cochlear, a lot of patients have auditory dysfunction. Autonomic is another one. So we will see the subtyping continue to evolve over the next few years. And there's still a lot of very active research there. Here's an abstract we had relatively recently, speaking of cochlear, looking at cochlear dysfunction in our patients that had prolonged symptoms, in our complex concussions. And what we, and for the audiologists out there, they all know this is the case, but what we try to uncover is that this is an under-recognized concussion profile. I have yet to see a paper that has cochlear as a profile. And yet, what was that number? 85% of those that we looked at that had prolonged symptoms were endorsing cochlear symptoms as well. So, that's a pretty big number of folks that are either having tinnitus, sensitivity to sound, or trouble filtering background noises. This is the screen we use over at Spark. It's out of UPMC in May of 2020. That's pretty much when, as soon as we saw it, we were like, that's what we've been waiting for. So we utilize it pretty much right away. So we have several years of data looking at this screen. I'll share a little bit with you. But bottom line, there's 29 questions instead of the SCAT5, which had 22 or 23. And all the questions feed into one of the 7 subtypes that they're looking at here. And so you have an average score for each subtype, and you immediately have a pretty good sense of what type of concussion you're dealing with, or what type of complex concussion you're dealing with. In other words, is it someone who subtypes cognitive visual mood, or is it someone who subtypes cervical sleep and visual? Because that's going to make a big difference in how you approach them. And this is all just from the patient, subjective data from the patient before you ever get your hands on the patient. And I can tell you from having used this for a couple of years now that this screen is really good. And it's most of the time very consistent with objectively what we see. So what we saw is the top 3, and I sort of alluded to this earlier, the top 3 profiles were mood, cognitive, visual. And here is sort of exactly how they look like in pediatric and in adult data. So for both cases, cognitive fatigue was a predominant number 1 in your PPCS patients. And also in both cases, visual and mood were right there second and third. The difference I want to highlight in adults is that cervical kind of snuck in there. So there's definitely more cervical dysfunction in a lot of the adults. And I think part of that is probably because they already have predispositions. As we get older, our necks are not as healthy as they are when we're younger, generally speaking. So, okay, so the management. Ultimately, we want to approach this with an evidence-based approach. There's a lot of research out there, and we're moving from having done a ton of research on simple concussion and how to manage that to doing a lot more looking at complex concussion, because this is really the beast now that we're trying to sort of figure out. And ultimately, these are some critical components that we'll talk about. Subtyping, so we understand what profiles we have, multidisciplinary targeted treatment to those profiles, and understanding the predominant profile. That's kind of obvious, right? If cognitive is their predominant profile, we probably shouldn't ignore that, but also refractory profiles. And we'll talk about that on this next slide. So the concept of refractory profile is still evolving in the research. But as a clinician who sees 30 of these patients a week, hundreds of these patients a month, I can tell you that this is very intuitive for me, right? So the refractory profile is ultimately the profile of greatest resistance to recovery. It may or may not be the predominant profile, okay? But ultimately, it's going to be something that's going to cause you problems, all right? So it's often related to predispositions. So if I have a history of migraine disorder, depression, sleep troubles, right? Those kinds of things can play into a refractory profile that really ultimately is not improving and limiting other profiles from improving as well through the complex interplay that they have. If I'm sleeping 3-4 hours a night and cognitive is my predominant profile, well, how am I going to improve my cognitive profile if I can't improve my sleep, right? So, and that can, interplay with so many other factors of what we're looking at. So ultimately, sleep, mood, visual, cervical can be common refractory profiles, but anything can be a refractory profile. And the thing to keep in mind with these profiles is these refractory profiles will persist despite what you're doing, and they often will have a stagnant trajectory. And when you start to notice that, then it's really critical that you've been aggressive with your treatment for that profile, even if it's not predominant. Okay, so here's a few of the consensus statements that more or less summarize our approach, the evidence-based approach for concussion. And one of the key points is this concept of early intervention, okay? So this is before complex concussion ever happens, all right? And Randy Cohen's gonna talk about this in depth because it's such a critical thing, okay? So we have to understand that the PPCS, the complex concussion battle, starts day one. Doesn't start day 30, it starts day one, right? Because if we do the right things early, we reduce that 20% chance in that particular patient, right? And I'm generalizing 20%. If someone's a high-risk patient, their chance coming in might be much higher than that, right? But we reduce it regardless of what it is to start. And there's some key concepts here. The acute phase really is 24 to 48 hours. So we, case by case, but we can really initiate early intervention as tolerated as early as 24 hours. And that includes a combination of subsymptom threshold exercise, potentially vestibular and cervical rehab exercises based on what's going on with your patient, implementing return to learn, and being really, really on top of triggers and avoiding those triggers. And if these things are done, we've seen again and again in the research in the last 5-10 years that early intervention is better than absolute rest, because that used to be our approach about 10-20 years ago. Oh, let's just give them a week off, sit at home and do nothing, okay? And there's no question we see better outcomes with early intervention. Reduce recovery time, decrease PPCS morbidity, ultimately better outcomes. Okay, so when we look at these consensus summaries, there's a lot of sort of points, critical points being made here that I've already touched on, but the key point with respect to complex concussion in these summaries is that it's up to 20 to 30% of all comers with acute concussion. So you just don't know, but early intervention can reduce the risk. If you have folks that have symptoms beyond 4 to 6 weeks, you need to be thinking about referring them to a concussion specialist to manage them, as well as potentially multiple other multidisciplinary therapeutic interventions. And it's very helpful to be able to identify risk factors for someone that's going to have a complex concussion or a prolonged course. What do those look like? So there's two categories here that are important, and there's papers out there that have taken some of the components of these categories, like the 5P from David Howell and his group at CU, and actually created a risk assessment score. So you can actually get, a quantitative score that more or less ties into a certain percentage that you would expect for somebody to end up with a prolonged course. So historical is basically the predisposition, and anyone who works with concussion or a lot of concussion, all of this will make sense, right? If someone's got previous head injuries, they've got a history of migraine, mood disorder, motion sickness, visual issues, learning disorder, ADHD, these all are going to play into them struggling more in those respective profiles, right? So, and I think this is important too, because sometimes we say, well, you already had migraine, so of course you have migraine. after the concussion. But when you dig deeper and they tell you, yeah, I used to have migraine once a month, now I have it 3 times a day, right? That's the key, right? So they have a predisposition, which is a weak point for them. And the injury is very likely to get after that weak point and make it a lot worse. So it's really critical to compare to baseline and get data and information about what their baseline is. Because yeah, if they had it before, you can say you had it before and you got it now, it's the same. But you need to be able to quantify what it looked like before, because oftentimes before is going to be much better than where they're at. And then you've got the presenting signs and symptoms. And this is also, so maybe I have a total clean bill of health, never had a concussion in my life, totally healthy, none of this stuff. But I show up with a really high symptom burden. I'm dizzy. My BOMS is very positive or pan positive. My NPC is way out there. I'm only tolerating, very light exercise before I have autonomic dysfunction or whatever other symptoms. My cognitive testing looks horrible. And another one is migraine type headaches. So headaches with, particularly if you don't have a migraine history, you're getting headaches with dizziness, nausea, light and sound sensitivity. These are all presenting signs and symptoms that someone's going to have a more prolonged course. Okay. And it doesn't have to be all of them together. Right? It just could be one person presenting and you recognize that their symptom score, whatever screen you use, okay, ours is up to 89, is 85 out of 89. That's a, at least subjectively coming from the patient, that's pretty concerning. And then if we look at their VOMs and we see everything's flaring them up, okay, this person may take a while, even if they've got a very clean history. So, all right. So let's talk about the multidisciplinary approach to treatment. And again, I think it all starts with subtyping because we have to recognize that all concussions aren't created equal and certainly not complex concussions. So we need an individualized plan for each patient. All right. Part of what we need to do with these complex patients is rule out other things. Okay. Especially if they have atypical symptoms that don't quite seem to fall into the complex concussion realm. Of course, the problem is the brain controls many things. So, there's a lot of non-specific stuff. And so generally, in these patients, if they're having symptoms greater than 3 months, we're usually going to do a bit of a more extensive workup that involves an MRI, neuropsychiatric testing. We may do neurophysiologic testing with QEEG, pituitary labs to make sure they don't have pituitary dysfunction, et cetera, et cetera. And a lot of that is rule out. And then we move on to implementing treatment. All right, and we want to use evidence-based multidisciplinary approaches here. So the exertional rehab protocol is still critical for these folks. So we don't want to, almost all of them have some form of exercise intolerance. You just got to figure out where that is, where that threshold is, and continue to work that. It's probably the one single therapeutic dose that's most valuable for them is exercise. So we have to have that part as part of the care plan. So even if someone tells me, oh, no, there's no way I can get on that treadmill, I'll fall over. There's no, we'll put them on a recumbent bike in a dark room, take away all the other stimuli. Let's just see you do this for 10 minutes, 5 minutes, right? We want to figure out, we can make all kinds of adjustments to that dose, but we want to get a dose on board, okay? And then addressing mood and sleep profiles is key. So, these are, like I said earlier, these are common refractory profiles. So someone, particularly with a history of these things, is telling you, I sleep 3 hours a night now. It doesn't really matter what you do. Unless you fix that, they're probably not going to get better, right? So, all right, so exercise intolerance and the active rehab protocol or the exertional rehab protocol, we really do shoot to begin this early intervention. Randy will get into that. But ultimately, the goal here, whether it's early or 3 months out, is subsymptom threshold exercise. So sometimes we do get patients that come to us 3-6 months out, a year out, 2 years out, and for that entire time, they haven't exercised. They used to maybe be runners, but so, well, when I exercise, I get symptomatic. And so my doctor said, well, then don't exercise. But there hasn't been this sort of, okay, what point are you getting symptomatic? Maybe you're a runner that runs 5Ks, maybe you go to the gym and push some weights, and that no longer is something your brain can handle, okay, physiologically. but there is something, there should be a dose that it can't handle. We need to figure out what that is and take advantage of it, at least from a therapeutic perspective. It may not fulfill your athletic needs, but if we want to get better, we need to fulfill your medical needs here, right? So that's the goal there. And ultimately, we want to establish this safe dose of exercise. We refer to it as a step in our clinic that defines intensity, modality, duration, all right? And these two, duration is usually short and we build, but intensity and modality become the keys, all right? So in the last 5 to 10 years, we've had a lot of research on the exertional rehab protocol and the importance of this. This was a paper that was highlighting the new guidelines recommending utilizing exercise early. CDC's message was similar. Limiting the duration of rest in the first days after injury is critical, maybe the most important message of the guideline. AMSSM, a very similar message, getting exercise going early. And ultimately, these consensus statements come from a lot of original research that has been done going all the way back to 2007, 8, and forward. A lot of groups, we love to give credit to John Letty because he's sort of been the lead, but a lot of folks have done a lot of great work in the value of exertional tolerance. This was the first randomized clinical trial in 2019 showing significantly better outcomes in those that were put in the early exertional arm as opposed to a placebo, which was just a stretching arm. Okay, and this was in high school sports concussions for the most part. And this is kind of what it looks like. There's multiple protocols in terms of exertional rehab, Buffalo protocol being the most well-known. They have a treadmill and a bike version. The goal is to determine that exertional dose. We do a 5-step protocol in our clinic, more or less progressing them in a linear way. And then we have a step 5 where we try to do maximal high intensity interval with multi-directional movement to bridge return to sport, which in a lot of our athletes, they're pivoting sports. So, getting to max exertion is often not enough, right? And this was a abstract that we published not too long ago, 1 or 2 years ago, looking at the utility of having a multi-directional submaximal exertional test, exit protocol, so to speak, that ultimately is going to make sure that they're not just ready for max exertion, but they're ready for the type of max exertion training for soccer or tennis or whatever it might look like, which has a lot of multi-directional components to it. And what we found is that 20% of the folks that tolerated max exertion still didn't tolerate step 5. So that's a pretty significant amount. 1 out of 5 that aren't necessarily ready for multi-directional because there's still some residual vestibular problems, right? So, what it might look like is we may get somebody in who's really struggling. We'll start with a recumbent bike and then sort of progress them over time to maybe running and ultimately doing these multi-directional and resistance type of activities. And, what does exercise intolerance look like? So for those of you guys that work with these athletes on the field or in the clinic, stuff like that. So a lot of times the symptoms that they're going to endorse are going to be headache, dizziness, lightheaded, what we call pre-syncope. Hopefully they don't faint, although that's possible. So if we have someone with a syncope history, or maybe that's how they got hurt, we're very careful to keep them on that recumbent bike, right? Because the last thing we need is for them to faint on a treadmill. Nausea can be part of it. And then ultimately we try to hone in on what the causes are. So the well-established causes of EI, exercise intolerance, in the research, hone in on vestibular dysfunction, visual dysfunction, cervical spine, or autonomic. And it could be some combination, but typically there's one key factor here that we can get after to try to help improve their exercise intolerance. And if you're really not seeing signs of those things, it is possible that it's more of a deconditioning process or a burnout process. So it's important to think about that broadly. This was a paper we also relatively recently published looking at etiologies of exercise intolerance. So I was just talking to Randy, and when we do our exertional challenge tests, we monitor every patient, every trial, and so we want to hone in not only on where their dose is, but what is the underlying cause. So we're able to look at markers for autonomic dysfunction, visual, vestibular, cervical spine is something we want to add. But in this paper, what we saw is about 30% autonomic dysfunction in the PPCS group. Okay, so what about cognitive impairment, cognitive fatigue? So we address this typically by, once we've got a clear sense that there's cognitive symptoms and maybe a predominant cognitive profile, we have a few ways to look at this objectively, right? We have computerized cognitive testing. There's many out there. We utilize Impact and Cambridge Brain Sciences. Neuropsychiatric testing is ultimately gold standard. And I think if it's been, longer than 3 to 6 months, that's often something we want to have on board. And then evoked potential is a QEEG-based neurophysiologic test that gives us a sense of their cognitive resources, cognitive capacity. So this has really been something that I would say in the last, again, 5-10 years has really been lifted as a priority for particularly our student athletes. That's kind of where it started. And I've seen a lot of school districts, including here in our community, starting with USD back in 2014-15, really make it priority to have something on board as a policy for return to learn. Okay, so this has picked up a lot of steam. We put together an individualized cognitive action plan, and we do this for work too, and people that it's not just for students. And ultimately, it's a lot of details that go into it, but your return to learn or work plan ultimately considers these factors, right? Not just your cognitive proficiency, but also your cognitive tolerance. Someone may do pretty well on a 20-minute computerized cognitive test, but they may really struggle and poop out at 4 hours when they normally go 8. And you can't ignore that, okay? There's something going on there with cognitive fatigue that we need to address. There may be specific cognitive deficits, say in a visual memory, that can be addressed with speech therapy or occupational therapy. Cognitive accommodations are critical. You need to give them workarounds so they can feel successful in what they're doing day to day, as opposed to feeling like a failure, because that can compound itself to a very negative cycle. And also including critical other aspects, visual, vestibular, exertional, cervical, that may play into their day, right? A kid that has to go from class to class in a busy high school, like say Tucson High, right? And I just had a patient, having to go from one floor all the way to the other, all these kids in between, getting jostled, the noise, all this. Well, so we want to take that into consideration, and from a vestibular perspective, give her a hall pass that allows her to leave 2 minutes early so she doesn't have to deal with all that, right? This is the cognitive recovery zone sheet we've been using at the different schools and school districts for a long time. And this sort of gives you a generic summary of, like a street light, starting with red when for a day or two somebody might be at home, and how we progress them to not just full go. This can't be a 0 to 60 thing. You don't just sit at home, absolute cognitive rest, and then all of a sudden, okay, full blast, let's take the final. There's got to be a process here that matches the healing process, which we know is gradual, right? So then as gradually they're recovering, we move them into different zones, okay? And someone who has more of a simple concussion, it might be 1 day here, a few days here, a few days here, and then they're basically in the green or blue 1 or 2 weeks out. But obviously with complex concussion, we can have somebody be in one of these zones for months. Okay, what about vestibular dysfunction? The key one here is vestibular rehab.
Okay.
So 95%.
I got in, but it took me a while to figure it out.
Okay.
So was it hear anything at all?
Nothing.
I will try to speak over the.
Have you tried to change the speaker mode?
A speaker mode, so where do I go for that?
We've got some noise coming in. I think somebody needs to mute themselves. We've got someone's, one of the virtual speakers. I think it just went away, but okay, great. All right. Okay, so 95% of vestibular dysfunction in concussions is central vestibular. So vestibular rehab, which Jason Klein's going to talk about today, is really the critical answer almost all the time. But there's other components that help the vestibular system recover. Exertional rehab is a key one. We do need to rule out that it's not a peripheral vestibular problem where we need to do a repositioning maneuver to fix a dislodged otolith in one of the inner ears. And also, the cochlear dysfunction often goes along with heavy vestibular dysfunction. They're sitting in the same space in the brain. So really being thoughtful about asking questions relative to sound sensitivity, tinnitus, hearing problems, and doing a referral to audiology or ENT for that. And then sometimes for the folks that have to commute, travel, et cetera, something like an over-the-counter meclizine can be helpful if they're having a lot of motion sickness. We don't use that very often. Vestibular testing, also probably, I assume Jason will get into this, but starting from sort of relatively easy stuff, moving our way down to very advanced, complex stuff that you might see at a balance center. But at the end of the day, we all have the capacity to assess the vestibular system. And if all we do is the balance area scoring system to assess it or the bombs, then we've still done a lot, right? But these are some of the other ways that we approach vestibular testing as well. We utilize sway velocity, Bertec at our clinic with multiple different protocols. And I think it is, always important to be able to implement a Howpike maneuver to rule out that there is a peripheral vestibular, because that could potentially have a really simple fix. And those are the folks that will tell you their symptoms are vertigo, room spinning, and they usually get attacks, right? And if that's the case, then that should, on history, trigger you to really look at the Howpike maneuver and see what happens. Visual dysfunction. So Dr. Pollack will be getting into this in detail. My points here are, really it's important to identify, characterize, and treat visual dysfunction. It often goes missed. I feel like in the last 5-10 years, we've gotten a lot better about recognizing this profile. But even 5 years ago, it really wasn't recognized well at all. And ultimately, this manifests with oculomotor or visual processing deficits. And oculomotor in the sense of the brain trying to control eye movements, whether it's saccadic eye movements to read or convergence to watch a ball coming in, there are problems there. And these are functional visual deficits that can be rehabilitated, and really we expect full recovery, although some of them are more complex. So there's a variety of complex and simple tests, but ultimately it is a central profile. I've always felt that way about vision because 80% of what we do on a day-to-day basis involves our vision. And so it is a player when it comes to school, when it comes to sport, when it comes to exercise, et cetera, et cetera. And we've seen in the research again and again that it is actually a predictor of these things, right? So if we can just look at a near point convergence test on all our patients, you don't have to have $1 million tools. Your finger is all you need. And some good practice to be able to do this the right way. What we've shown in a number of abstracts is that NPC alone, right, can be a predictor of academic tolerance. This is a very strong p-value with NPC. The farther out they are, the more they're struggling, the lower their academic tolerance is. And the closer they get to normal, the closer they are to being able to tolerate full time. Here's NPC and exercise tolerance. A very, very statistically significant trend here of near point convergence being a predictor of what step folks are able to tolerate. The further out it is, the lower the exercise tolerance. And here is near point convergence and King divot utilized to be predictors for post-concussive. So again, like I said earlier, they show up with an NPC of 30. You're a little bit more worried, even with a clean bill of health, that they may end up in this complex concussion arm here. So this is an example of some of the vision testing that goes on at the concussion center. And really the focus is here, right? Static, we got to just make sure their static acuity looks okay, their eyeball looks okay, their retina looks okay. It's rare to have problems here. Very common, 50 to 80% will have problems with dynamic vision. That's essentially what concussion vision syndrome is, right? So, and these are the different tests we utilize. Everyone in this room can do MPC, accommodation, cover, uncover, and bombs. And, some of the more sophisticated tools like oculomotor trackers and visual evoke potentials that we utilize in our clinic, I think really come into play in more of the complex patients. So the treatment for this, we generally still will start off, if they haven't had vestibular rehab, with a good physical therapist that understands vision and functional vision in particular, and how to integrate that into someone's life and into someone's world. That's the first place to start, because a lot of times we can get them there. but also reduce visual loads. If this is a teenager who wants to be on her iPhone, 6 hours a day, then this is going to be a tough thing on top of the injury. So we really have to have that conversation, reduce visual loads. Vision therapy can also be focused. So if we get to a point where we feel like we need a vision therapist or an OT to really focus on vision, we can do that. And I'd say at the end of the road here is that neurooptometric evaluation. So this is where potentially these patients actually are going to need prism glasses or orthoptics to really help with severe and refractory problems with something like near-point convergence, right? We've done all this and they're still sitting at 30 centimeters. Those prisms can be really helpful to just like a knee brace would be for an unstable knee, to help them come along with the rehab and then hopefully get there. So this is a study, relatively recent study, looking at taking away screen time. So they took 48 hours of screen time away from one group, acute concussion, and the other group, they didn't. And they saw significantly better outcomes if you gave up your phone for just 48 hours. It wasn't a week, it was just 48 hours. So anecdotally, I can tell you there's truth to this, okay? I've seen it again and again. They'll come back week 2, week 3, they're still on their phones, even in the room when I'm with them. And eventually it gets across to the families and to the kids. They take the phone away. Oh, the following week, they're doing so much better. Well, who would have guessed, right? So this is a big piece. Cervical dysfunction is also very common, especially in the adults, but you can see this in kids as well. Ultimately, usually this is mechanical musculoskeletal, suboccipital, paraspinal, trapezius, and they present with pain, stiffness, usually some level of limited range of motion, usually not super severe, but it can be. And they'll have chronic muscle spasms and in some cases trigger points. We need to rule out radiculopathy because if they have that, shooting pain or numbness tingling down into their hand or certainly weakness, then we need an MRI. And I think, it is important when you're evaluating C-spine, even though common things are common, to really ask the questions, is this a primary C-spine injury? Or is this a secondary problem because vision's been thrown off so much that they're in a head tilt? And over time, they're going to develop chronic spasms in their neck, or the vestibular system is doing that. So primary, secondary is the first place to start, because if it's secondary, you got to deal with the primary problem. Otherwise, you keep treating the neck and the neck doesn't get better because the primary problem is still there. If we're worried about herniated discs, actual C-spine injury, we've got to get that MRI. But ultimately, most of these folks fall into cervical rehab, possibly some interventions with trigger points, dragging, etc., manual therapy. Dr. Ong will be diving into this, and I think it's a very important profile to dive into. Post-traumatic migraine, Dr. De Leon will be getting into this. And so, I'm going to leave most of this for her. But ultimately, we try to start this approach non-pharmacologic. If someone already had migraine and was on medications, we obviously continue that, have them talk to their neurologist about whether they need to change that dose. But most of our patients, that's not the case, but they may present with post-traumatic migraine type headaches. But we still start with trigger avoidance, things like return to learn really can help that. The exertional rehab protocol, really focusing on sleep. If there's occipital neuralgia, trying to address that. CBT can be helpful. And then once we get into medications, we usually are working with the neurologist at that point, figuring out what the best scenario would be. But someone without a migraine history, that first month, even if they're presenting with post-traumatic migraine headaches, a lot of times we can treat it without having to dive into medications. Mood anxiety, this is obviously an important profile, often a refractory profile. Similar concept, unless there's a history of it and they're already on medications, we try to hold off on treating that because this should be a transient, right? 80% of the time, a couple of weeks, things are going to get better. So there's no reason to put people on medications. But we do need to recognize this, and if it's a refractory profile, we may ultimately need to treat it. But we have a lot of other approaches for this. This simple thing up here, giving exercise to an athlete who got hurt and had that taken away from them, can make all the difference in the world in mood and anxiety, right? So sometimes that's all you need. They have an exercise for a week, they show up at the clinic, we do some testing. Oh, you can exercise up to a vigorous level, no problem. You just can't play your sport yet. And all of a sudden, they're just, on cloud 9, right? So sometimes it's that simple. Other times you got to dig a little bit deeper, deal with coping strategies. Their sleep may be a problem. They may actually need psychotherapy or CBT, cognitive behavioral therapy, which is more where we get into with our complex patients, right? And a number of them are on medications or need to be, and that's where we usually start with SSRIs here. Sleep disturbance, another major one. We have Dan Combs speaking on this, so he does a great job of diving in to all the details. I love his talks. But my points will just be very similar to the last slide. You've got an athlete whose brain is used to, or just a recreational person whose brain is used to a certain level of exercise, and that's critical for their sleep. And you take that away, then their sleep's going to suffer. So if you can give that back in the form of the active rehab protocol, that can make a big difference. We really focus a lot on sleep hygiene in this group. The routine is critical. There's so much to talk about there. I'll leave that for Dr. Combs. And then ultimately, if we do utilize something, we usually start with some melatonin. Generally don't need to do too much more unless someone's really struggling, and then there's other medication options. So sort of back to where we started with the UPMC profiles, adding others, and really being thoughtful about concussion, and particularly complex concussion, and using this paradigm, taking this model to think about it instead of figuring out what box we can easily put them in. And if we do this, then we can really address all the problems that they're endorsing. We can objectively assess most of these profiles. So if there's a disconnect there, then we can figure out why. And ultimately, using this strategy, which is matching targeted interventions that are active interventions, not sit at home and let's just see if your vestibular profile improves. Let's get you in with someone that can work on that with you, particularly if you've had it now for 3 months. Okay, so I got 5 minutes to get back to this case, which is perfect, because I wanted to get back to this question, right? What do we do now? So this is the way we approached this case, but let me just show you some of the testing that I said refer to. So this teenager had King-Divitt scores that were well outside of normal for age matched. Near point convergence was 17. I mentioned earlier, upper limits of normal is 6 to 8 in that group. And accommodation was also long and asymmetric. So right away, this vision screening is telling you there's probably some oculomotor problems going on, and they're pretty significant. Vestibular, this was what the sway velocity data looked like, as well as the best testing, both abnormal. With sway velocity data, we have normative data, which is the gray, and the red represents what the patient was doing, well outside of normative, more than 3 sigma. So we knew this was probably a problem. Oculomotor tracking. So the dotted line in the middle is where the target is. The blue and red represent the left and right eye of the patient. So a lot of significant saccadic dysfunction, obviously, and the latency is very delayed. So from the moment the target shows up to when the saccade is initiated is significant. I can tell you about a 150% delay there. So, and that kind of goes along with his visual symptoms and also the King-Divitt test being a struggle, because that's a lot of quick saccadic movements. We've actually done an abstract to look at saccades and oculomotor trackers in comparison with KDs, and we see pretty good correlation. Smooth pursuits, also not where they should be. These are choppy, smooth pursuits. Cognitive scores, not bad on the memory. Those may or may not be normal for this person. We didn't have a baseline. But when we look at the processing speed score, when we look at the reaction time, way outside of 3 sigma, not normal. So, and this is someone who put a very good effort in with the impulse control score of 5. Neurophysiologic testing, so evoked potentials. You can see the reference range, age match for this person, well below that with respect to P300s. The central parietal region is where we expect to see a P300 voltage that looks like this in a normal case in response to an auditory oddball stimulus. But of course, there isn't really anything going on there. So definitely an abnormal evoked potential as well. So what did we do? So the management ultimately fell into right here. So we initiated school accommodations. Neuropsychiatric testing in 504 may be down the pike. I mean, you usually like to give it 3 months of really implementing strategies first. And then if you're not getting anywhere, you're looking at more of a long-term issue, then you can go down that path. Exertional rehab, physical therapy for vestibular rehab, cervical rehab, OT and neurooptometric rehab for vision therapy, cognitive behavioral therapy for mood and anxiety symptoms. An MRI and pituitary labs were obtained to rule out other problems. And then considering medications, particularly for symptomatic relief in this case, say migraine, sleep, mood. There are no FDA-approved medications for concussions because none of them have been shown to change outcomes. So we don't just use a med we really use it based on symptomatic relief. So what are the conclusions, the take-home points? Number one, again, starting and beginning with understanding what we're talking about when we say persistent post-concussive syndrome, symptoms, or complex concussion. A lot of different words, chronic concussion, to essentially mean the same thing. Someone with a mild traumatic brain injury who 1 to 3 months later is still not better and has significant symptoms. Okay, that's going to be someone that we got to work with, and individualized and targeted treatments are key. We want to be multidisciplinary with the treatments that we put into place for all the different profiles. Understanding there's an interconnectivity and that the profiles influence each other, and ultimately treating the predominant and refractory profiles are really potentially the keys to full recovery. So I think I'm out of time, and I'll leave that there. Dr. Osler is one of my favorites in terms of quotes. So this is one of my favorite ones, but I think we're ready for our next one. All right, thank you guys, appreciate it. I'll just go ahead and do a quick introduction. So Randy Cohen has been kind enough to come and speak to us on the early intervention and early screening. And we've known each other pretty much for as long as I've been here. I think he was one of the guys I met on my first interview at the U of A back in 2014. So it's wonderful to have you.
Great.
Thank you.
Thanks.
Thanks, Randy.
All right, where's the picture right here? Nice. You move me forward or not? Okay, oh, is there a delay? Okay, there we go. Nope. This one got it. Okay, this one's getting it, but this one's not. I meant. My screen next. I'll start talking while we're getting this set up. First, thanks for having me here. Dr. Mo just completely set me up with a lob pitch to hit it, so this is nice. And I'd say I've been doing concussion presentations for probably close to 10 years now, and this is probably the first time I've ever been set up where everything's kind of flows right, and I don't have to kind of start with this. We're finally talking about the active treatment of concussions, and I'll tell you my perspective and where I came from, and because you always like to know who talks to you, where their background is. The first thing I'll say is I have a gap, okay? My perspective is not at all with pediatric populations, okay? So I'm talking from 18 moving forward. And I'm a trained, physical therapist, athletic trainer, but really I've worked as an athletic trainer for 30 years. And my background is in college athletics. And we did not see for numerous years a lot of these prolonged stuff. And you think we have the most hits. We have people playing college football for years and taking multiple hits. We didn't see them. And the reason why is and when we did when UPMC, Mickey Collins and their group did a team approach for treatment of concussions in 2000. We met in 2005 before we wrote a paper. He brought 25 experts in concussion in the world in to talk about active treatment, because no one was talking about active treatment. And he brought me in. Okay, I was number 26. There's 25 extras and me, and there's all these extras. I'm like, and Mickey and I have known each other for years. We've been friends, and we've worked with patients. And he said, I want you to talk. And I'm like, why would I talk? I go, you got the experts here. The difference of being a college athletic trainer and working with college football for years is we had the great opportunity. We knew our patient before they were a patient. We knew all the risk factors before they took the hit. The moment they took the hit, we were there. We saw it initially. We intervened at that particular time. We managed all the variables up until when they returned. Then we followed them after they returned. Then we knew them after. And then we knew them later on, years later, and when they had kids and all this other stuff, right? So I had the opportunity to manage all the variables early on. When you manage the variables, you don't let these long-term problems occur. You can prevent a lot of these long-term problems, okay? Now, I'm caveat that with the 18 to above. Now, the pediatric, I think we can, I hope we can, and Mo is probably more of an expert in that area, and most of you in the room are more expert in that area, but I think we can. So what do we do early on to kind of manage these and look at these? So if I don't have any financial, that's me. There's our objectives. I want to talk a little bit different concepts. So the difference between treatment and concussion and return to play, okay? Treatment should start right away, okay? And in treatment should even occur after they return, okay? Because I'm going to show a bunch of data is we allow people to go back and they're back doing full activities and they're not normal. They are not back to all the little details we can manage and we can measure. Should we still be allowing them to return? Well, we know from the data we see and what we've seen, anecdotally, they're not having these long-term consequences later on, but they're having other things like risk of other injury, risk of lower extremity injury and things of that. And we're going to talk a little about that. And return to play is progression from medical clearance to full unrestricted activity. If it's sport, if it's work, whatever it is. Hey, you can go back to do everything. But that doesn't stop treatment, and it shouldn't stop treatment. And that's one of the things we want to talk about a little bit. So here's the misconceptions is once an athlete's cleared their return, they're 100% recovered. They're not. Once a person's cleared, they're not. There's some deficits you can still find. They may not feel symptoms, they may not notice them, but they're not completely reacting normal. And then there's nothing we can do early on to help the recovery. And I used to have to put this up there. I put possible misconceptions when I first started doing this. Then I went misconceptions. And now I think almost everybody realizes that, which is phenomenal now because I don't have to go in that. So this was the conventional thinking is 2014, a majority, 80 to 90% resolved in 7 to 10 days. The data doesn't show that anymore, okay? Justification for early treatment. We know that, you can assess for these things early on, vestibular operative dysfunction, has a factor in what we used to call post-concussion syndrome. Luckily, we're not using that term anymore, and we should not. It's not a syndrome, it's prolonged concussion symptoms. And vestibular operative dysfunction was only found in 28% of the pediatric population, but 62% of them were the people who had the prolonged symptoms. So if we can just look right off the bat of vestibular ocular, and Mo talked about that, so that's perfect. So justification for early treatment. These, in the next few slides, are going to be, these are performance measures after somebody returns in athletics. We know they did very good studies in NFL, or first of all, in baseball, where they looked at all batting statistics. And the athlete was out for 2 weeks with a concussion or out 2 weeks with either bereavement or paternity. They did not practice, they did not do anything for 2 weeks. Statistically speaking, across the board, the batting statistics after they returned with concussion were lower than when they were off for 2 weeks. So it wasn't the 2 weeks they missed, the systems aren't back to normal. Same thing they did a nice study in Georgia a few years back about, they did driving simulators, reaction time in driving simulators were significantly less than people after, post-concussion. They looked at, they're doing more and more of these, there's some shooting percentages in the NBA that are down. There's some studies on that. In the NFL, they really didn't find statistical analysis of how well they played, but they looked at a 10-year period and fantasy football, and statistically the fantasy football scores were lower in people when they returned for a concussion. So if you play fantasy football, take that person out of your lineup if they had a concussion and they're returning in the first 2 weeks because your scores are going to statistically be lower. So if you play fantasy football, you do that. This is a great meta-analysis that just came out, and this looks at the risk of lower extremity, and this was a systematic review. And across the board, we know there's a higher risk of lower extremity injury after return for a concussion. It depends on your studies. You say look at the different studies, 2 weeks, a month, even up to a year. Okay. And so here's a bunch of the research on that, up to how many days you have most likely risk of lower extremity injury and other injuries when they return. Dual tasking later on, even up to 1 year later, was worse, and they had a higher risk of injury. So early intervention is the key to preventing this type of stuff. Why is this, right? We have cognitive reserve. We know this from the research, you have cognitive reserve. And they know this from MRIs. You might have a significant damage in the brain, but people aren't symptomatic. Why? The brain accommodates. Well, when you're doing, so the brain has these accommodations, it has workarounds. So you don't notice, you don't get a headache specifically. You don't get, until you don't get dizziness, you don't get low loss of balance. Until they don't notice it. Until you stress the brain at the highest level, then it comes out. So you don't allow those accommodations to work. The system has to all work together, and it doesn't. So why do we need to intervene early? We need to do this. Mo went through these, these phenotypes, these disorders, dysfunctions, whatever you want to call them, subtypes. You manage all these down. We have those. We know those. We went through that. This is my term of rethinking a concussion. Okay, if I get a diagnosis from a concussion from a doctor, I look at that like I have a diagnosis as a twisted ankle from an orthopedist. But what's a twisted ankle? Twisted ankle could be as much as you fractured, you have a Liz Frank fracture and they twist their ankle and they're out for 6 months and need surgery, versus it's a mild strain and they can go participate that day. Okay? A concussion in my mind is the mechanism to cause some disorder. And the disorders all come together. So the disorders are, you have all these things. If I can figure out which these, I can treat any one of these things. But I can't treat a concussion, just like I can't treat a twisted ankle. But I can treat a anterior talofibular ligament sprain of an ankle. I know how to treat that as a clinician, but I don't know how to treat a twisted ankle. I have to figure out what isn't working, right? And these are all come together. So if I can figure out which ones of these they have, I can test. Or we figure out which one they're predisposed to, and then we intervene early so this doesn't become one of these problems, okay? So if you look at the predictors of long recovery, okay, we've had these for multiple years. Now the Keystone one is the first one by McCrae and his group back, this is a good one where, if you look at the, unconsciousness and post-traumatic amnesia, all unconsciousness isn't necessarily a predictor of prolonged recovery, but we've rested people more we've helped people out more when they're unconscious. So it wasn't truly a factor. These people had symptoms longer. So, but that's the only one it does. The other one, what is anxiety and female and younger athletes and learning disabilities and dizziness on the field is definitely one. Dizziness immediately is a big predictor, so you need to kind of really keep an eye out for that. Of course, greater symptom load and fogginess, like Mo mentioned. Pre-existing condition before of motion sickness, of oculomotor dysfunction, lazy eye. You have to do a good clinical interview to see if they have these pre-existing conditions. If they do, you need to intervene very quickly, okay? Or you have this on your neurological pre-participation screen in those questions, because then if you know that beforehand, if you're working with people you've done a physical on, hopefully we have some people in here, a lot of people in here who do that, you know what they're predisposed to. So if they get a hit, hey, I know right away they've had pre-existing condition of motion sensitivity, that the vestibular system already has a little bit of a deficit that can't manage. So you intervene on that right away, and you look for that right away, and you get them to people sooner and right away. Okay? Is this thing giving you guys like seizures right here?
Yes.
Straight in the front? Yeah, we might need to turn this sideways and let you guys look sideways or something. Well, continue to participate and take more hits or exerting after the initial contact is a huge risk factor. Okay, and we can talk a little about that. And exercise intolerance and of course psychological issues is the other huge factor. So predictor of long recovery, actually I think Mo mentioned this right here. This is a very big large study where they looked at 587,000 adults diagnosed with a concussion, and they looked for adults. If you looked at it, prehistory of psychiatric disorder, anxiety, and depression was the highest one. So that psychological disorder, depression, if they have history of that is, you need to address that right away. So what is your evaluation to determine these things? We have this huge evaluation, and Mo just went through all the things they do. It really comes down to one of the most important ones: a good clinical interview. Find out what predisposing factors they have. Okay. I also am a big believer of assessing what secondary gains are, especially with the younger people, this younger population. You got to figure out if they're playing football, if it's a football injury, are they playing football because they want to play football? Are they playing football because their father wants them to play football, right? And they don't really like playing, and they want to do something different. And so there's some secondary gain. The other thing I've seen a lot at the college setting, prolonged concussion symptoms, this weird thing that's hard to manage. And that in a certain group of population, you have to tox screen them and look at the THC levels they're taking. Because if they're using cannabis and they're smoking a lot or vaping or taking, which we have a lot more in our society, that complicates it significantly and that prolongs it and overlaps the symptoms. They all get overlapped together. Okay. So simple things is going all the way down here. The VOMS is a great screen to start to look for the things, and what do you do with them? Exercise, we mentioned that, and then sleep is vital. So the clinical interview, you look for these, kind of things we talked about in the clinical interview to really kind of get down to what are the risk factors. If you can get those early, you get intervention early, okay? VOMs we mentioned, and we talked about that. Vestibular disorder, if you do an impact, 3-letter sequence, X and O's, okay? And VOR and VO and motion sensitivity or, VOR cancellation. That's a simple screen to say, oh, you have some vestibular issue. We need to get that intervened right away, right? Symptoms that, increasing symptoms at the end of the day from an overload, symptoms in a busy environment, which we talked about, great, the classroom where you're at, but they have less symptoms in the morning when they wake up. How do you feel this morning when you woke up? Oh, I felt I had more energy. Okay, how did you feel after you drove someplace or somebody drove you? My symptoms were worse. Okay, that's vestibular. That's a very simple thing. I was in a busy environment, things going on around me, cars are going around me, driving like this, and I'm worse. Very simple screen. Now, anxiety is associated with vestibular. Like I mentioned about some of these countries. If you all of a sudden get in busy environments and they start to get symptomatic, then you have to turn around and think, wait a minute, they're going to have anxious about being in busy environments. They're going to be anxious about going to school. I don't want to go to school because I start to feel worse when I go to school. These link together. So if you can put this together, the ocular motor assessment, which Mo talked about quite a bit, and that's all that reading and math comprehension stuff in school and things like that, that'll get you. Looking at eye alignments early on, because you will start to see some changing in eye alignments, in these people who have these, red flags for, getting advanced evaluation very quickly, visual acuity changes, flashes of light, diplopia, misalignment of the eyes, your near point, you have that large near point convergence and it's just not getting better quickly. Get them in, and vestibular and cochlear, like you mentioned, some any hearing changes, ringing in ears, vertigo, spinning, dizziness, with strain activity. Those are we got to get those assessed quicker, get them to somebody quicker than later. Okay. The cerebrogenic headache, we talked quite a bit about that. We talk about the vestibular, we talk about vestibular spinal nerve, vestibular ocular, but we don't talk a lot about vestibular colic. The vestibular colic is the reflex to stabilize your neck. So your neck has stability, so your eyes can work and you can move your body. Well, if you sprained your neck, that affects that work. So you have to actually, it's just like any other, it's any other ones, you get to start to train that again. So you got to do some neck activity. If they have neck stuff, it's not just doing manual therapy, it's actually doing some stability things and some quick reaction changing of the neck to work and stabilize that. Okay? Autonomic nervous system dysfunction, I think is a significant thing. You need to look for that. So if you have an autonomic nervous system dysfunction, okay, so you have a sleep and you have an exercise intolerance, you have a heart rate variability change, right? What does that affect? That affects anxiety. You have more anxiety because you have a disconnect of your parasympathetic and your sympathetic nervous system, right? So it affects your anxiety. It definitely affects sleep, okay? And so all these things start to I just tell people you're starting to mix a pot together and you're stirring everything up. So if you can start to address one of these right away, you prevent the other ones from becoming worse. Okay, or even exacerbating another one that isn't really affected, you exacerbate it, then it becomes the one that you can't get better. So if you can get to these early and fix these things early, then you're not letting that pot stir. What is rest? And I love it that I don't have to talk about this anymore, but all it is doing all activities you can do without exacerbating your symptoms. It's allowing them to have their normal life, right? Without secondary trauma, of course, because we don't want to all that impact, the second impact from mature brain, or the vulnerability from that metabolism change early on, all the stuff with Giza and work out in Prims about what it physiologically is a concussion, and we're going to have those in a minute. I'm going to show you, we're going to go through those really quick, right? So you got this rest you want, all the data shows if you cognitively shut them down and physically shut them down, they become worse. If you cognitively overload them and you physically overload them, they become worse. So you find the happy medium of what they can do. Okay? You got to figure that out. And that's what you got to figure out as a clinician. Okay? So what is the pathophysiology of the concussion, right? Because we get the people come back and say, I'm a year later and I'm still having concussion problems. No, you're not. Your concussion heals, right? What is the cascade of a concussion? You get this trauma, you get this metabolic cascade of the trauma, you get this is what happens, you get the cell death, you get the axonal injury, you get the altered neurotransmitter, all that kind of stuff that happens, all the stuff out of UCLA with Giza, with Chris and his group out there. Then you get this metacalyx cascade. In over these 10 days, you get this inflammatory response, a little bit of this demyelinization. You decrease your cerebral blood flow, okay? So you get this decrease in cerebral blood flow, which is a huge, which is something we're gonna talk about in a minute, because that's very important to watch for the first 7 to 10 days. So you get this cerebral blood flow. I'm gonna talk about that a little bit. So you get this cerebral blood flow decrease. So you don't have increased cerebral blood flow to the area. You have cell death that's going on in the area, okay? So if you do more activity where it needs more blood flow because you need energy, it can't get the energy because the cerebral blood flow is going down. So you're starting that cascade down. So one of the first things we're going to talk about is fueling the system appropriately. We're going to talk about that in a minute. But everything kind of goes back to physiology, the pathophysiology of this, okay? We have to think about this in the future more, okay? This is the gut-brain interaction. The vagal nerve goes up and down between the gut and the brain. It's one of the only nerves that has afferent and efferent between the brain and the gut. We know the fact that this is going to be a huge factor. So what they eat nutrition-wise, there's more and more data on simple sugars have a huge impact on this and a negative impact, right? Is Alzheimer's the type 3 diabetes? Who's heard that in here? You should start to hear that. Is Alzheimer's the type 3 diabetes? Does it have to do with the gut and the vagal nerve? And simple sugars in our diet that we eat, can we affect this? This is going to be a huge future. There's data out there on lactose intolerance after concussion. It changes your gut. You have nausea, right? You have nausea with it. So did you get you can ask it, hey, are you having trouble eating anything now? Oh, wait a minute, that does. Okay, well, you need to avoid eating those so you don't have that negative interaction. And the simple sugars are going to be probably the key that we need to get away from all those simple sugars early on, but that's for the future. Okay. Again, I mentioned this, for all this data, the highest activities and lowest activities were the worst outcomes for athletes. Strict rest. I don't have to go through these anymore. This is awesome. I can fly through all this rest. So here's the hypothesis of what rest is. Increase in symptoms occur during the metabolic mismatch for the first 14 days, okay? First 14, 17 days, okay? You want to work at a level that doesn't cause that mismatch. Allow them to work and prevent that posterior secondary trauma, okay? What are some of the exacerbating activities? We know these. Photophobia. Well, let them wear lights. Let them do activity, turn the screen down on your computer, right? You talk about taking them off their phone. Or you say, don't get on your phone, but if you take the phone away to social media, the interaction with the kids for even 48 hours, that may increase their anxiety and their stress, right? Tell them to get on a tablet or computer. Make the font bigger. If you have a near-point convergence issue, you don't want to have to track in to say something. So if you make the font bigger, you're not overloading that system, okay? Take the light of the computer or take the light of the tablet and put it down to the light mode. If you have photosensitivity, if you lower the screen, you go to the yellow node, the light mode, you're not overloading that system, okay? Fogginess, just you allow them to do stuff at shorter periods of time. The cognitive fatigue and deficits, dizziness. Don't overload the vestibular system. I tell a story about we had a gal years ago that actually is an athletic trainer. She had multiple concussions and had some issues with them, and she had a vestibular issue bad. She'd wake up in the morning, felt great. The vestibular system rested at night. She'd drive to campus, and all of a sudden, by the time she got to campus, her system was overloaded. So I said, okay, that's where, we had her wear a hooded sweatshirt for the drive in. Somebody else drove her in. And then by the time she came to class, she was able to go to class and watch the board. She didn't have oculomotors, vestibular. So she was able to handle class without overloading her system. But the drive in messed her up. So we did his sweatshirt. You don't want to do that for long times because you have to expose the system to recover it. But you decrease the irritation, okay, early on, okay? Anxiety, please don't ever isolate people. Normalize their feeling. I spend half the time when I see, now I'm at U of A, but also we have the physio shop, our clinic. And I think 90% of the time when I'm treating people, when I bring people in with the long-term concussion symptom stuff, it's normalizing, hey, you're going to get better. You're going to be okay. Because the anxiety is driven, like I have a permanent brain injury, I'm never going to be right again. That becomes this concept, and we got to break that. If you have convergence injury, like I mentioned, larger font, move away from the screen. Cervogenic, make sure you definitely watch posture. Don't let somebody be like this guy. This is a young man in the end right here that he had symptoms for a while, and he had ocular motor issues and cervical issue. And when you come and put a hot pack on, he was on his phone, he was like this. And I had to correct him all the time on it. It's like, so that way, Angie's saying, okay, you can't do that, you have to lay yourself down. Okay, now we talked about this. Sleep early on is 100% the key, okay? Sleep is 100% the key. We have a whole lecture on sleep. This is great. But if they're not sleeping normal, they will not be, it doesn't matter what you do, what interventions you do, it doesn't help, right? And why is this? We know, I can go through this, but it's basically all the recovery occurs during sleep, okay? There's lots now, I got all kinds of data in here. You can look at this, all this research on sleep, how sleep has a huge factor on it. It has a lot to do with the lymphatic system, right? The lymphatic system only works during deep sleep and it cleans all the waste material out of the brain, okay? First of all, if we don't sleep, anybody who hasn't slept for like 3 or 4 or 5 days, you feel lethargic, you have a headache, you can't concentrate, your vision is shaky, you automatically have that. You build up waste materials and it doesn't clear it out. If you have a concussion and you have the injury, you have more waste materials, right? Because you have cell death. Mild cell death, it's small, it's not a lot, but you have cell death, so you have this waste material. You have to clean it out. The lymphatic system cleans it out. So if you don't get sleep right, so if you can fix anything to prevent prolonged problems, it's fix the sleep right away. Manage the sleep. How are you sleeping? You know, and I don't need to do that because somebody else is going to talk about that, which is great, right? Exercise regulation to improve sleep. Autonomic nervous system function, exercise and sleep, right? Exercise and sleep right off the bat. If you can manage those right away, you're gonna address a lot of the issues that you have. Treatments for sleep, I don't need to go through that. Exercise and intervention, why it's positive. Luckily, other people are talking about that. I don't need to go through that. Something's flying through my slides. This is great. So again, if you look at early exercise and the risk, again, there's great data that early exercise within, let's see this one right here. Participation in physical activity with 1 week after the injury will benefit recovery. So we got to get them exercising, and Mo eloquently talked about that. Create the exercise program. Stay below the level of symptom increase, okay? Monitor sleep, hydration, orthostatics, and calorie intake. If they're dehydrated and if they start to get symptoms from exercise, is it because they're dehydrated? Is it because they don't have any calories? Is it because of exercise intolerance? Is it because of vestibular overload, right? If they have so you figure all that stuff out. So you manage these variables. Make sure you're drinking a lot during your exercise, that you don't have any dehydration. Okay. Make sure that they're taking calories in when they do their exercise. If you have a metabolic mismatch, you have an energy deficit. Okay. You then have to feed the system, fuel the system. Okay. So things like managing it and kind of we'll talk about that in a minute. But examples, some other treatment examples: anxiety with a vestibular dysfunction, right? Combined, exercise and busy environment will overload them. Okay, exercise induced in a low, you want to do a low vestibular stimulating system, like Mo mentioned, in a dark, in a darker room on a stationary bike. Anxiety or ocular motor issues without vestibular. Sometimes you look at your impact will be no visual motor deficit. You can exercise the heck out of those people usually hard, and that's a good thing right away, right? So let's talk about nutrition. If you have somebody who has symptoms, okay, and they start to do activity and they have an increase in symptoms, it's because you're overloading the system or you're not fueling the system. We have decreased cerebral blood flow. At the same time, we have an injury to an area. We know that area needs more nutrients to heal itself. Okay, the area can't get nutrients because it has decreased cerebral blood flow. Okay. We know that the brain doesn't store any glucose. It has to be readily circulating glucose. So if you do not feed the system, do your symptoms increase because you don't have readily available energy for the brain to work. I've seen that. You have a kid come in and say they get on the bike right away, and after and they start going, they go, oh man, I don't feel really good. I'm starting to get a little more symptoms. I'm getting a headache, lightheaded. Have you eaten anything? No. Okay. But that's the thing. Here's some simple things. And I like to do complex carbohydrates. So you will give some simple sugars, but probably shouldn't do that. I used to do that. Here's a Powerade. Here's some gel blocks. Eat that. Then they get back on the bike. They felt a lot better. The symptoms weren't because of an autonomic nervous system dysfunction, exercise intolerance, vestibular overload. You didn't have fuel in the system. So I tell people who have concussions, you carry snack mix with you early on, and you eat every 2 hours. Fuel the system consistently throughout the day. Do not get to a glucose level where you drop down circulating glucose, because if your symptoms increase, it may just be that you don't have glucose for your brain to work. Okay? And you have a decreased cerebral blood flow. And you have an area that doesn't get the blood flow as quickly. And it doesn't have efficiency to get to the energy. So feed them. Feed them. Allow sleep and let them and eat consistently. There may be some data on the ketogenic diet a little bit early on. Fish oil, we know that DHA is what the brain uses to heal, right? So there is some data, there is some data on fish oil, high loads fish oil, because it doesn't hurt you anyway. Primarily DHA over EPA, but you can do a combination of both. This is Dr. Lewis's omega-3. Yeah, he wrote a book on brain health. This is his loading of his omega-3s, and I like doing the loading because it's not harmful anyway. And does it help? It's got it. At least we know that DHA does help. So I have them do DHA, load DHA. Okay. So nutrition, glucose not stored in the brain. I mentioned that. Need to have consistent glucose levels. Okay. Need to keep these levels up. You have a higher demand of energy. The damage doesn't get as efficiently. Eat every 2 hours. Complex carbohydrates for the energy. And looking at trying to do the anti-inflammatory diet. Okay, kind of talk about that. Here's Dr. Wiles' anti-inflammatory diet. Dr. Wiles has some great things in Tucson. If you ever get to go and you hear his lectures and what he's doing, a great thing with the Integrated Medicine Center. It's phenomenal. Psychological mood disorders. These are the other things. Screen for this. 2 minutes. Okay, I gotta go. 2 minutes. Screen for psychological disorders early on. We know that. Okay. Okay. Again, we talk about PTSD, screen for that because that has a huge overlapping symptoms. Okay. Cognitive serogenic, you treat your serogenic, make sure you're doing that and screen that early, get that worked on early. Post-traumatic migraine, is it a primary or secondary? Is a migraine because of sleep issue, vestibular, oculomotor, anxiety, energy? Okay, or is it because truly a migraine? If it truly is kind of like a migraine cluster, the previous history of migraine, get into a neurologist and manage migraine quicker. Okay, cognitive fatigue, do not let this occur. This one grinds in, so don't let that end of the day cognitive fatigue. Don't let them push through this. Okay, fuel the system for those. Your vestibular, we talked about this, some of the risks of screening and getting into a vestibular assessment early on. So your early treatment approach, this is kind of what I just summarized, right? You have to expose the system, but don't overload the system. Making them a little symptomatic and then backing down is good, okay? If you don't ever make them symptomatic, you're not pushing the system probably enough. You have to expose it, recover. But you want to do that in a controlled manner so at the end of the day, they don't have cognitive fatigue and their symptoms aren't worse. Okay? And there it is.
Always a blast listening to Randy. Thanks so much. And we'll have questions at the end. I'm sure many of you have great questions, and we're already getting some great questions in the chat. So we have 2 speakers that unfortunately, because of COVID, have to speak remotely. Dr. De Leon is up next on post-traumatic headache with a focus on persistent post-traumatic headaches and migraine loop or not. We are actively trying to make her the host right now so that she can click through her own slides. We will do the same for Dr. Streeter down here at 12:45. Her talk on concussion telehealth will be done remote. So I find that to be somewhat and we will have our 10-minute break right after Dr. De Leon's talk here. We'll try to get her going pretty quickly here. Okay, Dr. De Leon, if you can hear me, Jessica is saying to share your slides, like a screen share. Yeah. So if you can do a screen share, then we should be able to see your slides up on the screen. We don't see them yet.
There we go.
Okay, looks like they're loading. All right. Dr. De Leon, are you there?
Yes, I am here. Hi
Okay,
there.
perfect.
Hi to everybody. Can you guys hear me okay?
Yes, we can.
Okay, Dr. De Leon, our neurologist, I'm going to go ahead and pass the mic over to you, Dr. De Leon, and let you go ahead. Thank you.
Great. Thank you so much. It's such a privilege and a pleasure. And thank you so much for the invitation. Again, I'm sorry I can't be there, but I don't want to infect everybody. And I guess thanks to COVID, at least for the Zoom, right? So we can do this. But I'm very excited to give this presentation and kind of really focus in on those kind of persistent headaches that last, past the injury, maybe 3 months or longer, and just simply do not want to go away. I'm a neurologist here in town. I have various different types of fellowship trainings. I wear several different hats. I'm originally from Slovenia, and I was just recently appointed as the new Consul General from the Republic of Slovenia to the United States. So I do a lot of diplomacy type of work. My most favorite role is being the mom to these 5 toddlers, or 2 babies and 3 toddlers. On the right here, which is challenging in of its own, but I'm also a full-time neurologist. And on the right here, you just see a picture of our practice. 2 of my fellow providers are in the audience with you today, and I have an amazing team that I work with, which makes it easier when it comes to these complicated cases. When I first started putting this presentation together a couple of months ago, I was so excited, and it was about 3 times as long as it is today, and it's still too long. So I'm going to breeze through some of these slides. And I mostly base this on an incredible review article from my colleagues in Rome at the Sapienza University of Rome. Some of the research that they conduct in Europe is a little bit different, or has somewhat different results than what we have seen here in this country. And I think it's prudent to know and learn about what they're doing and finding over there as well. I don't think we get to hear that very often. And I'm a true sort of bicontinental neurologist. I have medical licenses in several countries in the European Union. So when I go there, I, as a sort of guest neurologist, do practice and get to do second opinions at different places, both in Slovenia and Italy. And also here, my experience is based on a fairly large post-concussion type of headache clinic that we have at the Vita Medica Institute. I'm going to start out with some basics. So I'm sure everybody in the audience is very aware of what I'm going to talk about for a couple of minutes. So this is a common complication, headache rather. It's a very common complication of traumatic brain injury. It's classified as a secondary headache that's attributed to trauma or injury. And the acute part, it has to develop within 7 days. And then the acuteness of this is defined if it lasts and if it resolves before 3 months are over, that's the acute post-traumatic headache. And if it persists after these 3 months, then we call it persistent post-traumatic headache. So that's really the one that I'm going to be talking about and focusing in today. Those are mostly the referrals that we get to our clinic, just because these patients don't seem to be getting better. And there's just, there's roadblocks in treatments that are being hit by other clinicians, and they want to get an extra opinion on those in the course of, various approaches of treatment that we've already heard about. So when it's been debated, or it's being debated, if this persistent post-concussion headache is its own entity, or is it truly secondary? Most often what we see in front of us is a phenotype of different primary headaches that are thrown together. You may see a migrainous phenotype, a tension type of headache phenotype, maybe with some cluster thrown in it. So it can be a very complicated type of picture. And when it comes to therapy, we try to mirror that, and basically based on the corresponding primary headache phenotype that we see. And we do try to go after abortive and prophylactic agents. And we have very effective type of treatments that are non-pharmacologic based as well. So I will say this at the outset. We think, based on the reviewed data that I will present to you, we think that the persistent post-traumatic headache is in fact a separate phenomenon from a true primary migrainous syndrome. But to really say that with absolute certainty, we don't have enough data just of yet, but I will go through several studies as you will see. And we always say we need more data to elucidate the issues. Again, some of the basics that I probably don't need to belabor. I've already talked about some of these definitions, and again, persistent PTH by definition has to be characterized by headaches lasting longer than 3 months. I will point out, that the burden on the society from the disability of these kind of headaches or concussion in general is pretty large. And look at the statistics. Even after mild TBI, persistent PTH, it can develop or is developed in about 14% of all the secondary headache disorders. That is not a small number. And it's estimated that 14 to 58 of patients with TBI will actually develop a headache at year 1 after trauma. I'll go on to table 1 as it's mentioned here on the next slide. But interesting to me was also some of the statistics that the Europeans have in terms of the prevalence, overall prevalence of this persistent PTH. For example, and it's easier for them to do this because they have government medical systems in these huge tertiary centers where they kind of keep records of everybody. So Denmark reports 4.7% of men and 2.4% in women. For example, in Norway, only 0.21%. For Slovenia, a colleague of mine, and ours is a country of less than 2 million people, but a colleague of mine, a neurologist, told me not too long ago, the prevalence of persistent PTH is about 3%, a little over 3 in men, a little under 3 in women, just because TBI is a little less common in women. But it's definitely interesting to see those differences in different countries that are reported. So here I have this table, fairly interesting. I won't focus on the primary headache types, but you can kind of contrast and compare yourselves. But I'll go over some of these statistics here on the persistent PTH. I already talked about the prevalence, fairly large after TBI. Risk factors, very, very important when you're evaluating these patients. Prior history of headache, very important. Even more important, in my opinion, family history of headache, which is a lot of times forgotten to be asked about. Female gender and older age are also risk factors. Again, depending what phenotypes you have in front of you, the duration of episodes is variable. Also, the symptoms depends what phenotype is predominant. The presenter before me, talked about how important associated and the treatment of the associated symptoms are. Sleep disorders, mood, behavioral, and cognitive deficits. I will tell you in my experience, if you don't evaluate, identify the problems with sleep and treat that, you will not improve the headaches by more than 20 or 30%, especially if these have predominantly migrainous type phenotype. When it comes to doing diagnostics on these persistent PTH patients, MRI in general shows us less cortical thickness in bilateral frontal region, so in the front of the head, and the right hemisphere parietal region, so in the back of the brain and the parietal cortex on the right seems to be more affected in terms of less cortical thickness. We don't know why that is. And then we also see numerous gray matter changes in the prefrontal cortex. On EEG, and I will definitely talk more about EEG later on, early abnormalities are noted. So when you do an EEG on somebody with TBI, with or without a concussion, with or without loss of consciousness, almost 100% of the time, you will see focal slowing or some focal slowing, maybe absence of activity in those that are, have severe injuries. Definitely amplitude asymmetries. Now, most of these tend to normalize after a couple of weeks, but some of them do persist. So I feel very strongly that EEGs are very important in evaluation of these type of headaches. And then we'll spend some time talking about different types of treatment later on. I think I've talked about most of this stuff. Let me just point out that migraine patients who develop PTH have a twofold increase in the frequency and or intensity of the headache. So pre-existing migraineurs, if they have persistent PTH, it's twice as worse than their migraines were, basically. Whereas PTH patients with pre-existing tension type of headaches also experience slight worse in a worsening or increase in attack frequency. So they have worse or more type of headaches. In contrast, if you look at the severity of headache, recovery time, race, marital status, level of education, alcohol use at the time of injury, etiology of TBI, and the Glasgow Coma Scale scores, these are not considered to be risk factors for the development of the persistent PTH. Which, you know, some of these I actually used to think that were associated, like at least the Glasgow Coma Scale, but the studies do not find that. Many studies have shown phenotypic similarities between migraineurs and persistent PTH patients. Everybody's familiar with these basic presentations, but we don't know the relationship, and the data are very conflicting. We'll review more neuroimaging studies, but there are really good neuroimaging studies, and I know I have some neuroimaging colleagues in the audience here. I'll shout out a hi to Dr. Travis. You know, Dr. Chong actually did a very good study and found significant differences in fiber tract profiles between patients with primary migraines and persistent PTH. And those differences were in the bilateral anterior thalamic radiations, the cingulum, the longitudinal fasciculi, and uncinate fasciculi. So some good data to actually point away and say that persistent PTH has a different pathophysiology than migraine. If we look at the sort of functional type of differences, we know that regional or if we stay with the volumetric study, the regional brain volumes and cortical thickness, as I mentioned, vary. So I'll continue to kind of review these studies where we see similarities and differences in what neuroimaging has to show us. Very busy slide. I wouldn't worry too much about reading through this right now. In terms of clinical presentation, you know, it can be anything as any other primary headache, and we have all kinds of associated symptoms that come along. In my experience, sleep issues, cognitive mood problems, anxiety and depression, as it was pointed out by the previous colleague. So those all have to be addressed if you want to be successful in the treatment of the headache itself. Also, we found that a lot of our persistent PTH patients come to us with some sort of an autonomic dysfunction. Sometimes that's POTS, sometimes that's bladder incontinence. So we try to address and seek help for those kind of conditions as well. When it comes to less common type of presentations, the trigeminal autonomic cephalogies are less common, such as hemicrania continua-like, chronic paroxysmal hemicrania-like, cluster-like headaches. Though clusters, in my experience, are way more common. You just need to know how to recognize them. Or this funny looking type of headache, short-lasting unilateral neuralgiform headache attached with conjunctival induction and tearing, shortly Sun City. But if you were strictly looking at the definitions that are set forth by the International Headache Society, you will find that a lot of these cases that you have in front of you will fulfill criteria for many secondary and primary type of headaches. So you have to be, again, very careful when you are classifying folks, and then obviously base your treatment on that. And here I'll also point out that when you look at the studies, you have to be very careful. Most of these studies are in fact review type of studies, so retrospective studies, so inherently they have a lot of bias. In my opinion, most of the research that I've read does not bother to actually record or ask if patients have any sort of headaches prior to the injury. So I think that muddies the waters big time. You know, so it's very difficult then to get an accurate number for the prevalences. That's why we have such a wide range, in my opinion. I don't know if there is not enough research money out there, or just not enough motivation from those of us who treat folks and do research to do prospective studies. But that's what's really needed, prospective studies of these patients, so that we could really tease things apart. A lot of times people try to self-treat. So another complicated factor that I found is that a lot of folks end up with what's called a medication overuse headache. And that's not reported sometimes, and sometimes just sort of touched upon and not fully explained what people may have done. So various variables are important, and they make it really difficult to figure out, are these separate entities or not? I briefly touched about neuroimaging before. And again, just based on neuroimaging, we have really no clear understanding of the pathophysiology of this headache, whether it is a separate entity or not. We have, you know, various imaging techniques that have been used to try to elucidate this. I mentioned volumetric MRI, which is the structural diffusion tensor. We can do regional cerebral blood flow analyses and measurements. These are used to assess brain changes, even in the absence of the significant structural damages, which is a lot of times the case in mild TBI. And then see if there are changes there, obviously. In moderate to severe injuries, obviously, we do find brain structural and functional changes. The problem has been that most of these structures identified point into different directions. So there's somewhat of a consensus, as I said before, that the bilateral frontal cortex has reduced cortical thickness, and the parietal on the right side. But otherwise, these studies really are all over the place, and there's been no conclusion yet what all structures may be affected in each case of a persistent post-traumatic headache type of a person. And there's also been different structures and connectivity issues found when you compare the primary migraineurs to the persistent PTH headaches that have predominantly migrainous features. I included all this information mainly for folks who can hopefully get a copy of these slides, and if they ever have to go back and kind of dig into this, they will have good references. So different authors find different things. When I looked at the literature here in the United States, the same sort of condition applies, though this is mainly a compilation of the studies from Europe. When you look, you know, at the people who have no pre-existing headaches, decreased function in anterior cingulate in dorsolateral prefrontal cortex seems to be prevalent in more than 50% of the studies reviewed. But then those differences resolve. That's what sort of the consensus was in a few of these studies. So nothing that would really help us diagnostically. So when I have a patient in front of me, we normally do an MRI of the brain, which is anatomical, structural. Most of the time, those are normal. And then if I order DMRI, I also order a diffusion tensor analysis with it. That is helpful in two ways clinically. It tells me, or it can help tell me the severity of the injury itself, and therefore I can prognosticate with the patient and the family about the recovery. Also the recovery of the headache. And sometimes it can actually help me in choosing of what kind of treatments for that headache I will use when I propose the treatments. But again, I mean, this is really just to point out that it seems like that these two types of headaches, migraineurs, primary migraineurs and persistent PTH with migrainous features, are two distinct nosological entities if you were just to look at the imaging or neuroimaging research that we have seen so far. So we need more high quality studies to investigate the structures and the changes that are specific to PTH, or persistent PTH rather. Here's one of my favorite subjects, neurophysiological studies. So EEG, I'm a neurologist, so I'm a little biased in this direction, so forgive me. But EEGs are not too frequently done in the hospitals. When we have traumatic brain injured patients, they're done in those, obviously, that are in a coma, or they have some sort of a changed level of consciousness, or they seem to get worse as time goes by. But typically we don't do that in mildly injured patients. I still think that the value of doing EEGs is there. And I get to see a lot of mild, what was thought to be a mild traumatic brain injured patients who either have, cognitive issues, mood disorders, and headache with it. That's the biggest type of referral of patients, and for some reason they just don't seem to get better. And I will tell you, in 80% of those folks, we find abnormalities on the EEG, be it in terms of some sort of sharp wave epileptiform type of brain waves. They may not be full-blown seizures, but they still need to be treated. And what's really cool is that a lot of stuff that you can use for prevention of migraines are anti-seizure medications, so that can work together really well. Or we can see, intense focal slowing of the activity, and sometimes generalized slowing, which has huge impact in terms of mood and cognition type of problems. Evoked potentials, just a few words on evoked potentials. I don't know how many people use that may be in the audience. Short latency somatosensory evoked potentials have not been shown to have an important value in testing patients with head injury or post-traumatic headache. The auditory evoked potentials, I believe, are probably more frequently done and are found to be abnormal in 10 to 20% of patients with head injury or post-concussion type of syndrome. More so if they have, prolonged episodes of unconsciousness, but they seem to improve pretty quickly. Higher cortical response amplitudes, increased interhemispheric response asymmetry, and deficit of response amplitude decrement that are usually measured were demonstrated by using different types of sensory stimuli and techniques when it comes to the evoked potentials. And again, I think this is mostly done in a research type of setting, or really specific or centers who specialize in evaluation of these post-concussions. I certainly, as a neurologist practicing, don't have sort of a quick go-to to doing evoked potentials, nor would I really know how to interpret them to help me clinically to treat that patient most of the time. Some other things that are used, electronystagmograms are used, and some of you guys may be doing those. Caloric tests, electronystagmograms may seem to be more sensitive than brainstem auditory evoked potentials. I think they're probably a little easier to do as well, so people tend to do them more often. When you get data from there, and if you know how to interpret, it can be very, very important and helpful in treatment of these patients. But I think what is still true in terms of the evoked potentials, they can be used to detect post-traumatic neurophysiological changes, but they're relatively subtle and may be challenging to distinguish from those seen in other conditions, such as migraineurs or tension type of headaches that we're trying to compare here. Finally, a few words on treatment. So, main point here is the one here in the middle of the page, and I will just read it off. Currently, there is no standardized type of treatment or data available from randomized controlled trials evaluating the therapeutic efficacy of medical interventions that would be specific to persistent PTH. So what do? We mirror the therapy for the conventional treatment approaches, that we use in non-traumatic primary headache disorders. And many of us agree that persistent PTH should be treated according to the class of the headache its characteristics most closely resemble. So if you have a typical migrainous syndrome in front of you, whether there was trauma or not, that's how you're going to treat it, even though in terms of the diagnostics, you will probably do, or hopefully do, a good clinician would, some extra thing to make sure that, you check on sleep, anxiety, other mood problems, PTSD possibly, and those kind of issues, nutrition that is coming more to fruition as to how important it is and so forth. So I'm not going to belabor this, so we're just going to quickly go through, and a lot of this stuff you guys do day in and day out. In my experience, most of the persistent PTH actually resembles tension type of headaches. And therefore, we use an awful lot of over-the-counter NSAIDs and other type of drugs like Tylenol, sometimes combined with caffeine, very rarely opioids. Most people will have tried that by the time they come to my office, though. A lot of times I also find that they've quite overdone it in terms of the medications over the counter, so we have to address that and be very mindful. I will talk about this a little bit later on when I go through other modalities, but in this tension type of headaches, I get to do a lot of nerve blocks, a lot of Botox into migrainous. This is more for migrainous, but a lot of other types of non-pharmacological approaches, as you'll see in a couple of slides. And then, the majority of the folks will resemble partially a chronic type of migraine. So we do get to treat that a lot. I should point out that even in tension type of headache, we do focus on acute treatment as well as prophylaxis, and tricyclics are actually very effective, but you have to be mindful of the dosing in terms of prevention of the tension type of phenotype in persistent PTH. In migraines, we like to use all of the so-called older drugs that have been around for a couple of decades, and you guys are probably very familiar with. I like to use a lot of the NSAIDs because they don't cause rebound headaches, and that's one thing that's often a problem in migraineurs of all kinds, not just in the persistent PTH. So a lot of times, or most of the time, these medication strategies are pretty effective. However, recently there's been a revolution of another type of drugs on the market. So I'm referring to the calcitonin gene-related peptide substances or blockers. We know that CGRP is a potent endogenous vasodilator and neurotransmitter, and it is involved in pathophysiology of migraine. So in the last few years, it's been the target for all kinds of various drug development when it comes to migraines. And we have several anti-CGRP monoclonal antibodies on the market. I'll use the brand names because those are probably more familiar to you, such as Aimovig and Ajovy and Emgality. We have an infusion called Vyepti. We have some orals such as Nurtec and Qulipta and Brelvy. And there's some new ones that are coming out, I think, before the end of the year. So, do we not use beta blockers and calcium channel blockers and tricyclics and antidepressants? We do, but we have to be mindful of comorbidities with these patients, which a lot of patients have a lot. I don't know, recently my practice, because this has been so exciting, to have all these drugs at our fingertips, it's been very exciting to try a lot of these newer agents and seeing how incredibly effective they actually are. That is not to say that we don't use some of the older agents that you see mentioned on this slide for sure. I'm a big proponent of using some of the naturopathic agents. I use magnesium, vitamin B2, coenzyme Q10 like crazy in my headache population patients in general, like crazy. Also, some of the herbs like butterbur, feverfew, we have a lot of extracts available in our office. And some of the people swear by those, but it doesn't work for everybody, just like in the primary headaches. But I think they're very well worth trying out. I had mentioned, a class of drugs that we use for prophylaxis that come from anti-seizure type of family of medicine. So we use a lot of topiramate, or more so Trokendi preparations, the extended release, gabapentin, valproic acid, especially in those patients who have some sort of a brainwave abnormality. In some of these rarer disorders, like the trigeminal autonomic cephalgus, needless to say, there's much less available to review in the literature. There are some case reports out there, but a lot of them talk about using indomethacin. And I know I have 1 or 2 patients that had persistent PTH with cluster type of features that we put on Emgality, and the treatment was very successful with that. But using gabapentin, carbamazepine has been reported as successful in the literature as well. I think I've touched upon this medication overuse headache, which is, reported in a pretty large percent of the patients that come to us, is my experience. So we always screen for that, but also in the literature. So you have to be very, very mindful of that, because they may not be responding to what you put them on the same way if they have rebound headaches or medication overuse headaches. So you have to pay attention closely. A little bit about other treatment approaches. So for the migrainous type of the persistent PTH, we use an awful lot of Botox injections, or I use Dysport as well, which is another muscle paralyzer. They both work pretty equally well. for the longest time, Botox was one of the main and the most effective preventatives in primary migraine headaches to begin with. I mentioned nerve blocks earlier. Again, I do a lot of peripheral nerve blocks in the office, be it in greater occipital, lesser occipital nerves, auriculotemporal nerves, supraorbital nerves, supratrochlear nerves, and even sphenopalatine ganglion blocks. So just to let you know, that these things may sound like exotic. They're, in my experience, not a whole lot of folks in town that do these kind of interventions. I do these in our office regularly. And when you identify the right kind of a patient for these, all these treatments can be very, very effective when combined with prophylaxis and other treatments. We get to do a lot of trigger point injections. I'm sure a lot of providers do the same. I always, and people who come to me have probably been through 1 or 2 rounds of physical therapy. When you look at the literature and any study that looks at either massage therapy, chiropractor therapy, physical therapy type of treatments, the end result of these studies is always that these persistent PTH headaches are better. However, when they stop the therapies, they tend to get worse. So I don't know how much placebo has to do with this. I'm sure some, but that's not to say that these type of approaches are not effective. So just some other type of approaches that people use. One of them is transcranial magnetic stimulation. Probably most people in the audience are actually familiar with this. I don't know that it's in such common use here in town. Europeans use a ton of this because it's very, very easy to do. And it's been approved, I think, for use much earlier than here in the United States. It's non-invasive, it's neurostimulation procedure in which cerebral electrical activity is influenced by pulsed magnetic fields. Okay, and so you have treatment or several treatments over a course of time. I'm not sure exactly how they do them. And when you look at the studies of these RTMS treatments to the frontal area of the brain, they see changes and people report improvement or resolution of the headaches. So there's more and more really quality type of research data that RTMS actually works for improvement or resolution of the persistent PTH. So hopefully we will be able to use this modality in this country much more frequently as well. I did want to mention surgical decompression. And I'll tell you about one case of mine that I had that was pretty successful. So there are several studies out there that describe different approaches to surgical decompression. Usually it's suboccipital to treat persistent PTH. And all of them show, either resolution or some improvement of the headache. What I really want to point out to you guys is that in every one of these studies, and as you can imagine, I mean, there's not a whole lot of people included in each one of these studies because this is not very common. But in each one of these studies, the authors suggest that patients with concussion or trauma may experience a traction stretch injury to their peripheral nerves. And that can then act as a potential pain generator. So I had a case several years ago of a daughter of a pretty famous, or I should say infamous, trauma surgeon here in town that I treated. She was a diver throughout a swimmer and a diver throughout her teenage years. And in teenage years, she did develop this disabling type of migraine headaches. So in the family, they swore up and down that there was no migraine words or nothing. And we had tried just about everything to help this kid, and she did not get better. And then this trauma surgeon actually moved to become the chairman of surgery in New York. I forget which hospital, and there they actually found a surgeon who was pretty experienced doing these decompressions for persistent PTH headaches, and she underwent one of these suboccipital decompressions, and she literally has been cured of those kind of headaches ever since, and that was about 4 years ago now. If I hadn't witnessed that personally, I don't know that I would have believed that, but that's one case, you know, my only real experience with this. But for some cases, apparently this does work. So people kind of have to keep it in the back of their minds. However, trying to find a surgeon that's experienced in doing these procedures, I think is yet another issue. I do a lot of sphenopalatine ganglion blocks in the office. That again can be another pretty successful therapy in certain patients. So, you know, as people have mentioned before me, you have to look at the patient as a whole, and because you've got so many other factors that affect the headache, you know, you want to treat and be mindful of those things. So stress, people have photophobia, phonophobia, and so forth. So you want to kind of steer them towards behavioral treatment that addresses that. And if they don't want to go, at least you want to counsel them on what I call headache hygiene. We talk a lot about sleep hygiene, again, off screens, you know, going to bed at a certain time, getting up every morning at the same time, that kind of stuff. Same thing pertains to the headaches, and a lot of it, you know, comes directly from the sleep hygiene. So you want to teach them about that, and you want to have them keep diaries, and you want them to bring that back to you and have them get into a routine of doing this. Most people cannot afford behavioral treatments because they're not very well paid for by the insurance, at least in this town. So, but they can do a lot of this on their own. And there's good research evidence that this stuff works. Okay, so these are some of the research studies that I condensed and reviewed that very well showed that. Sleep, the main thing, sleep is a huge issue. Everybody's talking about sleep problems and how everybody needs to be addressing sleep. TBI patients in general have reduced REM sleep, so a lot of the treatment strategies need to be targeting, you know, increase of that REM sleep. Sometimes people have other problems as well that need to be treated, but that's one issue that's consistent and found in every study that you look at, that the REM sleep is a problem in these patients. So again, as I said before, in my experience, I'm not going to be successful in headache treatment unless I address their sleep. And that's true across the board. And then obviously you counsel them about self-medicating and some other issues, you know, how to challenge themselves, how not to challenge themselves. Had a recent case just in front of me 2 days ago that I share with Dr. Mo. I forget if I referred her to him or he referred her to me originally, but we've been seeing her together for about 3 years now. And she's finally at the point where most of her post-concussion, including the headaches, have resolved, but she has one lingering symptom. But because she's been sort of so conditioned to be so careful about everything, she doesn't want to challenge herself. So we had this talk about, she had this revelation that she really needs to go out there and get a job and do things and be exposed to normal stimuli and not just be in her house and shelter herself. So that's really important to point out to these patients as well. Otherwise they will not get better, as I think Randy pointed out previously. So when evaluating, you know, it's important that you pay attention to all these aspects. So I will leave you with these conclusions, and they are in the making as we speak, because there is, thank God, a lot of research being done in various places on these issues. Again, I don't think that we're aware how much burden on the society the persistent PTH actually is. We don't understand the pathophysiology too well yet, and we do have sort of a lack of specific treatments, as it's evident from the literature that we reviewed. A lot of these folks present with a migrainous phenotype, so we were speculating about this migrainous loop. However, the relationship between the persistent PTH and migraine is very controversial and very highly debated. I've been in screaming matches with fellow neurologists in Europe who are completely convinced that these are the same thing as primary migraine headaches, for example. They do share phenotypic similarities, as you know. And we know that the history of migraines is a risk factor for developing persistent PTH. Thank God that whatever we have available in terms of migraine treatment does work for both entities, though. A lot of the neuroimaging studies is now pointing, to the fact that these are two separate and different nosological entities, because we have identified different functional and structural changes that are responsible for these phenotypic presentations. However, I think we need way more research and probably better imaging modalities to address this in the future. So I think I will leave you with that. There's a lot of unknown, but thank God, we can treat and really help these people if we pay attention to the phenotype of their headaches, and usually there's many combined into one. It's not just a migraine, it's not just a cluster, and then pay special attention in addressing their associated sleep issues, mood problems, cognitive fog, or whatever it may be, issues with feeding or nutrition, and therefore. And I think empowering these patients is also very important. So I will leave you with that.
Thank you so
have
much.
a long list of references here, so I hope people are able to get
Yes.
get a copy of these slides if they choose so, because there is a lot more in the literature than what the time afforded me to review with you guys this morning. I thank you again for the invitation. It was a privilege. If there's any questions, we can address them now or later. I think we're out of time though.
Thank you, Dr. De Leon. So we will have all the slides up, a plethora of information there. Really appreciate the talk there. We will have the slides up for everybody, including myself. I'm going to look forward to diving into that. We will address questions at the end. So Dr. De Leon, if you're able to get back on for the panel at 3:15, we certainly have a few questions for you, so you can coordinate that with Jessica. We're going to go ahead and get into our break now. We're a few minutes behind, so I'd like to get going with Dr. Combs' talk at 10:40 on the dot, just so that we don't stay behind. So go ahead and restrooms and grab some food, whatever you need, and we'll see you in a few minutes. Thank you. No, you gotta slow. Yeah, no. Sorry, it doesn't look like it. It's small.
I was gonna say your slides, I think are about the same. When I look at them every year, I'm like, so yeah, so you got the clicker and the microphone's in here.
Okay. That works. If I stand here, I'm fine. Okay, perfect. No, I forgot there's no.
Maybe. But now there's too many questions. So we did that. Yeah, and you guys will be. Yeah. Or, so that sensitivity, some of those things out. Not necessarily. Really, even if it's down to It's got a wide breadth. So at the end of the day, yeah. Well, cool, thank you. Yeah. Yeah, exactly. That was outside the box.
Actually, so I'm with, I graduated about a month ago. Yes, definitely, and I'm with football right now. But Dan's not
All right, everybody, we're going to go ahead for the sake of staying on schedule here and get started with Dr. Combs' talk. I know doing a lot of catching up and things like that. It's always fun. This is Dan Combs. He's from the U of A, sleep medicine, specifically does pediatrics. So I've worked with him a lot. Some of my pediatric patients with complex concussions where the sleep is just a total mess and we need their help and we need sleep studies. He's going to sort of dive into sleep dysfunction as it's related post-pediatric. So thank you for being here.
Thank you for the invite. Can everyone hear me?
Yes.
Okay. Here we go. Please cut me off if you have questions at any time. Please just raise your hand, ask, shout at me if I don't see you. My goal is to make this as useful as I can. So that being said, maybe. So overall objectives for the session, we're going to talk, it's kind of split into half kind of research, half like what can you do with this. So kind of first half, how has sleep changed after traumatic brain injury? What are the consequences of that? And then second half, focus really what are treatable disorders that you can do something about now. So not in 10 years, but like what can you deal with now? And then also when should you send people to sleep medicine or get a sleep study? So sleep alterations post-TBI, kind of broad overview, main things you find, increased total sleep time. So people sleep more. I don't think this is a shock to anyone. This is probably a good thing. Neuroplasticity, a lot of like your brain kind of, essentially brain maintenance, brain cleaning is happening during sleep. So we know your brain lymphatic system, the lymphatic system basically works during sleep to clean things up. Increased sleep fragmentation is probably more of an issue of just kind of consequence of the event. So sleep fragmentation, increased inflammation leads to sleep fragmentation. A lot of the inflammatory cytokines actually disrupt sleep. And so you're going to have kind of inflammatory state affecting that, and then also just general brain injury, as all of your sleep mechanisms are kind of distributed throughout your whole brain, which means that brain injury affects kind of all of them. Looking at the research, so this is from a study, 2013. On the left is total daytime sleep time. On the right is nighttime sleep time. This was a study of about 50 people who were hospitalized for traumatic brain injury. What they found, so kind of the darker bar is more severe. So on this side, it's Glasgow Coma score less than 11. And then in the other graph, it's with initial loss of consciousness. What you can see when these people initially present to the hospital, sleep is crazy increase in both of them. So this is this is in minutes. So this is about 1,000 minutes a day of total sleep time. So that's kind of 10, about 15 hours a day of total sleep time. Similarly, this is only daytime sleep time. And you can see here they're sleeping 8-9 hours in the day. So it's not even including their nighttime sleep. What you can see is in kind of the less severe injured group, this actually basically goes to almost normal within a week. And same for daytime sleep time. So you see a really profound increase in sleep immediately following TBI.
Yeah, sorry to interrupt. Can you turn up your volume a little bit?
Yeah,
More for
I can
that.
go.
If you can do
Okay.
that, that'd be fantastic.
Okay, I will talk loudly.
Appreciate
I can do it. I'll pretend you guys are my toddlers. So sleep fragmentation. So sleep efficiency, normal sleep efficiency is over 85%, usually 90-95% is pretty typical. What you see is that sleep efficiency really just goes kaput. So the sleep efficiency is the percent of your time in bed you're actually sleeping. So say you're sleeping that ideal 8 hours, you're probably really sleeping 7.5 hours of that, which is pretty much normal. What you can see, these people are spending about 2/3 of the time actually sleeping. So even though they're in bed for 8 or 9 hours, they're only sleeping 5 or 6. So they're not going to get enough sleep unless they sleep more total duration, which they will. This tends to stick around a little bit longer than that total sleep duration. Sleep latency is actually more or less normal. Normal is 10 minutes to 30 minutes. They're pretty much right at 10. Wake after sleep onset kind of correlates to sleep efficiency. And so this is after you fell asleep, how much of the night did you spend waking up? And so you can see in this study, actually about 3 hours of the night. So if they're going to bed at 10, getting up at 6, they're spending 3 hours of that awake. And then again, kind of importantly, the sleep fragmentation for that first week stays bad. That sleep duration gradually went to normal-ish. For most people, this really stays abnormal. This study only lasted a week, so I didn't follow past that, but it generally sticks around. This is actigraphy, which you guys are probably more familiar with. So sleep people use it to look at the absence of motion. Usually sports people are looking at more to look at your total motion for the day. It's the same concept. As a sleep person, what I look at is these bars are activity. So this is like a Fitbit essentially. And so the bigger the bar, the more activity there is. So like this could be like running or something like that. Not really, but because it's a TBI patient. And then the empty spots are sleep. And so if you're not moving, there's an algorithm, but essentially if you're not moving, it thinks you're asleep. And there's some nuance to that. What you can see, so this first patient really never has their sleep consolidate. This other patient does. What you can see is if you look eventually, there's kind of little ditzels here, like half-hour sleep here, 2 hours of sleep there, kind of over the course of the day. So this is daytime, this is nighttime in theory, they're supposed to be sleeping here. And then what you can see is this really doesn't improve. So ideally all of this should be like this. And so you can see over here, so kind of at the start, kind of fragmented sleep, kind of awake all over. By the end, this is more or less normal, where you go to bed at 10, maybe you wake up a couple times here and there. But that's what your sleep hopefully looks like. Whereas you can see for this person, their sleep is just kind of all over the place still. It consolidates a little bit, but it's not in the nighttime. Like you can see here this last day, they're sleeping kind of like 6 p.m. to 10 p.m. And then they're up all night because they can't sleep. So sleep tends to stay fragmented and it doesn't necessarily consolidate where it's supposed to. And this kind of goes along with, so in addition to that increased sleep duration that eventually gets better for most people, you also get circadian disruption. So kind of the two things that drive your sleep generally are how much sleep you need. So how long has it been since you've slept? And so if you stay up a long time, you'll sleep more because you're tired. And then there's your circadian rhythm. And so this is kind of your internal clock. And so what this is telling you is, in the daytime, I should be awake. At nighttime, I should be asleep. This is looking at core body temperature. And then for the brain injury patients, also the brain max temp, it's really the same results. I'm going to gloss over it. So what you normally see, if your circadian rhythm is in phase, kind of early morning, kind of like 4 a.m.-ish is your minimum body temperature. And then kind of like 4-ish p.m. Is your max body temperature. And so what you can see, this is a group of 34 healthy controls. And so what you can see, core body temperature is more or less the same time for everyone. Like everyone's kind of within that 2-hour range. These are TBI patients. And what you can see is that this kind of everywhere. So ideally all of these should be like this, where everyone's kind of team in and team out at the same times. They're kind of all over. So this is kind of a surrogate way of telling you that your internal circadian clock is just completely not working. And so interestingly, this actually is a common ICU finding and actually prognosticates survival in that people whose circadian rhythms don't come back usually have much worse outcomes or die versus if your circadian rhythm comes back, you tend to do better long-term. So chronic sleep changes, usually people gradually get better, depending on severity, obviously, but in general, people kind of start out bad. And if you follow them out a year or two later, are normal. That hypersomnia, 95-ish% of people get better, that completely goes away. About 1 in 20 still have objective hypersomnia, so if you measure their total sleep duration, it's longer. And actually present kind of like narcolepsy, where that really doesn't go away even 5 years out. You see kind of a slight increased sleep needs are kind of across the board. We all probably sleep 7.5 hours. You can see in TBI patients, they're sleeping kind of 8.2 hours. So they're getting half an hour more sleep than most people. Insomnia, so hypersomnia isn't super common. It will sometimes be persistent. Usually stimulants are actually how we tend to treat that, assuming there's no other contraindications. If it doesn't resolve, again, early on in the course, it's probably protective. You probably want them to be sleeping that extra duration. 2 or 3 years out, that's not the case anymore. Insomnia was kind of mentioned a bit briefly before. Very, very common, and actually a quarter of TBI patients have insomnia even 5 years out. And then kind of going back to long-term circadian disruption, usually, so this is your normal circadian rhythm, kind of turns on about 8 p.m., kind of gradually increases, hits a peak kind of 2 a.m., and then gradually decreases. What kind of matters the most is kind of how big that peak is. And so the blue is control, so these are healthy people, and then the circles are patients with TBI. What you can see is the TBI patients just don't have as much of that peak. That peak is really what kind of sets your clock, sets your timing. If you have kind of this smaller plateau, the way that you do here, it's going to be kind of essentially less strong circadian rhythm. You're not going to be in sync with the day as much as you would be otherwise. And so what you can see is that this was participants 8 months to almost 7 years out, and really kind of have this persistent decreased total melatonin secretion that really kind of suggests that the circadian rhythm is not as strong as it otherwise could be. This is going to affect sleep a lot, which if you go back to that whole things that make you sleep is your circadian rhythm, and then also how tired are you? You're kind of taking away half of that. So you're going to have a problem with staying awake in the day, and then also a problem staying asleep at night. And then this actually just came out this year, sleep and cognition. So we kind of in general think that poor sleep predicts poor cognition. We know that with sleep disorders kind of across the board. This was actually looking at sleep in people with a TBI. So this is a subgroup that had sleep studies essentially immediately after TBI. And then about 4 years later, on average, they did a cognitive assessment. What they found is essentially the worse your sleep efficiency, so the worse you are at staying asleep, the worse you did on this cognitive testing. And then similarly, they found N3 sleep percentage, so your slow wave sleep where you usually have growth hormone release, things like that. The less of that you got in general, the worse you did on these memory tests. The N3 sleep, you can't necessarily do too much about other than treat anything else you can. This sleep efficiency is something that you can target clinically. And then so kind of general overview, consequences of sleep disorders after TBI. So we know sleep-wake disorders across the board, decreased quality of life, in kids, increased behavior concerns, more family disruption, more cognitive concerns. And then we know that having that sleep disruption acutely actually predicts even a year out worse mood symptoms. Kind of other things, so there's a lot of kind of bidirectional relationship with sleep. And so inflammation disrupts sleep, but poor sleep or sleep disorders actually generally increase inflammation. And so this potentially could even increase severity of subsequent TBIs. And so among like the more physiologic reasons why multiple TBIs are bad, sleep could actually contribute independently. And then kind of, again, sleep is pretty much always bidirectional. So poor mood goes to poor sleep goes to poor mood. I would imagine everyone in the rooms has had insomnia for at least a night. You're in general cranky and you don't feel good. And so that goes vice versa too. People with depression tend to have insomnia, anxiety similarly. Pain is what's mentioned, and this is a relatively hot area of research. Pain disrupts sleep disruption and sleep fragmentation in turn increase pain sensitivity. So sleep is not kind of in its own vacuum. It really is, you treat sleep to treat the other things. Treating the other things will also improve sleep. So it really needs to be kind of a holistic approach. And then kind of moving now, like what can you do? So things that you can do clinically now is so sleep disorders after TBI. So I'm kind of splitting these into things that are common. So obstructive sleep apnea is fairly common. Restless leg syndrome is fairly common. Both of them really don't have anything directly to do with TBI, but they're relatively common and they're going to worsen all of your other downstream TBI effects. Insomnia can be either comorbid or directly related to the TBI, so it kind of fits in both categories. Delayed sleep phase syndrome we'll touch on. This is a circadian rhythm disorder that's usually seen in adolescents. Irregular sleep-wake rhythm is a circadian rhythm disorder that you actually see when that melatonin plateau is weaker, the way you see it in TBI. And then hypersomnia disorders we'll touch on too. Uh-oh. Okay. Next. Oh, is it you? There we go. Okay. So obstructive sleep apnea, about 1 in 50 kids, 15% of adults, so really pretty common in adults across the board. Symptoms in kids, snoring, when apnea, choking, gasping, just seeming like you're struggling to breathe. Daytime sleepiness, you can also see kind of ADHD symptoms, irritability in younger kids are fairly common. In adults, there's a screening tool called Stop Bank. So anyone who sees adult patients, this is a really convenient, kind of easy mnemonic. So snoring, so do you snore? Are you tired in the day? Has anyone said you stop breathing at night? Do you have high blood pressure? Is your BMI over 35? Age over 50, neck circumference more than 17 inches. To get that in men, just ask their collar size for dress shirts, and they will know it, hopefully. And then it's 16 inches for women. Male gender, if you have yes to 3 of these or more, they should probably get a sleep study at moderate to high risk for sleep apnea. So obstructive sleep apnea in kids, usually in otherwise typical non-obese kids, usually tonsillar hypertrophy. And so if they have sleep apnea, you get the tonsils out, and that actually resolves things. You can see obesity. Some people just have a very narrow airway just because that's the way that they're born. And so for people who don't have big tonsils, so for the adult population or kids with significant obesity or don't have big tonsils, really CPAP is kind of the way to go. And so that's using air pressure to basically keep your airway open from inside. Is really effective, assuming that you leave it on your face all night, which appearance is about half of people. We could talk all day about that, but I'll move on. You can use dental devices to actually move your lower jaw forward. So if you think about essentially doing like jaw thrust, like you do for like someone who's not breathing, that actually opens up your airway, can treat mild to moderate sleep apnea in some cases. Restless leg syndrome, again, 1 in 25, 1 in 50 kids, maybe 5 to 10% of adults, usually 1 in 100 kids might actually need treatment for this. You can have this and be otherwise asymptomatic, and so you don't need to treat just because. Symptoms in adults, this is really straightforward. So if you say yes to these questions, do you feel like you need to move your legs? Is it worse at night? Is it worse with staying still? Is it better with movement? You say yes to all of those, you have restless leg. It tends to run in families, you're getting family history. Toddlers are obviously not going to say yes to those questions, and so that tends to be a bit trickier. Usually things like restless sleep, just bad sleep at night, even with really good sleep hygiene, like really good sleep routine, should make you think about it. But it's kind of a tricky diagnosis. Family history is helpful. So if mom says, yeah, I have restless leg, dad says, I have restless leg, and our kid kicks all night, then they probably have restless leg too. What do you do about this? So number one main cause is low iron. So checking serum ferritin, if that's less than 50, which is gonna be way above the lab normal, which is usually like 15, having them take supplemental iron, which is usually just one per day of like the normal ferrous sulfate pills you can buy at Walgreens, buy wherever. Once you're over 15 kilos, that's your dose. And so for the vast majority of patients, that's what you're doing. Otherwise, if you really care for your kids, it's 4 mg per kilo of elemental iron, but they max out after 15 anyways. You can use medications. You can use gabapentin, which works fairly well. About 1 in 25, 1 in 30 kids are kind of irritable with it, so you have to stop it. You can use pramipexole, which is a dopamine agonist that we use in adults, usually it's a first line with gabapentin. It can worsen impulsive behavior, and so it's not the best drug for your kids in general. So we usually stay away from it. The handful of kids that use it and have actually all done fine, but it's something where you really don't want to trigger someone who's already kind of impulsive to begin with. Kind of side note, things that aren't restless leg, sleep starts, like those hypnagogic jerks people do every now and then, we're kind of like falling asleep and you're like, that's not restless leg, that's fine, we all have them, no one cares. Rocking legs, so especially kids with neurodevelopmental disabilities will headbang. Sometimes kids will kind of like rock their legs. It's interesting that it's always 1 per second. Don't ask me why, but like our brains are hardwired. Self-soothing things are 1 per second. Headbanging is totally fine, as long as they're not breaking their head open. Again, that's fine. It makes them happy. It's not going to hurt them. Rarely kids end up in helmets for that, but I've never seen it personally. You can use things like pool noodles to like cover the headboard if you need to. So you usually don't need to do anything about that. Delayed sleep phase syndrome, super common in adolescents. Mammals across the board, so mice, humans across the board are hardwired to stay up late and sleep in. This is not an issue in the summer. And so typically like teenagers will go to bed at like 2, get up at 10, 11 noon, and they're fine, no one cares. When this turns into an issue is when school starts. And instead of going to bed at 2, they go to bed at 9 and get up at 6. And so what happens is that at 9, they're not sleepy because it's like if you go to bed at 10, it's like, okay, go to bed at 5 tonight. You don't sleep. And you shouldn't sleep because you're not tired. Like that's not when you're supposed to sleep. So this is super common, usually around this time of year. Up to almost 1 in 5 kids will actually have symptoms for teenagers. And then what's kind of tricky is usually people will come to clinic with either I can't fall asleep at night or I'm sleepy in the mornings. And if you tease it out, usually they have both of them. And so weekday versus weekend schedule can be really helpful for kind of teasing this out. Because what will happen is on weekends, they'll stay up till 2, sleep till noon, life is better, like they're still tired, but they slept and caught up on sleep. Monday rolls around, mom says go to bed at 9, get up at 5:45, 6. They can't fall asleep at 9 because their circadian rhythm is like, this is like mid-afternoon. And then they can't get them out of bed because again, it's like waking you up at 2 a.m. Like you're not gonna like wake up and be chipper and okay, let's go to school now. And so pretty common, that's typically what you're gonna see. So that weekends versus weekday sleep is really kind of your easiest clue for this. Otherwise you can think, oh, they just have insomnia or maybe they have narcolepsy because they're so sleepy in the daytime. So if you get that clue where weekend sleep is much, much later, think about delayed sleep phase. Again, pretty common. What do you do about this? So what I will personally do is find out when you actually fall asleep. And so if you come to my clinic and you say, I usually lay awake in bed until 1 and then I finally fall asleep. That's probably your realistic like circadian bedtime. So what I will usually do for kind of the first week is say, okay, go to bed then, even if it's like midnight, 1 a.m. Get up when you need to get up for school. That's going to actually sleep restrict you, which is going to make you sleepier and actually make it easier to advance. From then, what you can actually do is you can give melatonin, not when you think you would give melatonin, so not at bedtime. If you give melatonin, it does 2 things. It's a really weak insomnia drug, like it makes you a little bit sleepy, helps you fall asleep right when you take it, like within half an hour. What it's really good at is shifting your circadian rhythm. And so depending on timing, you can shift someone's circadian rhythm earlier, later, or not at all, depending on what time you give it. You want to give it 4 hours before they typically fall asleep. So not when you want them to fall asleep, but when they actually fall asleep. And you want to do a low dose, so actually probably 0.5 to 3 milligrams. The bigger doses tend to be just too high and kind of wash out your circadian rhythm. So you actually want a lower dose. And so once you start that, you actually have them start getting up, or you have them start going to bed about 5-10 minutes earlier each night and kind of gradually walk them back. Daytime when they're getting up kind of varies depending on if they're in school or not. If they're not in school, they can get up late and kind of march that forwards too. If they're in school, usually they're kind of stuck, but they need to get up at 6 or 7 anyways, and so I usually don't mess with that. You can do light therapy. So people always mention light therapy. We live in Arizona. There's a lot of light outside. Don't bother. You can buy like a $200 light lamp, and I'm sure if you live in Seattle, it's really key. You just don't need to do it here. Like it's just a waste of money. And so then this is kind of like, so what you see with delayed sleep phase, kind of graphically. So say this is 10, usually go to bed, you wake up. With delayed sleep phase, you go to bed later and wake up later. So you really don't have a lot of sleep fragmentation. So people with primary insomnia have a hard time falling asleep and staying asleep. Usually delayed sleep phase, once they fall asleep, they tend to stay asleep. So then irregular sleep-wake rhythm disorder. This is really something you're going to see. So your kind of sleep textbook answer is someone with any kind of brain disorder. So like your sleep boards, it's always Alzheimer's, dementia in the nursing home, and they're awake all night and asleep all day. What happens with this is that instead of having a consolidated sleep period, you sleep for maybe 2 or 3 hours here, 2 or 3 hours there, kind of across the day. And so you might get a total of 8 or 9 hours, but it's kind of everywhere. Like it's really not at a particular time. The issue with this is that we can circadian rhythm. And so if you don't have a strong circadian signal, you just kind of drift in and out of sleep. So kind of as you get sleepier, you fall asleep. And so this tends to be really disruptive for caregivers, especially because they're awake at night and then sleeping during the daytime. So what you can do for this is really kind of exaggerate all of your circadian cues. So your main circadian cues are, you can give melatonin at night, which is kind of your intrinsic circadian rhythm, is melatonin there or not. But then also light exposure in the daytime. And so this is how this kind of translates, especially for like teenagers with TBI. They want to spend all day like in their bedroom with the curtains drawn. They might have headaches, they might have lots of things. Really getting them out of their bedroom and as much light as you can get them to tolerate during the daytime is going to help with this. So your goal is essentially to get them lots of wake cues in the daytime, and then at night, lights go away, so off your phone. Taking melatonin around bedtime can help. And that's really how you want to treat this. Then insomnia. So almost everyone's gonna have insomnia at some point in your life. It's pretty much universal. It's only a disorder if it persists for 3 months and it's relatively severe. So usually you don't care, and life is okay. So it's a disorder, it takes you more than half an hour to fall asleep. You're awake more than half an hour, it's happening more than 3 times a week, more than 3 months, and then you have something wrong with you essentially. So daytime impairments, so sleepiness, irritability, GI issues can all be kind of insomnia symptoms. What do you do about this? So behavioral therapy is fantastically successful, works phenomenally well. The issue with it is that there's not very many providers. And so doing behavioral therapy is really the right answer. It's the most effective therapy by far. How these work, so there's something called cognitive behavioral therapy for insomnia, or CBTI. This is kind of gold standard. If you can refer for this, you should. In Tucson, there's 2 kind of full-time CBTI people who are both at Banner. There's a couple community people who do it some. That's ideally what you want to do. None of them take access, so no one takes Medicaid. It's just all private pay. And then I'm going to touch on a couple kind of key elements that you can steal and use in your own practice that don't take a lot of skill. So there's something called stimulus control, which is kind of like really simple sleep hygiene. And it's this straightforward. If you're not sleepy, don't go to bed. You go to bed when you're tired. If you're awake more than like 20-ish minutes or so, you get up, do something quiet, like read a book, draw, stuff like that, until you're sleepy again. Get up at the same time every day. That's going to kind of accent your circadian rhythm, make that stronger. And you don't want to take naps during the day. So when you take naps during the day, you're less tired at night, and so you're going to sleep less. So essentially, how long since you've slept, how much have you slept, and circadian rhythm are your 2 cues. If you nap and don't get up at the same time every day, you're really kind of screwing up both of those. Sleep restriction is highly effective. You want to be a little bit cautious if you're trying to do it without a lot of training. So simplistically, if you don't sleep, you sleep more the next day. And so what a lot of times will happen with people with insomnia is usually say you go to bed at 10, you get up at 6. You can't fall asleep until 2 one night because you're stressed, you had a test, you had something bad happened. And so you can't fall asleep until 2, so you're tired the next day. So what everyone does is they go to bed early the next day. So you say, okay, I'll go to bed at 8, and I'll catch up on some of that sleep. That is the opposite of what you want to do, so that doesn't work. What ends up happening instead is that you just spend more time in bed. And so your sleep efficiency, which is that how much of the night are you sleeping, gets worse, which is kind of the hallmark of insomnia. So kind of paradoxically, what you want to do is stay on your same routine. So just kind of essentially ignore the fact you didn't sleep last night. Stay on that same routine, going to bed maybe 15-20 minutes earlier is fine. Sleeping in 15-20 minutes earlier is fine. But really more or less staying on that same schedule is actually the best answer. With sleep restriction, what you'll actually do is you figure out how much time during the night is someone actually sleeping. And so if they say, I'm in bed from 7 p.m. to 7 a.m., but I only sleep 5 hours. Then you say, okay, I want you in bed for 5 hours. And so usually people want to stay up later, and so they'll go to bed at 2 instead of 7. What that is going to do is just make them tired, and so their sleep efficiency is going to go up. What you then do is once their sleep efficiency is kind of over that 85% marker, you gradually give them back 15-20 minutes of sleep until they're sleeping 7 to 8 hours. Is really effective. Kind of issues with it, it's going to make you sleepy. And so if they're like a fighter pilot, it's probably not a great therapy. The other issue for people who have bipolar, you can actually trigger mania. So screening for bipolar is really important. And then generally counseling, like, this will make you sleepy, like, be mindful, like, this isn't the time to go drive to San Diego, like, be mindful of what you're doing. It's super effective. And medications, the short answer is that there is no safe, effective, long-term use drug for insomnia. If you look at all of the approved insomnia drugs, they're all for short-term use. So your Ambien drugs, your benzodiazepines, all short-term use. With benzos and the Ambien type drugs, we actually know they cause cognitive decline. So long-term use leads to early onset dementia. So probably particularly bad for people with TBI. So we know they're bad for you long-term. Obviously, risk benefits, sometimes it's worth it. There's a newer class of drugs that are suvorexant, lemborexant, that end in exant across the board. Those work differently, so they don't work on that benzo receptor the way the other ones do. They essentially mimic narcolepsy. They probably cause less cognitive impairments, but they've only been in the market for 3 or 4 years, and so we don't really know. It is a different mechanism. Insurance doesn't really like to pay for them because it's relatively new and expensive. That could be reasonable if you absolutely want to go to a drug, but again, you're really kind of flying without any strong evidence either way. And then finally, when you want to send someone to sleep medicine, so main ones, so hypersomnia, so people with persistent hypersomnia, like they're sleeping 10, 11 hours years after the TBI, they essentially get worked up, treated like they have narcolepsy. They should see sleep medicine. Suspected sleep apnea. Sleep clinic wait is about 3-ish months for adults, about 6 or 7 months for kids. Sleep study wait's about 2 or 3 months. What we will do is we actually at Banner will review all of the sleep referrals. And if it looks like you're concerned about sleep apnea, and so you document, they snore, they stop breathing at night, things like that, we'll send them for a sleep study first, so you can actually get diagnosed and treated for sleep apnea faster. Otherwise, they'll come to clinic first, and so if they come to clinic and they say, oh, I snore, I obviously have sleep apnea, then they'll get treated eventually, but it's kind of like a 6-7 month delay. Restless legs syndrome, checking serum ferritin, starting parasulfate is totally reasonable to do in primary care. Insomnia, ideally CBT for insomnia. There is a couple options. There's something called Somrest, which is actually an FDA-approved app. It is FDA-approved for age 22, which I find the absolute most bizarre cutoff for something you do on a smartphone. Why 18 to 21 is not included, I cannot explain. So it is essentially an app that guides you through kind of like self-guided CBT for insomnia. Insurance mostly doesn't cover it, and it's like $800. If you're a primary care doctor who really wants to use it, I think you can probably get patients on it for free because they're trying to kind of build a population that's used it. CBTI Coach is free on the Apple Store, the Android Store. This was actually developed by the VA because so many veterans have insomnia. And so this is kind of, again, a free self-guided CBT insomnia app. Not as good as seeing it with a provider, but is a reasonable option because there's not a lot of stuff out there. So with that being said, questions if there's any. Okay. Mo doesn't look angry. That means I can answer questions. So does anyone have questions?
Is melatonin okay for long-term use?
Yes. So there's no long-term data in kids. There is in adults. I think across the board, we think it's generally safe. Every now and then people publish scare tactic papers talking about how there's no long-term data. So one of those actually just came out like 6 months ago. I think if you're using it at a reasonable dose, so less than 5 milligrams or 5 milligrams or less, I think kind of across the board, people would say it's generally safe. So, other questions? Yes.
Any thoughts on valerian root?
No studies for sleep that I know of. It's worth a try, but there's I can't give you any evidence either way. So, other questions? Okay, then thank you guys very much.
Thank you, Dan. As always, fantastic talk. I always love learning more about sleep, even for myself. So I appreciate it. Next up, we have Dr. Schneider, Travis Schneider. He is traveled down from Southern California to be with us and talk about. He's a neuroradiologist who's with Simon Med. I've seen a lot of his reads over the years, communicated with him, and very happy to finally get a chance to meet him in person and have him here at our symposium. He's going to talk about imaging findings in TBI and complex concussions. And there he is. So Travis, I'll go ahead and give you the mic here. You might have a couple extra minutes to work with. Maybe he's outside. We are a couple of minutes early, so let me just see. Yeah, we're finished a little early, so I figured. Yeah, I tracked him down. So, yeah, we've got a couple extra minutes, and I know that you usually have a lot of slides, so we can go ahead and get started whenever you're ready. Thank you.
Oh, sure.
This is Doug. I introed you while you were back there.
Man, sorry I was late for. Sorry I was just working.
Yeah, so for
Oh,
for the mic, if you just speak loud enough so that.
Oh,
people
then we're
can hear you, there's a microphone for the folks on Zoom. That's right there. So, and then this is your clicker.
okay. If I can talk loudly, yeah, sorry for being late to my own lecture here, but I just stepped out for a second. And, but so I'm gonna be giving a talk on imaging. So it's lots of pictures, so hopefully you all find that kind of interesting. I find it interesting. And so the title of this is complex concussion. And the reason that is because in just regular concussion or mild TBI, we really sometimes don't have much to talk about with imaging. And so that's why and we're gonna give a little background. Some of this stuff is gonna be more advanced injuries, but in see if I have a slide here. Yeah. So, why are we talking about complex concussions? Because MRI is really insensitive for mild traumatic brain injury. And especially like a more mild concussion. The majority of time the most common finding on MRI in a mild concussion or a mild traumatic brain injury, especially on the smaller end and a lot of sports injuries, is actually zero, nothing. So when we're trying to be more sensitive, and some of the stuff I'm going to show here is sort of a more advanced stuff that is trying to push the boundaries of what we can do with imaging to identify some of these findings on imaging and try to offer both diagnosis and prognosis for the patients. And this is a study by 2013, who found that only 27% of patients with mild traumatic brain injury had any findings on MRI. And this study actually, if you look into the study even closer, it's actually even less than that, because a lot of these patients, some of them had skull fractures, some of them had subarachnoid hemorrhage and brain contusions and diffuse axonal injury, which normally it's not really considered mild. I mean, mild is a clinical diagnosis, mild, moderate, or severe. But these patients were definitely on the further end of mild. In fact, we even said that some of the patients in this study were moderate. So what the true number is less than that. So a little introduction with CT. I'm gonna move fast because we don't have much time. I really tailor down this lecture beyond what it normally is. And then, so a little CT and then kind of the optimal MRI protocol. And then hopefully we can kind of get through some of these. And I'd like to spend a lot of time on diffuser tensor imaging. I know some of the docs here have an interest in this. I have an interest in it. Our research group has a big interest in it. And then I also like to, if we have time, I'd like to talk about some of some of our kind of research. Some of it's preliminary findings, but you all might find that interesting. So CT is the basic modality, I guess, of traumatic brain injury, mostly emergency room setting, or I would say almost always in the emergency room setting. And it's done to assess for bleeds, fractures, midline shifts, life-threatening conditions is really what it's used for. And the fact even that a CT was ordered sometimes is significant. I mean, if it's ordered in an ER setting, then the ER physician was trying to exclude some of those findings is generally what they're concerned about. And some of those common bleeds are flashing here. Subdural hematomas, subarachnoid hemorrhage, and intraparenchymal hemorrhage. Subdural is just inside the skull, and subarachnoid is is a little deeper, like right next to the brain, but not in the brain. And then intraparenchymal is actually in the brain. So CT is even less sensitive than MRI for mild traumatic brain injury, and Dr. Osborne, who's written a nice book on kind of the guru of neuroradiology to some extent, they found only 6% were positive on mild traumatic brain injury. But one thing that is quite helpful, I think, is soft tissue swelling, and it's a lot of times overlooked by radiologists because, and you understand why they overlook it. You have a big list, you're going through studies, but it doesn't really impact the patient care necessarily in the acute setting. So sometimes it's not found. But CT is important, and so if you're looking at especially if you have a lot of images on a patient, seeing the whole progression of their injury or their course, you can see subarachnoid and some drills on CT, which will resolve on MRI. So it's always nice to have that CT if available to look at that. And here's an example of a CT, and it's showing the kind of progression. So you see the soft tissue contusion here, and then on 2 weeks later it's smaller, and then it's a year later it's resolved. And so that's what you look for. This is where the patient was hit. I mean, there's no question about that. And just to zoom in, just kind of show it a little better where the patient was hit. And this is a little bit of subdural and subarachnoid hemorrhage. And maybe other people have talked about this, so I don't maybe want to spend too much time, but these are some nice articles, and you all can have this presentation if you need it or want it, but in my opinion, these are some of the best imaging articles on the prognosis of these. And they're not benign prognosis. It's not like you have a subdural and it heals and then the patient's fine. I mean, maybe it could happen, but same with subarachnoid hemorrhage. And so these patients, and this study, this is the TRACK study, which is a really large multi-center study of mild traumatic brain injury. And they've really done some really nice research. And they actually statistically isolated these imaging findings for prognosis using statistical methods using a large sample. And the patients that had those had a worse outcome independent of anything else. So it was a pretty nice study. Subdurals have a risk of seizures. It's kind of unique. It's not, I guess, somewhat unique to subdurals in terms of the increase of it. Superficial siderosis is a phenomenon where subarachnoid hemorrhage, it only happens with subarachnoid hemorrhage. And the hemorrhage that's out inside the skull but outside the brain, it kind of settles down, it will layer on the brain, kind of coat the brain, and it's called superficial siderosis. And so these patients can have all these types of weird symptoms from it. And it can involve cranial nerves, it can involve other things, and you can see them on MRI. And this was a very interesting study by Zhao. Actually said that almost 100% of patients that had prior subarachnoid hemorrhage actually had superficial siderosis. They used an advanced imaging SWI sequence to look at that. And that was really news to me when I saw that, because you don't see superficial siderosis, even if you have a CT that shows they had prior subarachnoid hemorrhage, you don't really see it that high percentage at all, in my opinion. But they did this study that basically showed that. So kind of interesting. Okay, so now this is the main part of this. I think we're here to talk about the MRI. And it's really the best way to fully assess the patient prognosis. It's very, very common where you have a negative CT and you get an MRI and the patient's just devastated. You say, well, how could that happen? Because an MRI is just so much more sensitive. And whether it changes treatment or not would be maybe a different question, but it definitely will. I mean, if patient's having a lot of symptoms, it explains the symptoms. So this is kind of what we're doing at our centers. And so we try to do it on 3 Tesla magnet, which is the best pretty much commercially available. There's some 7 Tesla, but it's not really too far out there. And then SWI is the hemorrhage sequence that we were talking about. And so if you have a patient who has a traumatic brain injury and you don't get SWI, I think it's really not helpful. And that if you pick one sequence to do, one MRI sequence. MRI contains multiple different sequences, like 15, 20 sequences, sometimes 10 sequences. And SWI is the best for trauma. It can show those hemorrhages. Thin section triplane imaging, it means you don't just, a lot of times in emergency rooms, you scan up to down, and that's kind of it. We try to do up to down, left to right, front to back, so you can find some of that, the subtle findings. And then advanced imaging, volumetric software we're talking about, diffuser tensor imaging, perfusion spectroscopy, functional fMRI. Don't talk too much about that. Then there's MRA, which looks at vessels, and then there's an alar ligament protocol, which I think is really excellent that we've started doing for whiplash, because the head is connected to the brain. There's lots of kind of more recent thoughts on that it's actually that connection is greater than was previously thought. But there's time and cost constraints to doing all this, so not every center will be doing all that. So why advanced? I mean, we already answered this question because it's not very sensitive, and then these are some articles that say that the advanced imaging is actually more sensitive. Now, the downside is sometimes it's not as specific. So if you have maybe an older patient, lots of pre-existing conditions, advanced imaging may be abnormal, and then you're kind of stuck. Is it related to the trauma? Is it related to prior strokes or hypertension or diabetes or things like that? And these are the articles. One of our publications was the New York article. So some of the question I get not unusually is, when do you image with MRI? Some people say, well, you should image late, you should image early. In my opinion, you should image early. And the reason is that about 70% according to one article. My personal experience is it's not quite as much as that, but 70% of hemorrhages within the brain from trauma, microhemorrhages, that they will resolve on the follow-up MRI. And then also you can have non-hemorrhagic shearing, which is a little sometimes tougher depending on where it is to come down on than the hemorrhagic shearing. But 30% of those, actually up to 50%, can actually resolve as well. And then brain contusions, where there's actually volume loss and scarring around the contusions, about 30% of those will resolve on follow-up MRIs if they're imaged at the time of the trauma, with a 40%, almost a 44% volume reduction on average. So that's why you want to image early. Now, why would you want to image late? And that would be for the atrophy. So if the brain is injured, it will get smaller. Sometimes the whole brain, if it's a very bad injury, or just regional parts. So there's kind of benefits to both. I mean, ideally you would have both, but there's also, doesn't always happen. So here's some examples of some, these dark areas here are hemorrhagic diffuse axonal injury, and the image on the left is a gradient echo, and the image on the right is SWI. And you can see the SWI is better. Those are two different types of sequences. So you really want the SWI if it's available. And not all SWI is actually created, well, let me see how about that. You can also do 3-dimensional reconstructions of it. Basically, the computer program makes it kind of cartoonish, and just as nice to kind of see it better. You always got to check the source, but these 3-dimensional SWI is something that it's easily available, but a lot of places don't do it. And you can just see how it looks a lot clearer on the 3-dimensional. But you have to check it on the source image. Oh, and then I did want to say with this SWI, so not all SWI is created equal. There's the best actual SWI sequence that exists is through Philips. I have no relationship with Philips or anything. No stocks in Philips. Maybe I should buy some, but they have a patented SWI sequence. And it's just beautiful, especially on their more advanced. We have 2 magnets nationally at SimonMed that do the SWI, where it's so exquisite. You can see every single little tiny vessel in it. And they're beautiful images. The next best is the Siemens. It's still very good. And then G is kind of on the, but they're close together. It's not like one's a 10, one's a 5, one's a 4. They're maybe 10, 9, and 8. So they're pretty close. But it's just maybe something to be aware of. So triplane thin section, we're talking about doing the thinner sections, and both in many different planes. And this is an example. The arrows are pointing to the white signal there, and that's a very subtle contusion. There's no differential for that. This is a young patient who had a trauma, and it may look like, well, stop flashing. It may look obvious there, but this is on one slice of this very thin section protocol. And so I just saved those images, but these are like 2 millimeters thick. And so if you had a 5 millimeter, it would just skip and you wouldn't see it. So that's one. Here's quite a subtle temporal contusion, this area of volume loss here in the inferior left temporal lobe, showing the CSF signal there. That's where you can commonly get contusions. The most common are the anterior medial frontal lobes. And then the second is the anterior temporal lobes. And then the inferior temporal lobes, maybe it's third, I'm not sure, but the reason is because the brain is kind of grading on the skull if you get jostled, and it scrapes the bottom of the brain on the skull base. And if we had not done this coronal thin section T2, we would have just called it home. So I would have called. So this was a case I saw 2 days ago. I always like to put at least one case from 2 days ago, so people think that it's a recent talk. But this is a very subtle contusion here. T1 sagittal showing this, and this was on our neuroquant sequence, which is 1 millimeter, 1.2 millimeters. And you see the gliosis on the flare there. So it's one of the most subtle contusions that I've seen. And without that thin section, you also wouldn't see it. So these are more examples of hemorrhagic diffuse axonal injury. It's highly specific for head trauma, meaning there's no differential if you see this pattern on the SWI. So that's what that looks like. Here's a very bad case, and it's a bad case when you use circles instead of arrows, just a severe trauma. Maybe this isn't, I know this is supposed to be a mild or complex concussion. This is not any of those, but just to kind of show what it looks like, the standard hemorrhages from brain trauma. And if you have a patient that has diffuse axonal injury, I try to comment if there's areas that have hemorrhagic DAI, diffuse axonal injury, that are described in literature as having a poor prognosis, because it could mean the patient could do worse than someone without it. And these are really the areas that have most of the research in: corpus callosum, brainstem, midbrain, and thalamus. And these are the articles that talk about this, and especially the, hopefully there's an article by Moen, which is really the best on this, which somehow it's, but these are, so, those are the areas that you want to look for to see if they're effective. This is the Moen article. So Moen article is really great. And here's a patient that has these little black dots in the splenium of the corpus callosum, and that's kind of where it is on the sagittal. Corpus callosum is the biggest fiber tract connecting both sides of the brain. It's the only fiber tract connecting the right and left brain. So some other findings that you look for as a radiologist on head trauma patients is atrophy. So this is a patient, very bad injury. There's a subdural hematoma, there's edema, there's, and these are supposed to show, these arrows are supposed to be on the black ventricles, which is fluid in the center. And then years later, you look how big the ventricles are compared to that. So the whole brain is atrophied, poor prognosis, poor prognostic sign, all the frontal scarring. These are the articles, really nice articles. One of these is a 30-year article, probably never be repeated. They follow patients 30 years. And basically they found that when the ventricles got bigger because of trauma, that those patients had the worst prognosis, which interestingly was even a better predictor of cognitive outcome than the severity of the original trauma. So that was pretty interesting to see that. So you always look for that. And that's the benefit of doing serial scans is to look for things like that. And volumetric software can help with that. And if you really want to this was maybe from a legal case that I was involved in, where you can trace these to get actual volumes. You can also trace the corpus callosum. Corpus callosum can get smaller over time from injury, so you can do that kind of thing. But normally in the clinical reads, you kind of look at it and say it's smaller or not. And then you can graph these. So this is kind of what can really sort of prove a patient had a brain injury. This was a mild traumatic brain injury case. So this is actually kind of relevant. This patient actually had a scan before the date of trauma. And their ventricle size, I was tracing them to come up with the centimeters cubed of the ventricles. And then they had the injury, and then the ventricle size shot up afterwards. And then it kind of continued, but kind of stabilized. And this is the pattern that you see from trauma. From either atrophy or ventricular size increasing is right after injury will shoot up, kind of stabilize, and then continue. So that you can kind of graph these patients. There's articles that have done this, a lot better than this. This is only a single patient that looked at groups of patients. And so this was a mild traumatic brain injury case, very subtle case. And this was at the time of trauma, which was in 2009. And the arrows are pointing to the black fluid-filled centers in the ventricles. These are axial images, front, right, left, and back. Maybe I should have said that at the beginning of the talk. But and then so 2 years later, they got a little bit bigger, and then they kind of were a little bit bigger 7 years later. But the biggest difference between these ventricles is actually in the 2-year difference, not in the 7-year difference. These are closer in size than this, if that makes sense. And the reason is because of that atrophy, mild traumatic brain injury case. And we graphed, I think this was, and we graphed that, and this is kind of your expected. So the patient shot up like we saw, and then they stabilized. So that was an example of that phenomenon. Another area that I try to look at fairly closely is the hippocampus. It's commonly injured, maybe in more, doesn't have to be advanced trauma, even mild traumatic brain injury, as we'll show. But the hippocampus are these areas that kind of hang off the medial temporal lobes, involved in emotion and memory symptoms and things like that. And so you always want to look at those. We have a volumetric program called NeuroQuant. There's other ones out there, but I'm pretty familiar with the NeuroQuant. We've done some of our research that's focused on that. And this patient had normal by the size. This was in hard to read. I think it was a 98th on one side and the 56th percentile, which means basically it was the median on one, and then it was actually high. But the asymmetry index was in the 99th percentile. That compares the average patient right and left asymmetry. So even if it's normal in size, if there's an asymmetry that this has to be clinically correlated. It's not like the radiologist can necessarily make a definitive a diagnosis without, maybe they had prior head trauma, maybe they had epilepsy, those types of things. But it is consistent with trauma in the right clinical setting. So here's an example. Patient has a large left temporal contusion, and then the left hippocampus, which the arrows are pointing to, is clearly smaller than the right. Just an extreme example, and that's what it should look like normally. So the hippocampal atrophy will tend to be on the size of the where the trauma is. And this was a great study that came out pretty recently, 2021, in mild traumatic brain injury patients, and they had controls, and they had mild traumatic brain injury patients, and they saw that the hippocampal atrophy was associated with various symptoms like episodic memory and something else, but it was in 2 to 4 weeks, they saw differences between controls and trauma patients in mild traumatic brain injury. So it's pretty fast that they saw that. The Pharma is the only paper that really did it in this way, and it was a pretty nice study. And then you can graph these. So instead of the ventricles going up, and the reason they go up because the brain is atrophied and fills in, other structures will be reversed, so they'll go down. So following the trauma, you get like a rapid decrease, and then it will stabilize. So it's sort of inverse to the ventricles. And the hippocampus is one area you can look at. Another area to look at is cortical atrophy. And I know Dr. Delani was going to talk on post-traumatic headache, and cortical volumes have been associated with post-traumatic headache, and in some studies. So the volumetric software can look at that. You can also look at the images yourself and sort of see. And so this is an example case I saw a couple of days ago where there's these little red areas. Maybe you can't see those, but these are little red diffuse axonal injuries, all in the right parietal lobe. And this is the right-sided DTI, which we'll talk about. So it's all right parietal. And then we have, this patient had a trauma on 2 months before this MRI, and their volumetrics in the right parietal lobe was in the 39th percentile, which again is not abnormal. But then on the follow-up, it went down to the 25th percentile. And everything else, this is done on the same scanner, everything else stayed the same. So the atrophy was occurring in the same lobe as the hemorrhagic diffuse axonal injury following the trauma. So that was pretty interesting. Perfusion is another way to look at looks at blood flow to the brain. Just going to see what I'm going here, so I'm not over time. Okay, so we have a little. It looks at blood flow to regions of the brain, and so this patient has contusions, and obviously there's no blood flow to the area of the contusion, but the blood flow is altered beyond the contusion. This is a nice review article, pretty recent, 2021 or something like that, that looked at all the articles. You can do this with contrast, where you inject into the veins, or you can use arterial spin labeling, which is a non-contrast, which is what this is. So we're starting to do more arterial spin labeling, and it can be pretty helpful, especially more recent to the trauma, even at the time of the trauma. There's a lot of literature that says the alterations of blood flow in patients with trauma can be seen. Okay, so now talk about diffuser tensor imaging. And so, little introduction, it really works by measuring how water flows along these tiny axons smaller than a human hair, like telephone wires throughout the brain, and just looking at how water molecules are flowing. And one way to think of it is if you have a glass, you put a straw in it, the water will move preferentially along the straw, whereas if it's just in the water by itself, will move randomly. So that's what the MRI is looking for. And the value of how that water is moving is called FA value. It's called fractional anisotropy. It's just a number to kind of quantify. And typically low values are indicative of axonal injury. The acute phase, high values have been described. Even in the chronic phase, high values have been described. It's due to maybe chronic inflammation or compensatory. I've seen a couple of cases where we had a pretty strong feeling that it was compensatory, because there was injury on one side and the fibers on the other side had high FA values. So I think that is a phenomenon, not really well described. But this is how we do it in a lot of studies at our centers. We do the corpus callosum. the largest fiber tract, it's the easiest to measure. You can have technical issues with DTI, and so you want to control it as much as you can, so you're not so you're scientific as you can be. And you can do these kind of interesting 3D reconstructions of those fiber tracts. So basically, this is the axial image that you get, and then the computer can turn this into a 3D reconstruction. And this is what it can look like. So this is the anterior, this is the posterior, up and down. So it's the corpus callosum, which is this structure, the largest fiber tract in the brain. And that's what the 3D reconstruction can look like. And the arrows are pointing to a gap there, fiber tract gap or thinning. You can see it on both sides. And it corresponds to a hemorrhage. So a hemorrhage is right in the same area, the black dot there. There's probably a non-hemorrhagic shearing injury in this patient too in the same area. So it's kind of neat to see the FA values are lower, 3D, and it matches the pathology. So again, offering more sensitivity. And this is a case really just to show the validity, I guess, of DTI more than anything. This was a young patient. They had bilateral frontal lobe contusions. These are sagittal images showing the scarring and volume loss in the frontal lobes on both sides. This patient, I think, was like 8 years old, very unfortunate. And this is the DTI, and it shows all the front of the DTI is torn up. But the contusions the contusions are only going to about here on the DTI. So the DTI is offering increased sensitivity, expanding the injury, showing that it's actually greater than just these bilateral frontal contusions. And the rest of this is normal. You know, the back, this is how it should look. So that was a pretty neat case. I mean, in terms of imaging, not for the patient. And this is the same patient. So you're looking at the patient now. These are the eyes. So it's a frontal view showing these contusions, and then the same thing. Unfortunately, he was moving a little bit. And this is not a mild injury either. This was a patient's diffuse scoliosis and encephalomalacia. It means scarring and volume loss. But then the DTI done matched, very well where that was, and then shows these other areas also in the back here. So now the question is, what if you don't have that, but you have this by itself? Can you call abnormalities? And that's where we're trying to make progress to be without over.
Are you okay?
Oh, sorry. Is there a question?
Okay, bye.
Oh, just this is literature that kind of shows other neuroradiologists matching DTI with conventional imaging. There's not like we're the first people doing this or anything. Sure. So this is what one thing we're doing, which is pretty exciting. And this is having a normal database and comparing FA values, not just corpus callosum, but like 48 fiber tracts to a normative database. And so it's really challenging to do this. And I've seen this done in some other capacities or other centers where I don't think it's really scientific, because for a number of reasons, or as scientific as it could be. But you have to account for differences in DTI techniques. The DTI values can be different based on vendor, based on scanner. So you need to have familiarity with the scanner it's being done on. But you can use a normative database if you account for the differences between scanners. So using this technique, the company that we use is called Mindset. And they actually have a human that comes from the scanner where the database was done, flies to the scanner where the patient was scanned, and then you can use scaling factors because you have a normal patient on both scanners. So you can scale the scanners so that you can be scientific and then you have over 1,000 patients in the database. You can get Z-scores for all 48 fiber tracts. It's pretty exciting. And a lot of clinicians like this too, because there's deficits in the fiber tracts. They can do the physical exams or various tests, which they know much better, infinitely better than me, and they can correlate fiber tract damage to symptoms in an individual patient. So that's kind of what that is. And here's an example. So this is the same patient we saw. We already saw that. And these are all the fiber tracts. And I don't know if those are visible on the screen, but this is listing all the fiber tracts. The corpus callosum is 3 standard deviations below the mean here. The 0 is in the center. That's the mean. That means that they're kind of 50% as compared to the database. And then all these other fiber tracts are also 2 or 3 standard deviations below the mean. So the DTI database in this case turned a isolated, I mean, we already have it from the tractography that's bigger than we thought from the contusions, but the DTI whole brain really shows that there's injuries throughout all these fiber tracts in the brain where the patient is way below statistical significance and basically turned it into a global brain in that case. So yeah, here's another example of that database just to show the validity of it. We have hemorrhages. We saw this case before, hemorrhages in the back of the splenium, which is here. And there's just a diagram showing where it is. But this red star I put there, it's not like the patient has that, but that's where it is. And then the 3D tractography shows some thinning there. And then the DTI database with the 48 regions and all that showed that it was 2 standard deviations below the mean, the fiber tract in the back of the corpus callosum, which is right where the hemorrhage is, where we're seeing that on the tractography. And that's interesting, but then what's also interesting is that the body and the genu, which is the body is here and the genu is here, they're right at the mean. So these are normal, and then that's abnormal by the DTI database. So just seeing cases like that kind of helps know that that it's a valid thing that's matching what we're seeing. And this literature says that the corpus callosum can be involved in more severe head trauma. So those are literature examples. Here's a case of a hemorrhage in the right middle cerebral peduncle. So this is down in the back of the brain, showing this hemorrhage there. And then the DTI database showed that the middle cerebral peduncle was 2 standard deviations below the mean on the right side, but then also on the left side, which we don't see the hemorrhage. And the rest of it is all normal, although they had I think they had some other injury too, but all these other, this is the same case as the other ones. So they, the rest of these fiber tracts were pretty normal. So, and then this is also the cerebellar peduncle, or middle cerebral peduncle is known to be involved in head trauma. This was an article from New England Journal of Medicine. Not New England Journal of Medicine. I think that's the next one, but it found the red is showing differences between controls and TBIs, and it's actually clustered on the right where this hemorrhage is. So it's a nice article supporting the clinical finding. And then, this is the New England Journal of Medicine that saw that the cerebellar peduncles, there were a couple areas, and this is mild traumatic brain injury, DTI study, that there was significance in it, and the middle cerebellar peduncles were one of them. So try to look at that region and see if there's abnormalities. And then if you have an abnormal DTI that's in that region without a hemorrhage, then you might be able to call trauma depending on how low it was, or if there's any pre-existing conditions, even that you would otherwise call whole brain normal. So that's the value of this kind of database, I think. So this is a six-year-old. I think this is showing some volumetrics here. So we got a young patient that had a small ventricles and then severe trauma with dilation. And the ventricles by the volumetric analysis were in the 99th percentile. So that's more than 3 standard deviations above the mean. And that's what a normal should look like. So just a really bad injury in another kid. And this was the DTI database with all these fiber tracts. And these are, I think this one goes up to actually 4. So all these fiber tracts are more than 4 standard deviations below the mean. It's the ones that are completely to the right. So that's, I don't even know what percentage that is, but it means that you only have like less than 1 patient, if that would be that way normal. And this is their 3D DTI, it's just completely torn up. But starting with these severe cases and then working backwards, I think is the best way to kind of approach imaging to get comfortable with what you're seeing. And so this patient we were talking about the hippocampus before being affected by a head trauma. And these yellow areas are showing hemorrhages in the right hippocampus. So we have diffuse axonal injury in the region or adjacent to the right hippocampus. This is a volumetric analysis. This is not NeuroQuam, it's a different group we use that shows pretty an asymmetry in the volume. You can see it's smaller. So there's asymmetry with volume loss in the right hippocampus. And then the DTI shows that the right hippocampus has a decreased DTI in the fiber tracts compared to the left. So in a case like this, you have all three things matched. The volumetrics show the atrophy, the DTI shows the abnormality, and then you have the findings on conventional imaging. So it's nice when you get that because you can just say that. And then sometimes if you have patients that this chart is kind of interesting because even if something is not statistically significant, if it's a fiber tract that's commonly affected in head trauma, you could mention it in a stronger way in your report. So this is a nice review article, the nicest I've seen in terms of, it's by Niagara Naya, Journal of Concussion. And it looked at all these fiber tracts and it compiled, it only was looking at mild traumatic brain injury, so any other studies they excluded. And they described all the papers on all the fiber tracts. And so if you get the full brain DTI database back, you can look at see what fiber tracts are decreased compared to what she found in her study. And if they're matching, even if they're not maybe 2 standard deviations or low, then you could say that these are the patient has a trauma pattern. Maybe it's not a strong one, but it's one nonetheless. That makes sense. So so we also do this 3D tractography we started doing, and this patient with a frontal lobe hemorrhagic diffuse axonal injury, and then this is different than the corpus callosum one we saw before. It's kind of going out to the cortex. We started doing this, and it's nice when you can kind of see it there because it's just another way to kind of look at the injury with a cortical 3-dimensional tractography. All right, and this, I don't know if I can play this. Is there a way to play this? But this is, there it goes. Okay, this is the file that kept crashing everyone's email that I was trying to send. But this is what we'll hopefully be doing in the next probably month or so at all of our centers, is having this uploaded to the PAC. So it's a cortical DTI 3D reconstruction that will kind of spin around, and it's different than the corpus callosum, which is more in the center. And so the thought, and we've kind of tested this on a couple of patients, is that if they have like a contusion or they have somewhere, you'll see it on this, and it will help. Maybe to help you go back and look at the regular images, or even depending on how comfortable we get, call abnormalities on this alone, if depending on maybe some factors. So this is hopefully I'm pretty excited about this, and I think it's going to be a nice thing to do. Oh, okay, all right. So it looks like I'm actually somehow on time. Sorry if I was talking fast. I didn't want to stall out here at the end. But I wanted to talk maybe a little bit about some of our research and maybe see open to maybe questions are at the end, but if we have any, we could talk about. This was a study we did. We have in our group has a mild traumatic database of over 1,000 patients, and a lot of them are excluded. So we get down to like 700 with volumetrics, and maybe we have about 300 or 400 probably with DTI depending. And so he's published this study. It's a retrospective. It uses a statistical method called interval censoring, which allows you to compare patients that were scanned at different scan times with different times seen by the clinicians against clinical outcomes. We had an army of medical students who were going through and adding all the clinical stuff. Patient had dizziness, headaches, if they improved, resolved. And our statistician, Dr. Veneer, created this, she borrowed this technique to allow these large retrospective databases to look at clinical outcomes against some of these imaging findings. And maybe we don't have to maybe get into this, but as maybe other people have talked about, age is a worse prognosis. Loss of consciousness has a worse prognosis. Sex we found was pretty similar. Sometimes there's some articles that kind of say there's some mild differences. And then we did an MRI status where we took away hemorrhages, contusions, and we only basically used volumetrics, white matter, and perfusion and some of the advanced stuff, and then we found it was very strongly associated with outcomes. So it shows that these advanced techniques are promising. Now we're trying to sub-segment out of those. And so we have some recent abstracts, and we're trying to turn some of these, or we are turning some of these into papers based on this. And this is just a summary slide of what our research has found, and none of this is discordant with anything out there. It's all been described by other people before. But the take-home points is that diffuse tensor imaging of the corpus callosum has a high association with cognitive outcomes, at least between mild traumatic brain injury and control. So you get a report back and it says the corpus callosal DTI is kind of lower limits of normal, or it's abnormal, or there's a shear injury in the corpus callosum, then one thing that the docs might look for is cognitive testing or to assess that. We also found some DTI fiber tracks correlate with loss of consciousness, which was really interesting. Notably the extreme capsule, which is like on the far out of the basal ganglia, or the subcortical location diffusely, which is why we think maybe that could be affected. We also, the white matter hyperintensities in young patients, we found a statistical association with loss of consciousness and cognitive. Not published yet, but other studies have found cognitive. Some have not found statistical correlation, but they included older patients. Pituitary volume, actually, that's maybe not correct there. That's, ignore the pituitary one. Hippocampal volumes, we did find that the anxiety and depression outcomes and possibly headache. And then the cortical volumes had a pretty nice correlation, very strong, especially temporal lobes and other areas with post-traumatic headaches. If you take all the MTBI patients without hemorrhages or anything, and you separate them into lower cortical volumes, higher cortical volumes, account for age, that post-traumatic headache was higher in those with lower cortical volumes. So the cortex has probably something to do with the headaches. I'm not sure what that is, but that's. And then auditory fMRI, we haven't talked about it. It lights up this is auditory, so it lights up the temporal lobes, and we found some association with anxiety and depression and possibly headache. So anyway, that's just something to, I mean, a lot of this is unpublished stuff, but just for discussion or for the interest, that's what we found. And then I guess we could finish with this, alar ligament protocols I was talking about. The head connects the brain. So these are really, I think, beautiful images showing the coronal of the alar ligament, showing the transverse ligament right here and the alar ligaments just really nicely. And occasionally whiplash patients, we can pick those up on the action. So I think that's about it. Since I'm from Vegas, I have to show a contortionist in the scanner. And yeah, and this is her head, and that's her kind of butt. So she's doing a contortion for you all. And yeah, any questions, feel free to email me or anyone. And thanks again for having me. This has been a lot of fun. Thanks.
Thank you so much, Dr. Snyder. Great way to go out to lunch. Food should be out there. And any questions for Dr. Snyder, feel free to walk on up. For those of you guys on the virtual platform, just keep in mind to keep your computers muted. That's on the bottom right, so that some of that noise is carrying over. We will pick back up promptly at 12:45. So please enjoy lunch and mingle, and we'll get rolling at 12:45. Okay. Dr. Streeter, are you there? Can you hear me?
I'm here.
Okay.
Can you hear me?
Yes, I'm going to do a quick introduction and then I'll pass it on to you, okay?
Sure.
Okay. All right, everybody. We are back for our post-lunch sessions, and we have the pleasure of starting with concussion telehealth, reaching out to our remote communities. And fittingly, Dr. Streeter will be presenting to us remotely. This wasn't by design, unfortunately. She got sick this week, and this is kind of the way it worked out. So you get to test some of your remote skills. So that'll be cool. All right, so I'm going to just pass it over to you, Leslie, and let you get going, okay?
Thank you, Dr. Morzavi. I think it's appropriate that I am talking to you remotely from beautiful Benson, Arizona, given my topic. But as this presentation evolved, it is less about telehealth and more about improving concussion care in remote environments. And I chose to use Cochise County as kind of a reference for how are we doing, because I live in Cochise County, but I'm hopeful that this will be applicable to other parts of Arizona and just other rural communities in general. First of all, I want to just start with either the outline of real quick review of the best practice guidelines. Dr. Mortazavi and others have already gone through those. Then talk about how we decide, how we kind of went about deciding what is the current state of in Cochise County for trying to, or how closely are they meeting those guidelines? And then what are the tools for improving it, what works and what's been done? The best practice guidelines mostly come from the 5th consensus and the CDC. This is gonna be the 1-minute review because they've already been gone over so completely. Avoid routine CTs, functional assessment using validated tools, avoid absolute cognitive rest for more than 2 or 3 days, gradual return to cognitive and non-sports activity, use the return to learn, return to work, exercise rehabilitation programs and return to play, the use of vestibular ocular rehab, if we have deficits, vestibular ocular deficits, and cervical rehab. And then also referral to a concussion specialist if symptoms persist beyond 3 weeks. So current state of concussion care in Cochise County. I sent a survey out to every provider I could find in any kind of listing in Cochise County. I sent it to ER doctors. This is a list of the different kind of providers that I sent it to. And after that, in parentheses, is how many responses I got. It was actually a pretty underwhelming response, even when I sent reminders. But I'm grateful for the ones that I did get, and hopefully they will be kind of a cross section of what's going on out there. Also, it was interesting to note that the responses that I got from school psychiatrists and administrators just deferred to their ATs and RNs. They said, we don't know about that, ask our ATs and RNs. So I did get some responses from them, actually. They just declined to answer the questions. The first 10 questions for my survey, I asked later some things about feasibility and what they would recommend and of different solutions. But I just wanted to know first, how well were we doing based on the guidelines? So first, I just asked the first couple of questions, just talk about how prevalent is the problem? How many MTBIs or prolonged concussion cases are they seeing? And then all the rest just really reflected, did they know about and were they following the guidelines? So this is Cochise County versus the best practice guidelines. And the results were pretty mixed. Well, first of all, the numbers. I asked, how many MTBIs do you see per year? And if you look at this, there's a big discrepancy in the numbers. ER doctors and athletic trainers saw the most. Physical therapists saw quite a few. PCP saw the fewest. But then when you come down to how many prolonged post-concussion cases did you see across the board, it was 0 to 2, 0 to 2. So 0 to 2, if we look at 0 to 2 times all the providers maybe in Cochise County, it's not a huge population that we're looking at that needs help. But for those people that need it, it's very important that we still do what we can to provide a good quality of care. So knowledge level. I asked how knowledgeable are you of the current best practice guidelines? And I got not at all down to very well versed, with everything pretty much in between. So kind of a mixed review on that. Some people really didn't know about the guidelines and other people seem to be very proficient. What imaging, so starting with avoiding routine CTs, I asked what imaging was most often ordered. And they actually were doing okay here. Some don't order at all because they refer out to neurologists. But it seems like they've looked, one said not routinely. I rely heavily on UpToDate for recommendations. ER follows the protocols, regular ER protocols for CT. So I felt like this isn't something that needs to be so much addressed, that they already seem to be doing really well in this area. Functional assessment using validated tools, and what assessment tools were they familiar with using? As far as do you feel comfortable, I got all the way from a no to a resounding yes. Mostly providers were not comfortable. Athletic trainers, where I should have put who gave each response on these. I did on some of them and did on others. For the most part, athletic trainers were the most comfortable assessing concussion and seemed to have the most knowledge of what to do about it and how to assess for it. However, we did have one PCP in Little Tombstone, Arizona, was very comfortable and very proficient. He's the one that said he uses the military guidance MACE as his assessment tool. And on all of his answers, it was just very evident that he had a lot of experience. So if you get a concussion in Cochise County, you want to be in Tombstone, Arizona. There were people that had never heard of any of the assessment tools before. And some, like the athletic trainers, were more likely to use SCAT, bombs, impact testing, BESS, the ones that were most standardly used. Like the school nurses tended to use, I think all the school nurses said they used Heads Up, which I was really happy about that. I used to be a school nurse. And the fact that they're all using Heads Up, there's so much great information and resources in Heads Up. So I felt like that was really a positive. But the fact that some of them had not even heard of the assessment tools and had really felt uncomfortable doing an assessment, even people that have been in practice for quite a long time, means that we do need to do quite a bit of work in this area. And we'll talk more about that later. Avoiding absolute rest for more than 2 or 3 days. And I asked, what do you recommend in this area? ER said they don't make recommendations at all. The one ER doctor who responded, well, I don't know if that's a good recommendation and if that's better than recommending too long of rest. Some referred to neurology and just had the patient take their advice. Most people just said kind of common sense when they're ready to go back to do things, start going back to things, or they just followed the recommendation of their doctors. The athletic trainer again said first few days if they need it, and that's it. So I felt like overall the answers to this were that I learned that they know quite a bit. As far as gradual return to sports, return to learn, and exertional rehab, I felt like there's a lot of work to do. Most of the people said that they hadn't even heard of it. Some knew that it existed, but they'd never used it. The athletic trainer said they use it in their schools, but return to learn, this is from the athletic trainer at Buena. He's working on getting return to learn in his schools, which they do not have out here yet. And again, the doctor in Tombstone, he has it and he uses it. Okay. Vestibular rehab and cervical rehab, are you using it? What kind of rehab do you? And one said he knew nothing about it. He refers to a neurologist. And other response, I got this from more than one person. No, is there rehab for concussion? That kind of made me want to cry. The other said that the rehab they use is brain rest, education, and activity restriction. For the first 3 weeks of concussion, I guess that you could call that rehab a little bit, but it's not the kind of rehab that we really need. As far as rehab, we need some vestibular, some ocular, and possibly cervical, depending what's going on. The athletic trainer, again, very well versed in it, but said he did not have time to practice it. He's seen too many kids. And then this one I especially wanted to use from one of the physical therapists, that this was in Sierra Vista, said that they can provide expert cervical rehab, but very limited vestibular rehab, and that they're trying to hire a vestibular rehab specialist or train one. And that has been a limitation, is getting someone who's trained and able to work in it that will be here permanently. Referral to a concussion specialist after several weeks. I asked for PPCS patients, who do they refer to? Do they refer, and if so, who? Almost universally, they refer to neurosciences, specifically Western Neuro, Center for Neurosciences, and Western Neuro in Tucson, arranged. And again, I was really gratified that at least 2 people said they refer to Spark. So that's a shameless plug for Spark, that at least 2 people know that we exist and they refer to us. I just, the concerns for this, I do think referral to neurology is definitely warranted, but often neuroscience, they treat partially and then they send to us. And my experience right now, when I have patients that are just experience long-term headaches or other problems, and I'm sending them to neuroscience, it's taking months to get them in. So If they refer to like a sports medicine place, us or others that treat, we can usually get them in within the week. And then from there, we can get them into neuroscience as soon as possible. But I was glad to at least see that almost universally, that if the symptoms go beyond 3 weeks, that they're being referred to a specialist. Summary. So what are the needs? Based on the survey, one thing that was needed was increased knowledge of best practice guidelines. That most of them said that they really weren't very familiar with them. Access to functional assessment using validated tools. So we need to increase knowledge there and access, increase knowledge of return to work, return to learn and return to play protocols, increased availability of vestibular ocular rehab, and increased access to concussional specialists for PPCS without having to travel. Those would be my top 5 things based on what people said that when I asked, what do you feel like the weaknesses, and just from what I've seen. And so I wanted to talk a little bit about, we know the needs now. What are some of the things or ideas that we can try, and what are the feasibility? So for each one of you that kind of went through and asked some questions about what could we do about it. So knowledge of best practice guidelines. I feel like education for providers is the way to go here, obviously. Increased education, increase actionable functional assessment and validated tools. Again, education for providers, and also quicker access to specialists and people who treat it more commonly, so that they can have that. Increased knowledge of increased use of return to learn, return to work, and return to play. Again, education for providers. But the truth is that other than in the schools with the athletic trainers and the nurses, most primary care or emergency room doctors would not have time to implement it. So again, finding ways that we can get them through telemed or satellite clinics or other ways, get them into a specialist who can provide those things sooner. Increased available of vestibular ocular rehab. Okay, this is in here just for me and for nobody else, because we've been doing at Spark, we've started the last 18 months, we have kind of an experimental satellite clinics that we're doing in Benson and Sierra Vista. And one of the hardest things, I've been out there, one of the hardest things is finding people that have some severe, that they have a severe vestibular ocular deficits and they need some rehab. But the closest rehab I can get them is in Tucson. And other than just the minimal basics, for someone who just needs maybe the basics, that there's some PTs here that are quite good at that. But beyond that, I have to send them to Tucson. And these are people that have severe PCS, and driving to Tucson is often just not even feasible for them. And so this is a big problem. So what can we do? And because it does not lend itself all that well to telemed, my idea for that is recruiting or retraining, or else can we have a satellite clinic where we just have them there maybe once a week? And then the fifth one is increase access to concussion specialists or PCCS, and telehealth here would be a great way to go for that. Another way to go to that is satellite clinics. And tools for improvement, what works. So these are the things, the 4 things after the survey and reading a lot of reports and we're on rural health and what's being done. The 4 things that I thought could be implemented in Cochise County and most areas in Arizona. Education for providers, key, and probably the least expensive. Biggest barrier to this one is providers' time and interest. Recruiting and retaining providers, again, I think this is the least feasible, but sure would be certainly helpful. Telehealth, I think there's so much potential for that, especially I want to go into in some of the upcoming slides, some things that are kind of innovative that have been done. And then satellite clinics. And I'm going to talk mostly, I couldn't really find a lot of research that's been done about effectiveness, but I can tell you about our experience so far with satellite clinics. Education for providers, it's covered with explanation points because this is so key. I should have put my resources cited on each of these facts, but they're in my resources at the end. Proper management in the acute cage is critical. If we can get proper management for our patients in the acute cage, it's critical. All providers in the most common providers that are seen for concussion in the first 4 weeks are athletic trainers, school nurses, primary care doctors, and the urgent care. So those are the people they're going to see in the first 4 weeks. The acute stage of care is critical. So it's very important that we have education and that they know what to do. Those people that are going to be seeing first. 72% of the providers reported in my little survey said that they weren't comfortable managing MTBI. So we need more education. Also, research has shown that increased provider knowledge increases outcomes. And this is so much more critical in rural settings due to limited access to specialists. There's probably going to be a longer delay before they are seen by a specialist. So education for the primary, the athletic trainers, the school nurses, and the PCPs and urgent care who will be seeing them first is just so crucial. What resources are available? Shameless plug again for Spark, but we will come to your school or your office or anywhere else that you want to let us talk to you. Education is so much a part of our model. I've been at Spark, we're working with Dr. Mortazavi and learning so much from him for the last 5 years. And I've just seen, I kind of came in the tail end of TUSD, really implementing the best practice guidelines into what they do in their schools. And then as I've been here, seeing it spread to Marana, Sarita, and just the level of care has just expanded and become so much better in the whole Tucson area, but still so much to do in some of these outlying areas. So we are so excited to come out and give an in-service. If any of you are listening or know someone out there, call us. It's free. Also, our website has handouts, blogs, and videos. TMC Annual Concussion Symposium that you're listening to right now. I sent the link to sign up to this to everybody I send a survey to. And I don't know if anyone signed up, but it's free, it's annual. And I feel like this has just been a wealth of information that would be so useful. Barrow's annual training for AT, both of the ATs that responded to my poll said that they went to this last year, or said that I know from one, and the other when I reached out said that they attended this. And that's also free. So that was great. Every single school nurse that replied, all three of them, well, I should say all three of the school nurses that replied said that they use the CDC's Heads Up program. It is, especially if you have limited resources and limited time, it is a great resource. They have a 40-minute training for free. You get a certificate at the end that says you are trained. They have tons of information, handouts. It's all free. If any of you in the rural areas are listening, these are great resources, or anybody that knows people in the rural areas or have a way to spread the knowledge. Also, Brain Book by Barrow Neurological Institute. It's not being used. It's being used at TUSD. I think most of the schools in TUSD use Brain Book. Brain Book is not cognitive testing like Impact. Brain Book is information for students, coaches, and parents. It's more of it's still done on the computer, but it's more about concussion and when you should get out. And so the students can be advocates for themselves, and that they understand a little bit better why if they get hit and no one sees, that they tell a coach or they tell somebody. And it's a really great program. I do not know the cost on that. It's not being used from what I can tell from any information I could get at all in Cochise County. I do not know about other rural areas. And but that's another great resource for student athletes. Okay, recruiting and retaining providers, especially therapists. Best practice guidelines, and Mo talked so much about this, multidisciplinary approach to care. Routinely for prolonged post-concussion, I send to some or all of these providers listed plus more. And so as far as barriers, from in my survey, some of the responses I got to barriers to recruiting, they said always helpful, but we're very rural, and this is always an issue, and they have money afterwards. And then one of the school nurses says there's a huge need, but I don't think we have the volume to keep them here. And unfortunately, that is the truth. There isn't usually the volume of people that you'll see that a specialist could warrant a specialist moving here full time. But this is my sales pitch. I love living in beautiful Benson, Arizona. This is a beautiful county. If you love outdoors, especially if you are an OT or a PT and you've thought at all of moving to Cochise County or rural Arizona, we could sure use you, and I can give you the contact information and have a job for you. But we really need them here. It's one of the biggest challenges that I face doing satellite clinics is not having a therapist to refer to. Telehealth. This is kind of our great hope for the future. This information comes from a systematic review of telehealth and sports-related concussion by Torres-Dahl et al. It included 356 articles on telehealth for MTBI. The big questions, and they did both PCS as well as acute concussion. The two questions they were asking is how is telehealth being used for MTBI management in rural settings, and the strength and the weaknesses of telehealth for MTBI care. They found that it's not really used for prevention or for most acute settings. It's being used more for long-term care. I mean, for management of people that are more long-term. And so then what are the strengths and weaknesses of telecare for MTBI? Strengths, increased access to specialists much sooner. So they talked about that on average, without telehealth, it was usually 1 to 3 months before they were seen for a specialist. And that was the good model, the better ones. And with telehealth, it was more like 3 to 4 weeks. So that was an improvement. It facilitates multidisciplinary care. If you want to, we really need for the PCS patients, a multidisciplinary care team. You're really a team working together on all these different problems, on all that we talked about earlier. That all the different modalities, and it really is hard to get that in a rural setting. So it would really facilitate that. Reduce travel time and cost. For some people, travel time to Tucson from Cochise County is not a big deal at all. Especially for those that are having to drive themselves and are having vestibular ocular deficits, it can be really big. And for some people, they do not even have a car or access at all to get to Tucson or someone to drive them. Some of the other things that they found, well, looking at what it is most effective for, the studies found that it was safe and effective for history taking, symptoms assessment, and patient education. That it was just for those 3 things, it was just as effective as being seen in person. But the limitations are limited value for acute sidelines evaluation. You just need to see the person in person. There were some studies that about just a few where an athletic trainer could call in or a coach could call in, but and that is helpful. That is definitely better than nothing. But still, the ideal is someone on the sidelines or in the acute office doing the physical exam. Limited physical examination. This is probably the biggest limitation that I would say to telehealth. We've done, especially during COVID, we started doing more and more telehealth for a while, and then we've gone back to the office. And I feel like the biggest limitation is not really being able to do a good physical exam. For follow-up patients, this is not quite such a problem if you've seen them before, but especially for a new patient to really get a good look at how they're doing ocular and vestibular, you need it. It's really hard. You can do this somewhat on the screen, and I thought of going over some of the things that can be done with a physical exam, but the truth is that none are validated to use for telehealth, and it's limited. I've tried to use them before with patients. Sometimes you have a really clear reception, and I feel like I can see pretty well, and other times you can't tell if the choppiness is the screen or the eyes. So it's just, you need the physical exam if you can get it. Computer screens can exacerbate symptoms. This is so huge for our patients. They were telling them, don't look at screens for more than 5 to 10 minutes if they're really acute. And then we're saying we're going to do a half hour to 20 minutes to half hour visit with them. And sometimes they just cannot handle it. It's not feasible for most rehab modalities, especially OT, PT. They really need to be hands-on. Cervical rehab, it really needs to be hands-on a lot of the time. I'm sure there's small things that can be done, but we really need OT and PT, some neurologically trained OTs and PTs who would love to live in Cochise County. And this is the quote from the conclusion that I wanted to include. In-person visits will always have the advantage over telehealth visits. And I believe that this is true, that telehealth is wonderful and certainly fills in a lot of gaps. But if we can get in-person visits, any way we can get an in-person visit as soon as possible is to the patient's advantage. This was another study that was done in Canada, the potential of telemedicine to improve pediatric concussion care in rural, remote communities in Canada. And this was done in Canada. This was a really great study, I thought. They used a model that they borrowed from stroke that had been done in Canada. It started a comprehensive concussion care center in a big city. They also recruited a regional hospital. And then they had, they just approached different community centers through very rural communities. Most of these are way more rural than Cochise County, that lot can only be reached by helicopter or airplane. And they, in each community health center that agreed to be part of this, they trained a provider, a nurse practitioner, most usually it was a nurse practitioner, sometimes a pediatrician, but they were trained in doing functional assessment and using the functional assessment tools. And so the first visit was always done at one of the outlying health centers. And then and then they were referred to the regional hospital via telehealth if necessary, or to the concussion center. And then follow-up visits were done often in conjunction between the primary care doing assessment at the outlying centers, and then the meeting with all three together at the concussion center. And that was a really great model because it overcame a lot of the barriers that we were seeing, or a lot of the limitations of telehealth, specifically not having a physical exam. So it combined the benefits of telehealth with the benefits of in-person. And I think that this is a great model. And I think that maybe something that we could try, if we could do, we already have a point person in Tombstone, Arizona that knows all about it. So if we could, at one of the remote community health centers there, if we could get that kind of training at each community health center, this might be something that we could provide. Then I'm almost out of time, so I'm very briefly just going to talk about satellite clinics. We've been out there for 18 months. Apex, I have Apex's logo up there. Apex very generously has rented us space and has been so accommodating as we learn how to use the model up there. So we're renting space at Apex so that we can be there once a week, either in Benson or Sierra Vista, or sometimes I drive between the two. And in the last, we've seen 22 concussion and PPCS patients in the last 18 months and followed their care. Many have been discharged, some I'm still seeing. The strengths are really the in-person exam, that we can do an in-person exam, that we can have that rapport with them, seeing them weekly or every other week, or how often, every 4 weeks, however they often need to be seen. Reduce travel time and cost for the patient. In person, I'm quoting this back from the first study, in-person visits will always have the advantage over telehealth visits. So that's really the strength. Limitation is that we don't have access to all of our testing and the staff that I have in Tucson. For me, that means I can't do OMT or QEEG. Soon I'll be able to do OMT, so I'm excited about that. Or QEG, I mean. Also, I don't have all my staff. It's like living out of a suitcase. I have a wonderful MA out there. It's just me and her. So I take vitals. I don't do the active rehab, but between the two of us, we cover all the bases. But it is like living out of a suitcase. Everything that I need for my patients has to be packed up, the charts, all the information. I take pictures of insurance cards and send it back to Spark. And the biggest limitations, though, are lack of physical therapy, OT, speech rehab, neuropsych, neurooptometry. And so if I would encourage anybody that feels like that they could, if Dr. Pollack is listening, having a satellite clinic once a month in a rural community would be so beneficial to those communities who really some of them have just no access to some of those things that they need. And that makes such a difference sometimes in their care. I've had a few patients that finally I just convinced them that they needed to see neurooptometry or OTPT in Tucson, that it was worth their drive if that was at all feasible to them. And once they could get that rehab for the more severe patients, they started to make huge progress that we were just not making when they just didn't have the rehab that they needed. So in summary, the ideal is that we have best practice guidelines to inform the care for every patient everywhere. And so there's no more horror stories. Horror stories to me are the stories of patients that come in It's been 6 months and they have been in and out of school. Their kids went straight back to school. They've been in and out of school. They can't tolerate school or work. They think they're going crazy and nobody has any answers for them. And I just think that that should never happen, that there's plenty of providers out there that we just need to be sure that there's enough information that they know either where to refer or what to do. The other summary is just that this is the current state of the care in Cochise County. Hopefully, I would hope that some of the things that we learned are generalizable to other areas and that we can apply some of these things. Some tools for improvement are education for providers, key. And I'm not quite sure what to do more about this. I think when providers are only seeing 0 to 2 prolonged post-concussion patients a year, that maybe they're not particularly motivated given their very limited time to become more knowledgeable in these areas, but reaching out and trying to find ways to make this more available to them and to convince them to please do it. Recruiting and retraining providers, I made that small because it's just not as feasible, but again, I try. Telehealth, I think especially the model of telehealth and using the outlying regional community centers, that there's huge potential, that it could really be very effective. And satellite clinics. I found that a satellite clinic, at first it was hard to get used to, packing up all my stuff and traveling. I really like the rapport that I have with my patients in those areas. And even just kind of getting back to the basics of things like taking vitals again, really going through the whole process with the patient and being more involved in all of their care. I've had to really do some research myself on things like speech and PT and OT, just to try to get some home exercises that I feel like are more than just the basics we usually give, and then refer to OT and PT. So those are the things I've learned and the ideas that we have so far. Going forward, I hope that we can really work to use the model of care that really I feel like that we have throughout the Tucson area, and now just spread that further and further. We have a satellite clinic in Marana that I failed to even mention until then, and the 2 out here. I'm hoping that we can take this idea and really reach more people. And if you have any questions, I'll be available at the end. These are my references and resources, and thank you for your attention.
Thank you. Thank you so much, Leslie. I appreciate it. Just a fantastic talk on telehealth, and we certainly need to have more and more talks like that. My practice, my panel currently is 1 day of telehealth, and it just allows you to work those margins and reach out to patients who otherwise wouldn't be able to see you, or see anybody. So thank you for that. We've got Dr. Pollack up next to discuss treatment of vision and oculomotor deficits. She's one of our fantastic neurooptometric docs in town, and someone that we turn to a lot for our patients with the visual profile who are just not getting better. And so we will start with her. And as you can see, the rest of the afternoon, we've sort of got these quick hitters, 30 minutes each, and then we are getting there. So we've got a few other talks left, vestibular, cervical, and then mood, and then we'll be there. So thank you. So Dr. Pollack, I'll go ahead and bring you up. Thank you for being here. We're excited for your talk.
Oh, thank you. How's everybody doing today? There's so much knowledge that I've already learned, and it's just I'm writing down notes here. There's always something to learn with Dr. Mo and his team, and so I feel really humbly appreciated to be a part of this and to share something that I really love. I see a lot of friends out here that we all have a passion towards helping people, and that's why I just love being a part of this organization and this process. So let's move on, right? So when we look at, I'm going to be talking about vision and how it's really dealing with the space and movement of how it works. There's a real question of what is vision? And quite honestly, I'm still learning what is vision. And so when we start evaluating and reconsidering what it actually has to offer, I keep wondering, what about that? And what about this? So anyway, let's dive in a little bit. If I can move this, there we go. Is it gonna move with me? How about this way? All right, Dr. Mo. This one? Okay, there's no financial disclosures. We'll just move right along that one. Okay, here I am. I've been practicing for about 15 plus, probably another plus years. So I work mainly with concussion and rehabilitation. I also work with strokes. I work with learning related cases, also specific types of eye turns as well, and have worked a lot with Dr. William Padula. We've published some material with Dr. Mo and his amazing crew. I work with some in the sports world. And in addition, I have 2 different fellowships, one in College of Vision Development, and the other one is Neuro-Optometric Rehabilitation, where I'm 1 in 3 on the National Executive Board. And so there we're looking at protocols and procedures to take nationally to be able to move and be a part of it. I have recently moved my practice to a hacienda in the canyon, which is at Watermark Facilities. I was asked to bring my private practice over, where I still work with all of my public that I had before, but I'm also developing protocols for risk to fall and vision and balance rehabilitation. So as we move on, in my area, I work both in office and I also work virtual. As everything exploded, as we all know, I had to learn to be virtual, as we all did, right? And I found out, as Dr. Leslie has stated earlier, that sometimes when we look at concussion and the problems with concussion, that movement, and even as Randy, who did a fabulous job just recently, talked about that driving piece and how much having to drive from one place to the other is such a huge piece of how to be able to work through those symptoms. And so we have developed protocols and treatment programs in both areas. So I really dive into 4 specialties, one in movement and balance. So we're looking at peripheral central organization with overall movement and integration. I'm also working into enhanced learning. You're going to find out that a lot of these patients also have some type of cognitive or delay in processing. You may even find it doing in their history that they may have had this previously, and then everything goes up, right? The other area is in sports performance and enhancement. So I work in both spaces now, even more so, because I have a son heavily in baseball. So now I'm heavily in sports even more now. And then now we go into concussion and rehabilitation, who I have worked with Dr. Mortazavi and his team for about 4.5, 5 years now. So we are always on the cusp of asking those questions, which is so fun to work with him in that space. So let's talk a little bit about this. Why not, if you're having trouble with your eyes, why not just do general optometry? Why not we just go get an assessment and see what's going on? So when we look, and it's very critical to have this opportunity to do that. I mean, we are looking at the back of the eye and we are looking at the front of the eye. But the other piece that we want to be aware of is what is that difference, in a sense of when you're looking at neuro-optometric rehabilitation, we're not only looking at sight and ocular disease, but we're going beyond that. So what we want to be able to do is look beyond that and see what else is happening. We want to know what is actually happening with that eye. Does it actually focus? Can you actually use that eye to be able to look at something up close with just one eye? Can you do it with the other eye? We'll kind of play around with this a little bit later. Then how do those eyes actually team together? What happens with that process? And then what is really light sensitivity? Does it have to do with binocularity? So I want you to start kind of opening up that package and keep asking yourself, what is vision? What really is it? So now as we look through this, we come to these common symptoms, like when you think, okay, I think it's vision related. Let me ask some questions. Blurred vision. Do you have blurred vision? I mean, how many of you have that on your history form? Yeah, distance near, okay, I got it, I circled distance, I circled near, they got a bulb, okay, something going on with the eyes. But really, what is blurred vision? Is blurred vision just because I see blurry in the distance? Or I see blurry up close and I need a pair of glasses? Or is blurred vision possibly actually something that goes in and out of focus? Could blurred vision actually be when I'm trying to be able to see, it actually creates movement? That's the identification of blurred vision. So it's keep to question that idea of blurred vision could be more than just the statement and more than just needing a pair of glasses. Because a lot of times people will say, hey, I went to the optometrist, I went to the ophthalmologist, I got my glasses, I see fine, but man, is it not working? Why? So then we go to the second one, sensitivity to light. Is it because they have dry eye? Is it because actually with brain injury, as they're taking in information, it's too much information for them to take on, they can't filter that information, so therefore that whole sensitivity to light is overwhelming, that's what they're calling it. Okay? Then as we look at the reduction or loss of visual field, this is another piece. When we do a visual field, we're saying, okay, ophthalmology and optometry look at that and say, okay, we got a left visual deficit, we got a little bit of there's a little bit of field loss here, or it's a neglect. But the piece is that some of those testings, they look the same. And the other part is it may not be just one or the other. It could actually be a combination of both. And the more that you start doing the treatment, the more I start like pushing the envelope a little bit. And that's just how I play. Because the piece is that when you're starting to deal with vision, vision is the integration of, it's working with the brain. It's working with every lobe in the brain. And we'll be talking about this. It's dealing about this integration of movement. And so when you look a little bit further into that and you say, okay, is it neglect? Is it a field loss? We even find sometimes it actually changes a little bit more and we start actually improving in visual field. Well, how do we do that? Well, maybe it's just because the test isn't there enough to be able to provide that, and we're doing neuroplasticity like we all know of through our research. Okay, the other piece is headaches. I have a headache. Okay, we'll dive a little bit deeper. When do you get your headache? Do you get your headache when you're trying to read? At what distance? Just because it's on a computer, is it arm's length? Is it further out? Is it over to the right? Is it over to the left? And the other part I always do is you're evaluating behavior, right? We talked about behavior therapy. We'll put this right smack in the middle of that because in behavior therapy, we're really looking at why does that person do what they do? They do it because it's the best thing that works, right? They look over to the right, they put their computer over to the right, they have to bring it down a little bit. So that's giving you feedback, and those are giving you little pearls that some of you in the rehabilitation world can use. Because now you know that's where you're going to start, because you got to take them from where they are to move them to where they need to be. And if we don't look at those pieces of how they move and behaviorally how they integrate, then we're not looking at the whole picture. Reading difficulty. What kind of reading difficulty? I have trouble reading. Okay, well, do words move on a page? Do they go like this? I can't tell you how many people that I train to do this type of work, which I help. I think so much with Dr. Leslie just talked about that, is that you have to start educating people of other areas to look at other professionals what to look for. Words move on a page. Do they go blurry and clear? Does it happen all the time? Where are your headaches? Do you actually skip words? So you're starting to create an understanding of it. If somebody reads it to you, do you understand it better than if you read it yourself? If that answer is yes, okay, then you got something visually going on, right? There's something more available there that you haven't dived into. The other part that we're looking at is more of the ocular motility movement, difficulties with movement. So you need to go into that. You can do the bombs of the piece of going side to side and up and down and check those gazes. But you really want to know, can they move in all areas of gaze? What is their best area of gaze that they focus in? Can they hold their fixation? How well do they hold their fixation and what gaze is it? That's your cue of where you're gonna start your rehab. Because we're always looking for that extra piece of where to begin. And those are the ones, when you're in the rehabilitation world, that is gonna tell you how to begin, because you first have to build off of success. We all know that in the trenches, right? That's how it plays out. So, oh, it moved. People virtual having a little trouble, now we're back on. All right, so the science between vision and balance, and how we look at this. VOR, we've been talking about it all day. VOR, really important to know about vestibular ocular reflex. Why is that so important? Hey, I'm scanning, I'm trying to walk, and I'm seeing my area, and I'm gonna move my head from side to side, and guess what? I'm blurry, I'm dizzy, I'm a little nauseous, I don't know what to do. Okay, so we know that there's this huge correlation. We know the whole neural networking system of that process, but let's back off a minute. What are we not looking into? If we take a step back a little bit, we're gonna see that some of those dominant pieces, if we don't see if they have stable bifoveal fixation, and we're gonna put somebody, and we're gonna take them a little bit further, we just took somebody, okay, and we put them on a boat, and we told them to dance. Okay, it's not gonna work, because you already have a system that's already rocking. And now you're gonna add something else to that. You've created instability on top of even more instability. So you have to confirm that their fixation is stable enough and it can actually hold that stability before you move anywhere. Otherwise, as you build off of that, you're gonna have a lot more difficulty. You may see a little bit of improvement here and there, but you're gonna plateau. Most likely, prove me wrong, it's fine. But most likely, that's what I find, and that's what comes to me. The other part that I go into is all those brain pictures were amazing. And in some of those things, from both neurologists, as we're looking at this, we're seeing that 70% of sensory information is visually related. 70%. Every lobe in the brain is involved with vision. It's involved with processing. And if we're not looking at it in a full dynamic way, opening the box and really checking it out, you're missing the boat, biasly. Okay, so we gotta be able to look at this, because what we're looking at is the consequences of spatial visual processing. What is vision? It's spatial. It's not how I see with one eye and the other eye. None of you are wearing a patch right now, just to see with one eye, luckily. We are looking at our space. You're evaluating where you are, where I am, where everybody else is. You're thinking about where the bathroom is, where the food is. You know where all that pathway is, right? You're taking in all that information and you're thinking about how you're gonna move it in it. That's vision. And it's dynamic. And if we need to understand that variety of what's really happening there. So as we look a little bit deeper, it's a bimodal visual processing system. Why bi? Because we're looking centrally and we're looking peripherally. Centrally, where you point your eye is central. Peripheral is all the secret sauce, as I always talk about. That's what you have to be aware of, is what's going on with that peripheral system. If there's a brain issue, there's dysfunction with the visual processing system, you're gonna affect your binocular system. If you affect your binocular system, that's bi-ocular two working together. If that fusional system is disrupted, you just lost your spatial orientation. If you lost your spatial orientation, now you're gonna have a little bit more trouble with being able to hold your posture. And a lot of times we find that after they've kind of lost how to use their eyes, then all of a sudden I start kind of seeing movement of how they start working. I don't know if you guys have seen this before, hopefully you have, but they start trying to figure out how to look at you and how to move themselves posturally to make sure that their visual system is as stable as it can be. Then now ask somebody, you do it. You stand like this and I want you to walk now. Go ahead and walk forward and backward and see if you're having trouble with your balance. Okay, so that's the part, is you need to transform that vision is spatial. And it's dynamic. And that's where we need to be looking at, because when we start evaluating that, we're being able to see that if we can be able to change the postural locate, how somebody's posture changes, and we can get them to be more upright and to work more binocularly, then think of all the things that you guys can do with all of your background. Because the vision is telling the body how to move. So let's go a little bit deeper. What we need to be able to do is look at that dynamic visual assessment. Being able to treating that as your base. I'm going to cruise a little bit more. Then when you're thinking about vision, you need to be aware we're dealing with the whole brain. Every lobe in the brain is involved with vision. You're looking at the central system. You're looking at the peripheral system. And that secret sauce that connects one visual field to the other visual field to keep that system to have a depth perception. If you don't have your depth, then you've lost your full binocularity. This is a case that happens a lot. We're just going to say monovision. Monovision, one eye distance, one eye near. Now that I'm working on protocols for risk to fall and working with a lot of the retirement community, I'm finding how much people that have been okay in monovision are now really struggling with risk to fall and are getting a lot more falls from that situation. And so when we look at some of this, we want to be aware of what's really happening. You guys take a pair of glasses. If your patient has glasses on, take them. Look at them. Look at one eye. Look at the other eye. See how different they are. Are they different or are they same? What does minus do? Minus minifies. What does a plus do? It magnifies. You put a small object and a big object, and you try to put it together and say, okay, brain work. Sorry, it's going to be a lot more difficult. They're either going to see double, they're going to have confusion of putting together, or the brain's going to try to figure it out and maybe do some other different things with that. This gives you a story of what we look at when we look at an assessment. And in this assessment, I'm saying I have a prescription. I got right eye, OD is right eye, OS is left eye. Right eye, I have a plus 225. Left eye, have a plus 375. What you're going to find is that, okay, right eye is 25, left eye 70 together. Hey, what? I got 25. You think that's okay, right? Now let's go near. Right eye, I have 125. Left eye, I have a 30. But you know what? Oh, both eyes are 30. But what we're missing is the story. A lot of times we look at near point of convergence, but what just happened? When you look at this assessment, you're going to find, I'm just going to give you the picture, the snapshot, is that in the distance phoria, there's a number here. This is phoria H. What that is it's talking about over-convergence. In the distance, the system is over-converging. But you know what? You didn't hear the rest of the story. Up close, it's under-converging. So you think you have convergence and deficiency, but you know what? You don't. And as you start evaluating this, what you're going to see is that, you actually have got a little bit of suppression going on. And at distance, you're having a little trouble with the right eye, but up close, you're having a difficulty with both eyes. So let's check out our right eye. And in this assessment, you're going to see how your eyes are tracking. You're going to see how your eyes are moving side to side. And just by looking at that assessment, you're going to see that one eye is kind of hanging in there, but that left eye, man, is really going to town. And it's moving all over the place. So if I go back, and we don't have time for this another day, when you're looking here at this process, I then decide, okay, where do I gotta go? I gotta go to a place that balances the system the best I can. So I'm actually gonna, and it's not all the time, but I actually have the opportunity to make them balanced. So I balanced them. I put a +3 in each eye. Then I got 20/20 acuities, which is good, but you know what? My near got 63 acuity in both eyes. What am I doing? Wait a minute, didn't they see better at near before? But let's look a little bit more. It starts to create balance. And you start looking at some of the symptoms of what happens with that right eye. Because the thing is, right eye meaning the test. And in that test, you're going to see that they're starting to learn how to be able to understand space and how to be able to move their eyes from side to side. Just imagine if you're trying to move your eyes from side to side and your system is off, you're already working on a boat. I call this when you have one eye that's distance and one eye that's up close. I tell a lot of patients you have basically what you're doing is you're walking with a flip-flop and a high heel. I said, can you do it? Sure, you can do it. Can you run with it? Maybe some can, maybe some not so good. But the thing is that we don't have a balanced support to begin. So when I started working, I actually did change that distance prescription just a tad because I'm very picky. And then after that, I got a little bit of this. Oh, and guess what? As I started integrating the visual processing system, not even changing anything, my visual acuity got better at near. So if I would have scribed it, I would have given double the amount needed. Now I'd start giving that person a little bit of that near prescription. And as you'll see, all my ocular motor movement starts to go down and they start being able to work better. But you know what? We're symptomatic, so I'm not done yet because the brain hasn't learned how to work with all the system yet. So I'm still working, but I'm getting there. And I'm learning how to create this system to understand space and movement. So now when you look at a progressive lens, I want to just create that understanding that when you're asking somebody that's having trouble with balance and you put them in a progressive lens, you just put them on a roller coaster ride because they're already having trouble seeing in the distance. And I told you I'm blurred and you gave me more. You actually gave me more information than what my brain can take on. Sometimes it's too much information. Just because they have 20/20 acuity does not mean the brain can use that information. It may be too much. They can't process it. So our secret sauce of our peripheral vision just got lost in a progressive lens. And we gave them about 5, 6 different pairs of glasses for them to try to learn how to use their eyes together. Other piece, some things for you guys to take home with you is when you're looking at acuities, you want to be aware of, oh, I just got an acuity. I can't tell you how much information I get from doing an acuity. Why? Because I can find out how do they turn their head? What do they have to do? Do they have to follow the letter to see if they know where it is? Do the letters jump? Do they move? What happens in that process? Is there a difference between the right and the left eye? How much? What's really happening? Look at all the symptoms. So you really want to look at how their body moves. The other pieces are to look at those progressives, right? Do they have a history of ADHD or anything else? Because that's going to rock their boat in vision way more. So you just got to keep that in your head. And also high prescriptions. Take the glasses off. If you're seeing when you look at something and it really magnifies it a whole bunch, all right, it's gonna be a harder case. If it magnifies it a whole bunch, another really hard case. If you're finding that it's really different between two eyes, your next third hard case. Really simple. So in 2 seconds, if you take your amazing pen that you guys all got, and you cover an eye, and you look in the distance, and you look up close, take that video in your head, do it again, other side, distance, up close. Ask yourself, was it different or the same? Now, take your pen, bring it up close, look at your pen and be aware of what's around you. All around there. That's your center vision, and all around that is your peripheral vision. Now do it a little bit further. Look at your pen, look around there. When you have some time to experience it, how is it different? How is it the same? Those are the things that we're ignoring of how powerful vision is. So when you start looking, Nora, I love Nora. This is my group. So they work multidisciplinary. They believe in multidisciplinary. I believe in multidisciplinary. These are some guidelines to look at. I am always available to show you more. I am now at Hosslingen in the Canyon, Watermark Properties. I welcome you as well. I will train anyone. I want to share this information because I believe knowledge is power, as we all are here. Thank you for the opportunity.
Thank you, Dr. Pollack. That was fantastic. A lot of just amazing stuff, and your speaking is always so dynamic. I appreciate that. And speaking of dynamic speakers, we've got another one coming up. Jason Klein, who I have also known for pretty much as long as I've been here managing concussions, because folks like Dr. Pollack and Jason are critical in helping our patients get better. He's going to be talking about vestibular and autonomic dysfunction. And we're super excited to have him. Sorry.
Thank you guys for having us. Fun seeing a lot of familiar faces here. All right, so we're going to try to stay on time, so I'm going to talk relatively quickly. All right, we're going to hit 2 topics today that each could be an 8-hour lecture on their own. We're going to try to give you guys a little bit of information that is useful leaving here today. So as you leave here, I want you to have tools that you can use. Oh, there you go. Tools that you can use and some clinical pearls. You're going to notice that a lot of things that I say actually sound like things you've heard already today. Some of the things that Dr. Pollack said, I'm going to reiterate. Some of the things that Randy said earlier, I'm going to reiterate those as well too. We're going to hear a lot of similarities between our talks. As we do that, that shows you that this multidisciplinary model in Tucson has a lot of overlap. We like that. We like the communication. We like that people are on the same page. So at this point, no financial disclosures, but I'm sure just like Dr. Pollack, if anybody wants to throw money at us, we'll be willing to take it. We're going to center ourselves right off the bat. Concussion pathology. This was my area of research. I have 2 concussion areas of research. One is histological damage during concussions. The other one is physical therapist role in evaluation and management. Those are kind of the areas that I've looked at and done work in. This is important to remember. We're not going to spend a lot of time on this. Randy talked on this earlier. When we see an immediate concussive event, we see a decrease in cerebral blood flow, we see a decrease in cerebral glucose. That is our acute pathology at this point. That does not explain some of the longer term symptoms because this resolved right around day 10, day 14, depends on which research you look at. So just so that we're aware, we're thinking about this as an energy crisis. We're centering ourselves around that. The vestibular system is part of that process that takes energy in the brain. Now, like Dr. Mo said, the vestibular system's a function, it has a lot of different functions in the brain. Spatial awareness, balance, where you are in space, autonomic nervous system. We're also going to add, thank you to Jessica for keeping me centered again. She's done more work to get me in line for this than you guys will ever know. So kudos to her. So in addition to what's on the screen right now, I just want to make sure that we're still thinking about that anxiety component. That was something that Randy talked about earlier. That's something that Dr. Mo has talked about. This is very much integrated into vestibular function. So that's a skill set that a lot of physical therapists don't have. So we as a community really need strong counseling services. We really need people that can help us in this battle because oftentimes vestibular dysfunction does not happen in isolation. Oftentimes the people who have had prolonged vestibular symptoms can develop some secondary mood, anxiety, psychosocial components. At the physio shop, we're happy that we're bringing in a sports psychologist from an NBA team starting October 1st. We're pretty excited about that. The community has kind of been catching up with concussion care in the last decade. And so now we have more and more resources around the community that are able to help us with that. Again, I cannot stress this enough. Concussion management is multidisciplinary in nature. Everybody has a piece of the puzzle that can be useful for certain patients. And that's where we go to those different phenotypes. So vestibular rehab can look like a lot of different things. And as Dr. Pollack was talking, and I apologize, I'm gonna make sure that you guys are all awake. I apologize for the pun already. This is where her and I get a little bit blurred with this. Oftentimes, vestibular dysfunction and ocular dysfunction can kind of overlap. This is where there's a lot of people that can be helpful, and getting someone to those services is so important. BPPV or vertigo is one of the things that's come up in the literature a lot recently. So we're going to spend a little bit of time on this. I want you guys to leave here with enough information that you can be well versed in it, but not as much that we're going to spend 4 hours on. Orthostatic dysfunction, cervicogenic dizziness, and this is the one that none of us want to talk about, but it does happen. We are going to see some patients that are malingering. There is a lot of circumstances that can happen. It's not just associated with concussion rehab, but it is something that we need to be aware of. So if something's not presenting as a physiologic loss of balance or an explainable loss of balance, sometimes we have to be aware of some of these other variables. So those are our horses. What are our zebras? Well, we have a lot of ones that I'm not going to be evaluating. So this is, again, where if somebody's not responding and they have true vestibular symptoms, this is where your physician or primary care team can be very, very helpful for ruling out alternative diagnoses. If someone's not responding, let's look for the other answers. So we're not going to spend a lot of time on that. Those are things that we can delve into later on. So BPPV, this is something that, depending on which literature you look at, occurs between 2 and 29% in patients with concussion. Now, what does that tell you? That tells you we have no idea how much that happens. 2 to 29%, that's a huge window. 2 patients versus 29 patients, that's huge. True vertigo is a separate pathology to a concussion. And this is, again, going back to what Randy was saying. A lot of these symptoms are not necessarily concussion induced. You can have a peripheral vestibular pathology that is happening in conjunction to the central deficits of a concussion. Does that make sense? So true BPPV is a dislodging of a crystal into a semicircular canal and having it get stuck. That is a separate pathology to that neurometabolic cascade that we talked about. They are treated differently. I hope that every person who comes into the clinic with dizziness has BPPV, because that is something that I can affect in 5 minutes. That is a very, very straightforward, most of the time, not always straightforward, I won't say that, evaluation. And then the treatment is very much if this, then this, and then we go from there. If it doesn't happen, then there's other opportunities for other medical management. Generally, if you're going to see someone with true BPPV, it is going to be positional. What does that mean? That means when they change position, and it's going to be short-lived. Generally, symptoms are going to be intense, lasting about 10 to 60 seconds, and then it's going to resolve. If they don't move their head, you'll see them walking like this. They're afraid to move any direction because guess what? When the room spins, they feel like they're going to throw up, and nobody likes that feeling. It can be asymptomatic until it's provoked. Now, generally when we say asymptomatic, I mean that intense spinning dizziness. People will oftentimes say that they feel a little bit off if they have BPPV and it's not being provoked at that time. They won't feel right, but they won't have that intense dizziness. So when we talk about this being asymptomatic, I'm talking about that room spinning, make you feel like you want to throw up. So if you're going to rule in or out BPPV, the combination of these 2 questions has a sensitivity of approximately 88%, which means if they don't have a positive answer to this, we can say with pretty good certainty, or it's unlikely that they have true BPPV. These are the most common things that people will describe when they have true BPPV. So if you do get a positive for that, or if you do suspect it, there's tests that you can go into. We're not going to go into that today, but those are the reference if you want to look at it. So there's your little clinical pearls on BPPV. You may not see a lot of it, but you have to be aware of it. So we're going to go through this. Every person in here, regardless of the financial status of your clinic, the equipment that you have, should leave here with the ability to do a rudimentary vestibular evaluation at the end of this. So if you're going to look through this, you're going to go through a subjective, an objective. We're going to go through some of those. If you have the opportunity for impact, which is one of the more widely used neurocognitive tests, we want to be able to correlate it with that. And then we need to know when to refer. So you need to be able to evaluate it, and you need to know when you need to get them out to someone else. All right? So your primary evaluator subjective interview should include what different symptoms people are having. Try to target them to the vestibular activities. Do you get dizzy in the car? Do you have a past history of car sickness? Gosh, it sounds a lot like what Randy was talking about. We can identify these people early on. We can get them to the appropriate care before this becomes a chronic issue. The goal is to not have people get into that chronic state of this. Do you have symptoms in a busy environment? Hallways. Okay, this is going to sound a lot like what Dr. Mo was talking about with some of the accommodations. Do you get dizzy when people are walking by you in a hallway? This sounds a lot like what Dr. Pollock, I lost where you went. Dr. Pollock was saying with some of that peripheral vision. Those are things that we need to be screening for. These are questions that are targeted that can give you information. Do you get symptoms with rapid head movement? Okay, well, this one, you got, again, just like the last 2 questions, it may lead you towards vestibular, but it doesn't necessarily mean it has to be. This can still be ocular, it can still be cervical. Okay? Just so that you are aware, again, gosh, sounds a lot like what other people have been saying. Dizziness at time of injury is associated with a higher likelihood of protracted recovery. It is something you need to be aware of, because if someone comes in day 2, day 3, immediately off the field, and they're describing dizziness, You need to have that in the back of your head as a potential risk variable. Okay? So the BOMS test. This is one of the more widely used vestibular ocular screening tests. Now, it is a screening test. The primary goal of this test is to identify symptom provocation. It is not doing what Dr. Pollack said. This is to say someone may benefit from seeing Dr. Pollack if they have symptom provocation in these areas. This is to help you identify which of those phenotypes these individuals will go into. The bottom 4, and I included near point of convergence, really it's going to be the bottom 3, maybe a little bit of near point convergence. We're going to talk about for the vestibular screen. So if they have positives on these tests, you need to have a suspicion up for at least a vestibular component to this concussion. Concussion phenotypes usually will have overlaps. And this is something that Dr. Mo was talking about. It's very rare, at least in my experience, to have someone with an isolated single phenotype. Oftentimes you will have overlaps between the different profiles. Identifying one profile does not mean that you stop your evaluation there. It means that this is something that you need to be aware of. It's something that you need to be cognizant in your treatment plan, not negligent in your management. All right? So when we talk about the BOMS testing, it takes 5 to 7 minutes. It takes a tongue depressor with a 14 font X on it, and it takes you a little time in the room with the patient. There's no fancy equipment. There is no expensive equipment. This is something that you can do in a rural community, you can do in a hospital, you can do it in a multi-million-dollar facility. This is a tool that has clinical utility, but it should not stop there. For the sake of today, really what we're going to do is we're going to say you need to be aware of this. This is a tool that you can use. It's not cost prohibitive, and it can be useful for you. So when we look at this, 3 positives, and positives are rated as a 2 out of 10 or higher increase from that person's baseline. So if someone comes in and they say they have 0 headache on a BOMS, actually I'll pull up this next one here. If someone comes in and they say they have a 0 out of 10 headache, and then they jump, or excuse me, 0 out of 6 headache, and they jump to a 3 out of 6 headache, that's considered a positive. So if 3 of the different categories rate as positive, it correlates with a 89% association with the diagnosis of concussion. So we're going to use this for targeting vestibular deficits here. You can use it for targeting ocular deficits, or just giving you an idea if that person is actually diagnosed with a concussion. So here's your clinical pearl. I know we're after lunch. I know that this has been a long day. So if you fall asleep, that's fine. Have your buddy wake you up for the clinical pearls. All right? I won't take offense to it. This is the part that I really want you to know. The other stuff, really, you can find on your own online. This is the stuff I want you guys to be paying attention to. Understand that when we have a positive on this test, it doesn't stop there. There's activities in this person's daily life that are going to provoke their symptoms. For example, if someone has visual motion sensitivity, which means that if I put them in the room and I have them in the corner and going back and forth like this, so they're tracking on a single object, kind of like what you just had to do with Dr. Pollack, and the background is moving behind them, that's a positive on your BOMS. Guess what? That is not the only time that that person is going to do that. They're going to be doing that same activity, walking through the halls, walking through the grocery store, driving. That's something that triggers in your mind a need for accommodations. You cannot just treat the symptom, you have to treat the daily activities in their life. If we are going to make accommodations, so common ones, and this is one that Randy talked about with the patient who drove to the U of A in the hoodie, baseball caps, hoodies, activity avoidance. This isn't something that we want long-term. We don't want them to accommodate to this. This is kind of like me saying, guess what? You get a headache when you go out into bright lights, which means I'm going to keep you in the movie theater for 20 hours a day while it's light outside. And then, oh, by the way, you got to go to the store. Now you go outside, guess what? You're even more sensitive to the light because you haven't been exposed to that stimulus. These should be thought of as temporary accommodations to allow someone to become less symptom provoked by those activities. These should be progressive. They should not be static. So if you're going to have someone wearing a hoodie, have them wear a hoodie for one class and then take it off for the next one. If they get symptomatic, go ahead and put it back on. But don't just shelter them. This is what we learned early on. We don't just shelter people in the early stages of concussion recovery. We saw what happened. The literature did a complete 180. This is a similar concept. Don't just shelter your patients from their symptoms. Allow them to be exposed to a stimulus and then recover. Don't just cocoon them. This is a similar concept. We talk about the accommodations of leaving 5 minutes early for the class. I think Dr. Mo said 2 minutes. We're going to go with the same concept here. If this is what's necessary early on, this is something that should be fluid. This isn't something that they should have 1 month, 10 months, however long, where they get to leave 5 minutes early. This should be something where we're constantly trying to reduce that accommodation. So if for the first week they need 5 minutes between every single class, that's great. That's what they need. They're in a highly symptomatic state. Allow that to happen. But that shouldn't just be the end of it. We should reevaluate it and say, all right, if this person if this person leaves 5 minutes early for the first class, can they leave on time for the second class? And if they tolerate that, great. That's perfect. Go back and leave 5 minutes early for the next one. You've just built on success. Dr. Pollack said this. Gosh, it's like we all drink the same Kool-Aid. All right. So build off of success. If they're not successful, go back to what you know they're already successful with, which is more intense accommodations. But don't just allow that to be the baseline. We should always be trying to decrease accommodation to increase activities of daily living. One of the things that I will stress to you the most is life activities can be concussion interventions. Daily life is full of visual stimulus. It is full of vestibular demand. It is full of exertion, postural muscles. Don't take that away from people. If they are not symptom produced by it, don't take it away. All right, so we got through the subjective. Jason went on a rant. Now we're into the objective. We're going to, again, keep this as anybody can do this in their clinic. Minimal cost to entry. There's a lot of fancy tools out there. We're going to talk about a couple of them in just a second, but this is one of the more rudimentary, well-studied balance tests that we can look at. The vestibular system is not just associated with the eyes. Dr. Cohen said this. It's also associated with balance and posture, where your head is in space compared to where your eyes are, what your body's awareness. These are all things that we need to be looking at. So the best test is a balance error scoring system. Dr. Mo talked about this as well. It is something that can be done in clinic. It's something that can be done on the sideline. It is important to remember that when we are testing balance, balance is most diagnostically accurate in concussions within the first 10 days. So if you've got someone a year down the road, this may be a good objective measure for you to have, but it may not have as much clinical applicability for that original diagnosis. If it's a year down the road, you already know what's going on too. So this is something that can be done. Again, this is another one that takes you about 5 minutes. It can be done in clinic. So we've got 5 to 7 minutes for bombs. We've got 5-ish minutes for a best test. Great. We've got a lot of time left over. So we talked about some of the cool new technology that's happening. This is if you've got a very well-funded clinic, shall we say. There's very cool tech that's coming out nowadays. So we've got some balanced sensory organization tests from Vertec. We've got different virtual reality systems. Tracer is one of the new ones on the market. This is something that Randy is on the forefront pioneering. This is something that incorporates reaction time, visual stimulus, proprioception, sport-specific activities. This is a very, very cool technology, but it's not something that is readily available for all clinics at this point. It is a costly piece of equipment. It is great if you can get it. If you don't have it, you can still treat and manage concussions. Okay? So there's a lot of fun things out there. You can spend a lot of money. I'm sure they would be happy to talk with you. It is great, great resources, but you don't need it if you don't have that budget. So impact testing is another thing that's very widely done. If you are doing impact testing and you are worried about a vestibular phenotype, look for memory, verbal memory, and then also your reaction time. Those are the two different categories that we see most positive when people have vestibular phenotypes. Okay, we're gonna move on from that. That's just information that you have as you're moving forward. So when to refer. At this point, if someone's had symptoms longer than 2 to 4 weeks, generally that should trigger in your head. That's somebody who may need a referral. Dizziness at time of injury with a subjective or clinical interview that indicates high risk for vestibular involvement, refer to someone or start treating that if you're comfortable. The goal is that everybody in the rehab settings can do this. This is not something that is unique to me, our clinic. People can learn this, you can do this. The community as a whole has come a long way in the last 10 years since we started really talking about this. You guys can pick this up. I always tell people there is no magic in the air in our clinic. There really isn't. People can learn this. You can do this somewhere else. Our patients can do a lot of these things at home. What we need is the guidance. What we need is the tools to teach them how to be independent. So I really like this diagram. This comes from UPMC. This is demonstrating the overlap of how we manage this. So Randy talked about this. Sleep should be one of the first things that we normalize. But as we are working on sleep, we're not just doing that in isolation. We're also treating vestibular, ocular. We're working on these different components of the concussion in terms of what that patient presents with and what we're trying to provide them with. Our clinical examination should lead to what interventions we are providing that patient. They don't happen in isolation. We don't practice in silos. Multidisciplinary management is the gold standard for concussion management. So again, this is something that you've heard from Randy: expose, recover, expose, recover, expose, recover. This sounds like a nebulous term. Here's what I want you to think of. If you're going to the gym, if you're training for a race, you don't just go max out and then hope you can do everything. You expose yourself to a stimulus, whether it's a bar for bench press, whether it's one pull-up, whether it's jogging 30 seconds at the gym. If that's what's taxing for your body, that's fine. Allow yourself to be exposed to the stimulus, then allow that tissue to recover. Don't try to do as much as you can, because then you break down, you become more symptomatic. We wouldn't have someone go from running 0 miles to running a marathon. That would be detrimental to them. The same thing happens with concussion rehab. We want to find a successful dose, I'm pointing at Dr. Pollack and Dr. Moe, and build off of it. And that's the value of your clinical evaluation at this point. Find where they're successful. Your VOMS testing will tell you where they are most likely to have symptom provocation. Start cautious there. If some areas don't have symptom provocation, know that you can push them harder in those areas. So traditionally, these have been some things that vestibular rehab has included. The problem is none of these look like life. I can sit there and look at my thumb and I can go back and forth like that. And then if I expect someone to go and play D1 basketball, guess what? That doesn't meet the demand. Just because they can do this exercise doesn't mean they will be successful on the court. We can't just rely on these isolated interventions to rehab high-level vestibular or any type of function. It should look like their real life. Individualized care structured to what that individual is going back to. So if we take the sports example, we take it one step further. If I'm a basketball coach and I train someone for 4 hours a day to shoot free throws, that doesn't make them ready to be a basketball player. That doesn't teach them the intricacies of the game. That doesn't teach them how to dribble the ball. That doesn't teach them how to interact with their teammates. That doesn't teach them how to cut, to jump, to rebound. So if we expect our rehab to be just here in an isolated environment where there's no stimulus, no movement, isolated to a single task, we are setting people up to fail. We can start with these isolated controlled environments, but they need to be progressed into higher amplitude, longer duration, more uncertainty, more stimulus surrounding. So as you're creating your interventions, start with success, become more complicated until it looks like what they need to get back to doing. Here's some other examples of vestibular function in sports. None of those original black and white exercises look like this. We need to train people to the level that they are being asked to perform. So, just so it's on your radar, this is a little bit of a plug. We are coming up on the 6th International Concussion Consensus Conference. This one's going to be in Amsterdam. We've heard of Berlin, we've heard of Zurich. Guess what? This one's 2 years late, better late than never. We've had a couple things going on for the last 2 years. This is one of the more comprehensive gatherings for concussion management. It drives a lot of the innovation in the field. One of the other ones was the team conference that happened, I believe, in 2016. If Randy was here, he would correct me. And this This goes to show the benefit of having someone like Randy in the community. Randy was one of the 33 or 36 people, I always forget this one, that was at the team conference. They were the people that basically were saying that concussions are treatable. Concussion is something that we can work to manage in a way that is effective, that doesn't just cross our fingers and have them sit in a dark room and hope that they get better. So having a resource like Randy Cohen in the community is exceptionally valuable to us, and we are all better because of that. So just so it's on your radar, that one's coming out. We're gonna go through autonomic dysfunction real quick. So we're gonna basically talk about this in terms of exercise at this point. So do we recommend exercise plus concussion? You better believe it, Dr. Mo said this already. It's nice to see some of the stuff that he had up there is the same stuff you're gonna see right there. JJ Letty did some research in 2010 and 2011 that basically said exercise post-concussion is safe, assuming that you rule out a couple red flags. But for the majority of post-concussion pathology, we are saying exercise after that initial 48 to 72 hours, we want to do. We want to do that in a sub-symptom producing threshold environment. So here's just some of the research that's been done on this when we look at the body of work that's come out of the last decade to 15 years. Those are resources that basically have validated the use of exercise as a management modality for concussion management. So 2 different exertion tests that you can do. So we spent 5 to 7 minutes on bombs. We spent 5 minutes on BEST. The Buffalo Concussion Treadmill Test and the Buffalo Concussion Bike Test are 2 different exertion tests that you can use. What we are looking for is symptom provocation at this point. With these tests, we're looking for the symptoms to increase from their baseline, again, greater than 2 out of 10. And then we're looking to correlate that with the heart rate that happens. So that gives us a therapeutic limit at that point. Remember, we want to be exercising below that symptom producing threshold. This gives us information where we can push people to right off the bat. It's important to remember that not all people post-concussion will have an exercise intolerance. Some people will actually have a decrease in symptoms afterwards. So this just shows another diagram of how you incorporate exertion or exercise testing into your concussion evaluation and management model. Clinical pearls, all right, buddies, wake everybody up, make sure you're there, all right? So not all concussion patients with a concussion will demonstrate exercise intolerance. Some may actually decrease. We see this a lot with the anxiety mood. What do we know from an anxiety mood phenotype perspective? Exercise can be beneficial regardless of concussion if you have an anxiety or depression. Understand your test environment. If someone has a vestibular overlap or an ocular overlap, there are things during your exertion testing that may provoke their symptoms. If you are worried about that, control that environment. If you have vestibular, if you have positive bombs, don't put them in the middle of a busy room where they've got stimulus on their peripheral vision. Guess what? You're going to provoke their symptoms and you're going to get a false test. Here are some of the modifiers that I would look at if you were going to do some exertion testing. And then as we start doing return to play, make exertion testing patient specific. This is something that Dr. Mo talked about with their clinic and the different types of sport specific testing that they are doing. So I'm going to talk about this for 2 seconds. This is something that you guys need to be aware of. This is, again, another 4-hour lecture. So when we talk about autonomic dysfunction, we talk about orthostatic dysregulation. This is something that's come up a lot in the literature in the last 5 years. POTS, MCAS, EDS, and hypermobility syndrome disorders. I'm getting my words all tied up right now. So these basically think of your hypermobile patients who have a hard time with orthostatic regulation. You need to be looking for a specific profile. This is not the only profile that you're going to see, but you need to be aware that this is where it's most commonly seen. So it can be triggered with a concussive event. You'll see that 11% of patients had a concussion or a potentially concussive event within the last 3 months of a POTS episode. 25% had a recent infection or illness. Ratio, it happens more in females than males, but males can present with POTS. Median onset was 12 to 13 years old. We're going to see this in conjunction with hypermobility spectrum disorders. It's generally, so this study was a little bit biased in terms of their patient population. They generally saw it in Caucasians. Their population was biased a little bit more towards that. So I would say have that on your radar, but don't think that in isolation. And then look for hypermobility and concurrent inflammatory disorders. And then, how did I do? We good on time? Yeah? All right, so thank you guys.
Thank you, Jason. Another fantastic talk, and you went not only through vestibular, but even beyond as usual. So thank you for that. We have up next Dr. Ong, who will be talking about concussion-related cervical dysfunction and treatment. So we're very excited to have Dr. Ong here. She's been with our group over at Spark for a couple of years now, goes by fast. Originally, I think from SoCal. We are very excited for her talk. Certainly the cervical profile is a big one. And those of us who manage brain injury recognize that it's par for the course in many of the cases. So, all right, thank you so much for being here. The clicker is right there, yep. And you could just go forward.
Okay, cool. All right, so I'll be starting my discussion about concussion-related cervical dysfunction and treatment. So our main objectives will be to explore the cervical symptoms associated with concussion, to understand the role of cervical dysfunction in concussions, and also to kind of explore the different types of treatments that we will have. And so I think from the whole day, we might have already discussed some of these definitions or statistics, but for a quick review, about maybe 80 to 90% of concussions, they do tend to recover within about 7 to 10 days. And these patients we actually don't really see in our clinic in particular. So the other 10 to 20%, however, these concussions may persist for more than 10 days or they're more than 2 weeks. And by this time, we do see a lot of this population in a concussion clinic. So for post-concussion syndrome, so it's basically a concussion that's persistent over 10 days, and we're seeing a constellation of associated symptoms. And so a lot of them, they do report or endorse this type of post-traumatic headache. And in some reports, some studies have also reported about up to 73 to like 90% in pediatric age range. So there's a couple of running theories of how this comes about. I've touched over it before, but there's thinking that there could be continued metabolic dysfunction. So there's some kind of ATP imbalances and also continued axonal dysfunction. So there's maybe some white matter integrity that's maybe not functioning as well. And then as far as psychological factors, so as we have learned or seen in a lot of our patient cases, is that they do tend to have some anxiety, maybe some depression or ADHD and some of our pediatric population too. Maybe some altered cerebral blood flow and also cervicogenic mechanisms. So for example, we do see a lot of motor vehicle accidents and also in addition to your typical sports concussions. So what is cervical dysfunction? So this, we have a concussion injury, and it's usually associated with a type of sprain, strain type of injury to the cervical spine. So for us, we have in these type of injuries leads to these constellation of symptoms that we see. And this includes headaches, dizziness, there's a loss of balance, they have nausea, there's visual, auditory disturbances, and some reduced cognitive function. So all of these symptoms we've all kind of explored a little bit throughout the day today. And so here we have kind of a more pictorial representation of what could happen within cervical dysfunction. So it could be within your cervical spine, it could be the muscles around the neck or the posterior part. It could be in a certain dermatome related to that cervical level spine. It could also be in between the vertebrae, so the set joints could be affected from this whiplash, motor vehicle accident type of injury. And so we kind of put all of these symptoms together and create this cervical clinical profile. So one is having neck pain. So they are reporting some type of neck pain related or associated with cervical occipital regions. There's pain generating structures within your cervical spine or around it. So there's the joint ligaments. You also have your cervical nerve roots and also your vertebral arteries. So everything kind of all encompassed and involved. The other part of the profile is having this cervicogenic dizziness. So they're reporting some imbalances, disorientation, neck pain, there's limited range of motion. And then there's also, as we have talked about before, is the cervicogenic headache. And so this could be secondary to a cervical spine disorder. These patients also have decreased range of motion, or there's this type of worsening headache that's associated with a certain type of motion. And here on the picture on the right side, it's a little bit hard to see far away, but these are the different realms of concussion that we have discussed before. And to kind of zoom in on one part is the headache and migraine realm. So these patients come in and they may or may not have a normal exam. However, they can also talk to you about having occipital tenderness, so their posterior part, and then neck tenderness, maybe having some tight neck muscles that's limiting their range of motion. And that's really all contributing to what we call cervical dysfunction. And we talk about a little bit about the different ways to treat it here. So manual therapy, things like that, I'll follow up a little bit later in this presentation. So here is a whole list of concussion and cervical injury symptoms. So I've highlighted a lot of those things in yellow. So headache, dizziness, ear ringing, irritability, having sleep disturbances, blurred vision, neck stiffness, balance disturbances, cognitive deficits, attention deficits, decreased isometric neck strength. So all of this I've highlighted, you definitely can see in concussion, but it's also overlapping with a cervical injury. So that's not to say that if you have a cervical injury, you definitely have a concussion. However, with these patients coming into our clinic, we know they have a prolonged course of concussion, and we are seeing all of these cervical spine or cervical dysfunction symptoms as well. And so mechanisms of injury, so with mild traumatic brain injury, a lot of the times there's a type of whiplash overlap in these concussion patients, and it could create these pain-related symptoms and also proprioceptive-related symptoms, so some type of imbalance, or they just don't feel very steady with either motion, it's worsening their symptoms overall. And so for cervicogenic pain, so how would your patient describe that to you? So of course, neck pain is super common. Headache is another thing that we've talked about many, many times. And in one study, over about 98% reported having some type of headache and dizziness. And then sometimes they can also try to localize their pain. So they may say they have upper cervical pain. So where are they pointing? Is it from the occiput to around the C3 level of their spine? Are they having, when you're examining them, are they actually having certain localized tenderness to palpation? And so how do we evaluate this when these patients come in? So we ask them in regards to having neck active range of motion. So you're having them rotate, you're having them flex, you're having them hyperextend or flexion. Are they noting certain segmental levels of pain? Is it the upper cervical portion from the occiput to their C3 level, or is it the mid portion or the lower cervical from C4 to C7? Sometimes it might be even a little bit lower around their T1 to T2 area. So, and there also is some differences when we talk about segmental side-based pain. Are they having pain on just one side of their neck or their head, or are they having both sides too? And so again, with examination, that's really important. And that's definitely something that we may not be able to do over telehealth, which an in-person appointment would be much, much more helpful. Other things to evaluate cervical dysfunction, they may also do this in the physical therapy setting in terms of diagnosis, is having a joint position, reposition error test. So this is where we are trying to test their ability to reposition themselves after passive flexion, extension, rotation, so all types of range of motion in their neck. And we're seeing if there's any type of evidence of spindle damage in their muscles. So that's one way. And then the other part of evaluating cervical dysfunction is doing a smooth pursuit neck torsion test. So they are rotating 45 degrees to one side, to the other side. And basically we're testing for any kind of cervicogenic cause of dizziness. And we're assessing for the afferent disturbance in the neck. The other part is the head and neck differentiation test. So this is testing for the cervicocolic reflex for their cerebellar function. So you're holding the patient's head pretty stable while they are rotating themselves. And if they are endorsing some signs of dizziness or lightheadedness, that is a positive test. Another way to evaluate cervical dysfunction is the cervical flexion rotation test. And this is really testing for the afferent proprioception disturbance in the neck. So this patient, basically, if they have a positive test, you do treat with manual therapy. And we'll talk about that in a little bit. So for treatments in terms of manual therapy, so there are different types. There's cervical scapular muscle exercise, there's spinal manipulative therapy. And I think in one study back in 2020, it was a randomized controlled trial. So they were measuring these clinical outcomes of these patients having cervical dysfunction. And they are saying if cervical exercise itself is helpful or is adding cervical manual therapy more effective. And these symptoms were measured at the end, or their outcomes were measured at the end of the intervention at 3 months and also at 6 months itself. And they, although the study wasn't a huge study, I think the number of people were about 81, but they did show some promising results in terms of having cervical exercise and using manual therapy did show some statistically significant improvement in all study outcome variables. So these outcome variables, they were measuring if they had greater range of motion, they had decreased pain. Those are a couple of the things that they were able to measure. So coupling these two types of treatments or therapies was much more helpful towards the patients in the end, in maybe the short term and possibly even long term. And so another way we can treat cervical dysfunction is trigger point injections, which we do commonly in our clinic here. So a trigger point is a focal taut band of skeletal muscle that is clearly palpable upon exam, and it is or does cause this referred pain. So where does this kind of pain generated, where is this pain generated from? So it may be from this abnormal motor end plates within a muscle, where basically you have motor and nociceptor nerves, they coexist. So that kind of amplifies the pain factor even more, increases sensitization within the spinal cord. And this picture is here just to let you kind of see where we can target these trigger points. A lot of the common muscles, especially in the posterior neck, your upper back and shoulders, that's where we see most of our trigger points. And so how do we do these trigger points? Injections. So it is injection therapy. So some use cortisone, some use just anesthetic like lidocaine. And commonly in our practice, we do use prolotherapy, which is basically a concentrated dextrose solution, and and it's a 1-to-1 mixture of anesthetic like lidocaine. And we do tend to do these ultrasound guided, and I do think that a lot of our patients appreciate that, where we have a good visualization of where we're going into the muscle. And it does also help us sometimes if we're going a little bit deeper, not just the superficial muscles as well. Common areas of cervical trigger points. So a lot of the times our patients kind of describe their pain is kind of in their posterior occiput. Sometimes it radiates to the front, but it really starts in the back of their head. And so that gives us an idea of where we can target our injections. So in this case, we would do a greater occipital nerve block. So that's one way we could target their pain to try to decrease their headaches. And so other places that we would target include the levator scapula, the upper trapezius, and also the rhomboids too. So the trapezius is a huge muscle. So there's a lot of different parts. So we have the upper part, we have the middle part or lower part as well. And once we get to the lower part, we also hit the rhomboids or the interscapular region. So a lot of those times they will also mention that they have pain not just in the posterior occiput, but also all the way down to their mid-back range. And those are the main muscle groups that we do target. And so for treatment, most of the time it is non-invasive therapy. So this is where we work really closely with our physical therapist. For some physicians, or if others are trained in osteopathic manual manipulation, we always welcome that as well. There's acupuncture, there's massage, and there's craniosacral manipulation. So there isn't always a single way to treat it. There's always adjunctive therapies. So there's not just one thing that we can try to target. And this is why we always try to emphasize a multidisciplinary approach in terms of working closely with our community physical therapists, acupuncturists, masseuse, and everything to help decrease the severity of our patient's symptoms. So in conclusion, prolonged concussion symptoms often include cervicogenic dysfunction or headaches, dizziness, muscle dysfunction. And if these symptoms are better identified or sooner identified, so we do a lot of pre-intake questionnaires where a list of those symptoms, they say yes, no, or how severe they are. That helps us give us an idea of what we can do right away to steer their course of treatment. And these treatments obviously may include, but are not limited to, physical therapy, manipulation, manual therapy, and also trigger point injections. That concludes.
Dr. Hong, thank you very much. Appreciate it. Another fantastic talk there. One of our quick hitters on cervical. Very well done. We're going to go ahead. We're a little early, but this is good. We're going to go ahead and just move right along to covering the mood profile and the role of cognitive behavioral therapy in PPCS with Dr. Dusenberry. And if we finish a little early, we can take a little break while we set up our panel and then answer all your questions and enjoy the rest of our Friday. So we're almost there. All right. So Dr. Dusenberry, one of our docs over at Spark, is going to be tackling one of the tough profiles here, the mood profile. So thank you for being here.
All right. Thanks for having me, guys. I will try to be relatively quick. I know I'm the last one, kind of standing between you and the end, so you can make it, hopefully. You may have some anxiety about this. You may be a little depressed at listening to one more person come up and talk to you. Good news is we're going to talk about mood, so maybe we can help you. I have no financial disclosures. Okay, you've seen this kind of set up a couple times already today. Main reason I wanted to bring this up was one, obviously we're going to be talking about mood, that little circle down at the bottom there, but also to just kind of talk about how all of these things, again, you've heard this already before, but there's a lot of interplay between all of these things, right? So I wanted to focus a little bit on kind of the intrinsic aspects of concussion that can focus on mood, right? So maybe I didn't sleep very well last night. Maybe I've got a lot of headaches. Maybe I'm a little, blurry when I'm looking at something. All of those things in and of themselves may make me feel a little anxious about the next thing I have to do, or maybe it's going to make me feel a little depressed that I'm not performing at the normal level that I am accustomed to doing. So just knowing that there's obviously a lot of interplay with all of these things, and knowing that treating one of these things can positively affect the other thing. But on the converse, if you don't treat any of these things, there can be a lot of negative loops going on where one thing's leading into another and going forward from that. There's also some extrinsic factors to your mood, right? Maybe you follow politics. That would be a depressing thing to do. There's wars. Dogs die sometimes. That's, sad. Maybe like you get bullied at the clinic. All the other doctors pick on me and stuff. It depresses me. Or maybe you got relationship problems, right? So there's a lot of other things that could be playing a role in what's going on. Or maybe there's like some global pandemic and that's really bumming you out, right? I don't have a presenter mode, so I don't have all the little stats I had put on my little cards, but I don't remember what it was, something like 25% increase in depression and anxiety since the start of the pandemic, just as a general overall. So it's obviously playing a big role. So we got to kind of keep an eye on some of those things. So what are some of the mood symptoms that we see in concussion? Well, you could be anxious, you could be depressed, you could be irritable. ADD, ADHD certainly kind of falls into this mood category. Maybe you're in a car accident, and now every time you get in a car, you're really stressed and worried that something else is going to happen to you. There can be personality changes. You can have some changes in your behavior, or just kind of your self-identity, either your kind of how good you feel about yourself, but also, again, I'm kind of focusing on some of the pediatric and some of the sport-specific stuff, but these kids who can't play the sport that they are normally playing, that's a huge hit to their identity, especially these kids who have played, say it's football for the last 10 years, and they think of themselves as I'm John, the football player, and now I can't play football. So what am I? So it can be a really devastating thing for some of these people to deal with when they have a concussion. Next, blank screen, good. Frequency of mood symptoms. So it happens a lot, right? Now there's a kind of distinction to make here between whether or not we're saying somebody has mood symptoms or has a mood disorder. Actually being diagnosed with a generalized anxiety disorder or severe depressive disorder or anything like that is certainly less frequent. But to have some amount or some kind of mood symptom that kind of correlates or goes along with your concussion is extremely common. So a couple studies showing 22%, 23% of kids, but some of them up to 50% of kids who are having a concussion are going to deal with some of these mood symptoms. And to be honest, anecdotally in our clinic, in my experience, it's definitely much higher than just 50% of these kids who are having some kind of mood issue going on. Next, kind of talk about the kind of interplay between mood and concussion, right? So if you had a mood issue prior to your concussion and then you get a concussion, you've got a much higher risk of having prolonged concussion, right? Say that you had a higher symptom score when you actually had your initial concussion, you have a much higher risk of having mood issues, right? There's even some evidence to suggest that if you've had previous concussions, even after your concussion's done, you have a higher risk of having a mood disorder later on. So trying to illustrate that there's a kind of interplay between those two, and having a concussion can lead to some mood issues, but having some mood issues could also lead to either worsening concussion or more frequent. Other stuff, kind of touching on the last part, they actually did an interesting study with NFL players. So it was over about 10 years. And it was just looking at players at the beginning. They took a survey, said, how many of you guys had these concussions? Who's got depression? What's going on? Came back, looked at them 10 years later, and there's this dose response curve to the more concussions you have, the more likely you are to have a mood disorder later on in your life. So just kind of showing that there's that specific interplay there. But they also see this in adolescents too. So if you had a history of concussion, you had a 3.3 times greater risk of having depression later on as well. So not just for the NFL players out there. So maybe let's move on a little bit from concussion, talk about anxiety, right? So there can be some kind of just innate pieces of anxiety when you have a concussion. Again, focusing on these kids, like they're not being able to participate in that sport that they usually do. They may be worried about their relationships with their friends. They may be worried about getting playing time when they come back. They may be worried about the potential for them to get that ever elusive but always sought after scholarship to go play in college, right? But then this also comes back to adults too. So we'll see lots of adults that have concussions, and when you're an adult, turns out you have to start paying for your rent and your food and all these other kinds of things. And if you have a concussion and it's a little harder to make it through work or do all the things that you normally do, there's a lot of anxiety that revolves around that. Another interesting study where they were looking at actual college athletes, and these were athletes that were not concussed, right? They're just asking them, hey, how do you feel about concussion? Do you worry about them? Are you thinking about them? And almost 50% of these athletes are already, prior to being concussed, anxious, worried, thinking about like, oh gosh, what's going to happen if I have a concussion? So we have to kind of just be aware of how big a role that the mood is playing with all of these things. ADHD and concussion, another big overlap here. So basically all of these are trying to say that if you have a history of ADHD, you have a higher risk of having a concussion. If you have a concussion and you have ADHD, you have a higher risk of having a longer concussion. But so there's kind of this, again, interplay between those two. So, is it the ADHD that's leading to a concussion? Is the concussion leading to ADHD? There's theories of, is it that these kids may be a little bit less protective of themselves. They may be kind of just going out and running as fast as they can, not thinking about worrying about getting hurt or anything like that, and potentially having more concussions from that standpoint. Hard to say, but we definitely see that there's a relationship in between those two. So again, all of that is kind of trying to just say that there's some aspect of mood that plays a role in concussion. There's some aspect of concussion that plays a role in mood, and they're not mutually exclusive, right? So that goes both ways. So how do we treat mood symptoms if we do kind of go ahead and notice that these patients are having a lot of trouble with their mood? The first one, reassurance education. Next one is going to be mindfulness relaxation. Third one, big one that we'll talk about, cognitive behavioral therapy, and then medications. And as you've heard already many times today, active rehab, exercise is medicine. Yes, do that. That's good. Okay, first one, reassurance and relaxation. So the data here is kind of from a systematic review where they're looking at a bunch of different studies and how some of these things played for kids who had concussions and whether or not this helped them get better. So first one, reassurance and education. So kind of mixed results on this from the studies that they looked at, but generally either neutral or positive. So although mixed, skewed towards the positive way. But again, anecdotally from my experience, making sure people understand that this is a normative part of a concussion and a normal part of their situation and their rehab process. Because I believe it was Leslie, somebody was saying that, if you've got this going on, you may think, and you don't have a specific history of concussion or previous people who have concussion in your life, you may think you're going crazy. You may think, I thought concussion was I just get a headache, and now all of a sudden I'm irritable and depressed and anxious and all these other things are going on. So making sure that we kind of normalize this for patients and making sure that they realize that this is not something that's in their head, so to speak, but something that a lot of us go through, especially if we're having a concussion. Next one, relaxation, mindfulness. So again, this kind of depends. I try to tailor this depending on who I'm talking to. So if there's kind of somebody who's coming in and a little bit more disparaging mood, they got maybe like some sandals on and like some dreadlocks and some, they're more into some of that kind of stuff, they may be much more open to some mindfulness techniques versus if I'm talking to like my grandpa, we're not gonna get too far, right? So you gotta base it on who we're talking to. But there's some decent evidence to again say that working on some mindfulness, working on some yoga, working on some meditation can definitely be useful. And it can be useful not only for mood, but that could be, especially if we're talking about yoga, that could be something where we're working on not only some exercise aspects, but depending on what positions we're working on, that could be working on some vestibular aspects as well. So there's a lot of overlap that can be going on with that. All right, so let's talk about what my main talk is supposed to be about, which is cognitive behavioral therapy, or CBT. So this is kind of the gold standard as far as therapy for many things, but certainly for concussions. So the idea of CBT is that you've got behaviors that you're doing, you've got some thoughts on those behaviors or thoughts that are causing you to behave in a certain way, and both of those are then feeding into how you're feeling and how you're responding to the external environment that's going on with you. So the three core principles are you've got some problems in the way that you're thinking about what's going on, or you've got some problems in the behavior that you're doing after you've been thinking about these things. But the third principle is that these are modifiable. So we can change these. We can learn better ways to attack these problems that we're dealing with. So what is CBT? So basically we're going to be working on recognizing the distortions in your thinking. We're going to work on some coping skills. We're going to maybe role play a stressful situation so that you can try to have a better behavioral response to those things. Calming strategies can be a big one. And I think one of the big ones that I try to drive home to patients is that it's focused more on your current situation and not on previous history things. So a lot of people, the stigma of therapy is definitely not what it once was, which is good. Bad news for that is less people are stigmatized for it, and so they're more interested in getting therapy. Great. But the supply has not quite kept up with the demand there. So it can take a long time to get into therapy. But I also trying to focus on these people to tell them that it's not the kind of therapy where you're going to be laying on the couch and saying about how when you were in kindergarten, some terrible thing happened and you're really worried about it. And it's all stemming from that one individual thing that happened forever ago, right? This is, again, more on coping strategies. What's going on now? How do you feel about certain things? What are the things that are making you have that depression, that anxiety, whatever it may be, kind of spike right now? And how can we better address those things? So let's look at some evidence to see, does it actually work? So this was probably my favorite article that I was reading about this. And so it's from McCarty. And basically what they did was they took teenagers. All these teenagers had already had symptoms for over a month. And they were, so at this point, they're PPCS, right? They're prolonged concussion symptoms. And they divided them into two arms. One was control. So we're going to let you exercise a little bit. We're not going to let you do too much. We won't make you push from a return to learn standpoint. And then the other one was, okay, we'll do all that, but we're also going to have you talk with a CBT therapist. We're also, if it's bad enough, we'll have you talk with a psychiatrist about, do we need to actually start some medication for you? Interestingly enough, in the study, they only wound up starting medication on about 10 to 20% of the actual arm that was getting that therapy. So it wasn't like everybody was getting SSRIs or anything like that. But at 6 months, 42% of the control group still had high concussion symptoms, whereas the actual intervention group was down to only 13%. So there's a really significant improvement in a lot of people's functions just by having them go and talk to a therapist and work on this. Getting back to that systematic review, they looked at 3 RCTs, all showing benefit with cognitive behavioral therapy. They also had a couple non-randomized studies, but again, all showing significant improvement in outcomes with people who wound up doing CBT. So it's good, it works, we should do it. Medication. So sometimes you need a combo of both, right? Sometimes you're getting a little bit of benefit from your cognitive behavioral therapy, but maybe they need a little bit more. Maybe this is a person who's got a baseline of some mood issues, and this concussion is really just unearthing a bigger problem that was already there. Well, we may need some meds. Our first line, usually SSRIs. My first go-to is usually Lexapro, more from a side effect profile, familiarity, and just had good experiences and good outcomes with it. But there is obviously certainly more than one SSRI out there. And if those aren't working, we can always go to our second line of an SNRI. There is some data out there that suggests that maybe this isn't really necessarily beneficial in this population. So this was a meta-analysis in 2018, but there's some kind of issues with that. So one of the main issues is that they included a couple of studies that had, instead of really mild TBIs, they were more moderate TBIs. And if you actually excluded those numbers from their meta-analysis, there would have been a significant improvement with this. And the other issue is that it's not really how we use medication for these kind of patients. So it's not either, you know, we tried this medication, it didn't work, then okay, give up, you just starting a person for medication. In the general setting of trying to treat somebody with medication from a mood disorder, you're going to try an SSRI. It's going to take 4 to 6 weeks to even see some benefit. If it doesn't show any benefit, or if they're having a side effect, we're going to switch and try a new one. That didn't work, okay, we'll switch and try a new one. And there's a lot of times where they don't maybe get as much benefit from the first or the second, but the third time around, oh, this medication really does help me. And so the study there kind of doesn't quite encapsulate the real way that we're treating. So there's another study that was saying, hey, never mind that other study's no good, do SSRIs. So yeah, that's kind of the basic stuff. So take home points, right? There's this bidirectional relationship with all of these things really, but specifically concussions and mood. And then early recognition and treatment of symptoms is hugely important, right? So we don't want to let these kids or adults just flounder for a long time. If we see something that we can really make a difference on, the sooner we get into there and the sooner we do something about it, the better. References, questions. Person who gives me all my mood symptoms. I think that's it.
Thank you very much. So we made it. So we're going to take just a couple minute break. So you guys can grab a drink, restrooms while we set up our panel. So all the speakers that are still here, we'll just have us sit here and we'll address all your questions. We're going to do this pretty quickly and then get things wrapped up. So if you don't need to use the bathroom, there's no problem. We'll just take a minute to do this. Okay. Yeah, Jessica's got a lot of questions on the chat we can try to address.
It's blessed to do things like this.
Like it. That's right, we'll have it recorded, so you can always. Always a pleasure with you here next year. Yeah. Yeah.
How are you doing? No. Okay.
Well, I got here this afternoon. I did not
See her.
Yeah, I've been here the entire time. How rude of you. How's everything?
Last week though. Yeah.
Oh, good, Oh, my goodness.
All right, we're good.
Oh,
Okay, cool, we can roll this.
perfect.
So you out of the hose. It's gonna be the first part.
Oh, good. Oh, that's great.
Solid amount of time.
Stay tuned and then I'll get back to
Yeah, still trainable. Okay. So.
All right, if we can have the folks from the panel come have a seat up here. And we can slowly get settled in for the last 15 minutes here. We've got our remote speakers on as well. And that's Dr. DeLeon and Strader. I think a couple of our speakers from the morning had to jam, but that's okay. We can field their questions as best we can. So, fantastic. So we've got a few chat questions. Let me start with the group here, though. And we can field a couple of questions from the audience, and then we've already got some questions up on the screen as well. So, yes.
I have two. Does Spark take Medicaid?
Do we take Medicaid? That's a good question. I don't have the exact answer. I know there's definitely some insurances where there needs to be authorizations, et cetera, but I can get you the people that can answer that question a little bit more effectively.
The other question is, how young of a child benefits from post-concussive treatment?
When they're babies, I've had a 2-month-old brought to me because he fell and hit his head and had a skull fracture. So it's just a different approach. A lot of stuff we're talking about obviously doesn't apply, active rehab, investigative rehab, and all this stuff. But as soon as, they're 3-4 years old, if you have a good pediatric therapist that understands how to get down and do some of these things in a play way, Jason, you're a PT here, so you can comment on that. I've certainly seen a lot of great benefit, even little kiddos like that. So what do you think about that?
I think if you have some.
Oh, real quick, Jason, the mic is here for everybody else, so just keep your voice up if you can.
I think the concepts of treatment can be extrapolated to that pediatric realm. And so if you have someone who, like if you were to have a young kiddo that was diagnosed with a concussion, but then have a good pediatric therapist, I think you can have collaboration between them, and that pediatric therapist may be able to incorporate different modalities of those concepts to target that person appropriately.
Yeah, and as pediatricians, a lot of us who have that pediatric background, we understand that you have to make adjustments depending on the age when it comes to the evaluation, the exam, and certainly those doing the therapy. So, and Dr. Pollack, for you, I'm sure you're also, have seen little guys, 5-year-olds, 4-year-olds, and you have to adjust what you guys do so that they can sort of keep up with what you guys want to get out of them, right?
Yeah, the pieces that we tend to kind of hold back, and some of the parts that I like to mention is vision is learned. It's a learned process. So the sooner that you can have that evaluation and you can find out how that system can be integrated in a balanced way, the more opportunities it is for that child to have the best level of integration between vision, brain, and body, right? So I always go for the earlier the better, and we see what we can do. Sometimes we all get creative, but all of us are creative in how we look at things, and we'll do as much as we can, and then just if it's watch, then it's watch. But if it's, oh, wow, do these different types of movement to incorporate, because, you know, just looking at crawling is important, and making sure of how they move their head is important, and all those pieces. So the sooner that we can look at those modalities, I feel the more empowered we are for the child.
Thank you.
Great questions. Other questions from, yes?
On Brett, on your piece, one of the first things I thought of when you were talking was moving into the mood and the behaviors. But when they have a concussion, is there a part of them that goes back into the skill set that says, how did I get here? And they want to relearn the move or the the athletic piece of it before they actually get into a whole psychology, anxiety, So the first thing I thought of was, I didn't see that piece, like, how did I get here? What did I do wrong? Okay, let's practice that. I get I'm depressed, I get I'm anxious, I'm a little bit afraid, whatever, but I need this. Is there that part too on?
I'm not sure I understand the question. Do you mean like from an athletic perspective of
Yeah,
how did they
Because
get
they've had
injured?
a concussion,
Uh-huh.
and now they have some kind of mood, anxiety, and all the different things that you talked about that. But is there a part of them that goes back and says, I just need to know, did I move this way wrong, or can I see that way again? Like, it's a whole physical athletic skill.
So, and if I'm not answering this correctly, let me know. But what I'm thinking you're saying is, so are they getting a little bit nervous about getting back to their specific sport, or are they going to be able to get back to their sport and do that move the way they had done before? And is that going to put them at another increase in getting another concussion? Or
I guess I never thought about the anxiety, the mood, that when you first started talking, I think working with students, my first thing is wanting to know how did I mess up that I got injured? It's completely skill. And so when you presented, the answers were over here. They went into the mood, the anxiety, the depression, being careful, blah, blah, blah. But is there any part in your work where it simply is, let's just kind of go back here and see if what the skill that you're looking for is really this as a priority?
Yeah, for sure. When people are rehabbing and getting back into everything, they need to be able to feel comfortable at each specific step. So if they're not, and yes, to your point, we do back them down, and I think Jason could corroborate this certainly, and start from square one. Like, are you moving this way correctly? Do you need to have more support than this? Are you having some balance issues here before we kind of get you back up into your specific sport-specific exercise? And so they need to be able to feel confident in each spot, because to your point, if they're not feeling confident, that's a risk factor of going back in and getting another concussion.
I guess I didn't see that.
If I could state something too,
Yeah.
having both sides, being a mom who has a kid in sports and also on the other side looking at concussions, is that one of the biggest pieces that I do even with my own sons is I go to Spark and get a baseline. Because I think we lose that dynamic assessment of what is the baseline, where am I, where are my skill level, right? And then you can say, okay, well, as I go and do the concussion, where did I miss it, and what else do I need to be working on my personalized baseline? Because I think we're missing that piece of, where was I in the beginning? What do I even know what I could do? And then realize, gosh, I actually have trouble with this and this that I wasn't aware of, that no one else is doing.
Right, I think that was my next piece was that all of this, the working with students, when they go into their internship, when they're looking for their placement, some of them have an injury, they have a story about why they want to get into that health. And they don't have a roadmap. And that's one of the things I'm thinking is that when they go into your facility, there's so many opportunities. Like, I don't know that there's a roadmap that says, here's a menu of services so that we make sure that if you do have some blurred vision or walking down the hall, they just, you hear from the students, it's a behavior thing, it's a mood thing, never thinking. It could be part of the situation you just lived through a year ago. They've not associated as you're just a moody kid, or you're just a situation. And this is the thing, I think, working with the internship students, they have these stories, they're all on anxiety medications, or 90% of them, or 80% of them are all on anxiety medications, and they're part of this journey going into healthcare, but they have a story.
And that's
they
what
need a
that
roadmap.
baseline, and that's what that baseline does, is say, I didn't even know I would have these different difficulties. And either you're saying, oh, there's a weak link, you need to really kind of work on these things, or you're saying, oh, wow, you know what, you're doing pretty good and you're fine, or wow, you really are having some difficulty here, and these things may be causing some of those mood difficulties that you're facing, and what can we do to support that? So that foundation is strong to have those baselines. I cannot tell you how important it is to have that foundation.
I would like to be a part of that.
And I think if I'm hearing you correctly as well too, and I think this is the benefit of that multidisciplinary team. We may not have the psychological interventions that the clinical psychologists may have, or our sports psychologists may have. And so if someone is having those type of thoughts and they go to those counseling services, that is definitely a technique that kind of looking back at this, like replay that injury, break it down, understand it, that they may be able to help out with it. So I think the four of us up here may not have necessarily that psychological or counseling toolbox that you're talking about, but I can see how that's so important and how that would be so valuable to help reset.
Yeah, you're the parent, you're looking at it and you go, oh, I had no idea.
Yeah, but it opens you up, right? Because then you can look at the different specialties. And I know with vision, if the peripheral system is overstimulated, I get anxiety, I get depression, I get isolation. And so that is huge in my space. Now I'm very biased, and there's all these other spaces that baseline is going to give you to say, okay, there's a visual issue. You know what? No, there's actually a structural issue, or there's a cervical neck issue that we need to address. And it creates some kind of menu to say, okay, at least I know. And if I'm going to ignore it, well, at least I knew what was going on, right? It empowers that person.
Thank you.
Thank you, great question. Next question? Yes.
I have a question, I think Dr. Combs, is it?
Yeah, so Dr. Combs is not here, but we'll try to answer your question, and we've got a couple other questions for Dr. Combs.
And Dr. Combs, or whoever wants to chime in. What are your current recommendations for sleep support? Any supplements or anything along those lines? And I know he only took care of kiddos up to the age of 18. When you have somebody in your clinic over 18, who do you recommend for sleep?
I think I can field that question, and we see sleep dysfunction in so many of our particularly complex concussions. So generally, we really, like I said in my talk, we really like to start with using all the non-pharmacologic and even the non-supplement interventions that we can. So one example I gave is if someone can start doing some exertional rehab, get exercise back in their life they've been told not to do it, that can make a huge difference with sleep. Sleep routines are critical, so we really dive into that. Same bedtime, same wake up time. We really try to have that golden hour. Dr. Combs talked about it, which is really a wind down opportunity before you go to bed. So if your goal bedtime is 10, by 9 o'clock, you're really trying to reduce overhead lights, no screens, wind down activities, no strenuous conversations, obviously no strenuous exercise, et cetera, et cetera. And if you can keep consistency with when you go to sleep and when you wake up, and do the right things before you go to bed and the right things in the morning when you wake up, you can establish a pretty good routine, and that goes a long, long way. Beyond that, we still find folks that still struggle with sleep induction or multiple awakenings, and that's where we may start to tap into some supplements or medications. We usually start with melatonin, just like Dan Combs was talking about, low dose melatonin, depending on the age and whether they're used to it or not, somewhere between 1 to 6 milligrams, something like that.
Nothing other than melatonin.
There are other things we use, but 90% of the time it's going to be that, and then there's going to be more complex situations where you're doing all that and they're coming back and saying, hey, I sleep 4 hours a night still, you know, and you're trying to recover from a concussion. So you do have to do more sometimes. So there's other medications that can be utilized. Sleep medicine. So Dan Combs is peds, but you know, Banner has an adult group as well. TMC has a group. So there are adult options for sleep medicine doctors and sleep studies as well, if we're particularly worried about the quality of sleep being affected by some sort of central induced apnea because of the brain injury. And that can happen. Great question. Yes.
Okay, so I have a question about bridging the gap for short-term acute care, because when you are an athlete and you get injured, you have your athletic trainer to help with that short-term, so you're less likely to have post-concussive. But if you're in a situation of which, like say you get in a motor vehicle accident, where do you think we can go to bridge that gap of not having the acute care right away?
That's a great question. Does anybody want to jump on that? I mean, that's not an easy question to answer. It's all about access to care, right? I think it starts with awareness. If there's an awareness in the community that regardless of who you are, this isn't about athletes. This is about anybody who has a brain injury, right? So regardless of who you are, you should have the opportunity to understand that early intervention gives you better outcomes. And from there, it's about access to care. So if you know you're severe enough, your access to care may be the ER. If you're not, and you're lucky enough to have a primary that can see you quickly, then that's where you're going to be. But we know there's a lot of gaps where these people have to wait months to see their primary or whoever specialist that you know that they need to see. But I think with a lot of the growth in this area, we are building and building on really just opportunities and options for people to be able to get in and get early intervention quickly. I know that in our clinic, we're not making people wait. If we get a call and more or less the insurance lines up, we can get them in quickly. I know Jason's clinic is more or less the same. I know if I reach out to Dr. Pollock about somebody who really needs that kind of care, I know she would get them in quickly. So there isn't this 3 to 6 months and, good luck while you wait. I think in this community, been fortunate enough that we do have places that can initiate early intervention for the general population after an MVA, say, pretty much right away. Our problem is the folks that don't have insurance or have insurance that for whatever reason they can't get into the right people quick enough. That's still definitely a gap, and it's a tough one that I think we're working on. So
and I'd like to jump in and tell you that I come in as a vision consultant, but I would tell you my refer is first to Spark. It is because they understand what to look for in a concussion and how to start being able to treat it immediately. I'm here because I believe in what they're doing. So that's the part. And unfortunately, I think there's a lot of education. There's a lot of gaps that are missing of really understanding about concussions and how quickly to be able to move. And then that's why they kind of go through a system and then they go back to Spark and say, oh my gosh, I just didn't know. So, I think that having that opportunity to go to that clinic and say, okay, they can go through the standards, they can have the evaluation and see what's happening and then say, okay, here are all the red flags, you're good to go, or wow, we need to start in that treatment, and how to start to get them back again, right? So I think it's important to understand that gap and the respect of where we can get help.
And I'll piggyback and I'll just say, you guys probably picked up from my talk that we try to have a comprehensive approach, right? So, I take pride in really being able to assess all the different subtypes and profiles. But I also recognize that I'm not able to treat people with severe problems in any of them, right? So at the end of the day, I'm gonna have to take that, predominant vision profile or refractory vision profile and talk to Dr. Pollock or Jason if we're, dealing with someone with cervical or vestibular, or our psychiatrist colleagues or counselors in behavioral health, et cetera, et cetera. So, at the end of the day, I think, our role is ultimately as coordinators of care. We see ourselves as sort of a quarterback to be able to really get early intervention directed. We do as much as we can in one clinic, but at the end of the day, it's really a village approach, and all the pieces are critical. And it's critical to be able to get in quickly, because I can say, oh boy, you need to. But if I can't get them in,
why are kids doing that?
So, okay, so great question. Other questions from the audience? We've got a few from the chat that I can dive into. Yes.
So my question is probably better more towards Jamie. So when it comes to progressing concussion treatment with collision sports, I know we talked about touching symptoms, not going through them. So you have an athlete that's okay with cardio, okay with cognitive rehab. You get them into a little bit of impact, nothing live, pads, things like that, but that develops symptoms. So how would you, I guess, how do you train through impact, like the actual contact things? Or how do you use concussion treatment to reduce those symptoms?
So basically that is a symptom right there. And so that doesn't tell you the origin. And so where is that symptom coming from? Is it because they're having trouble stabilizing their neck during that contact? Is it because there's a vestibular shuffle when that impact happens and it takes a little bit of time to adjust after that? Is it because there's an ocular delay where they get hit and it takes their eyes a second to refocus? Is it something where you have an underlying secondary pathology? Do they have a disc injury in their neck? Something else that's going on. So basically what that tells you is now you've found something there. Now you need to dig in a little bit more and basically say, all right, we've got all of these other things handled. This is going to be our focus, and we're going to target all of our evaluation first and then treatment at that. So long way around to say there's a lot of things it could be, but that's the best part is now you've narrowed it from here to here.
And another point to piggyback that we talked about earlier today is there are some patients, because of the complexity of their injuries or multiple injuries, they may look great when they go back to thud or even hit, and they may even be fully cleared, but they develop lower thresholds for establishing new concussions or developing new concussions or symptoms, even from light impacts, right? And if that's the scenario you're dealing with, then you may have a situation where it's an athlete that you need to have a conversation about the type of sports that they're going to be playing, because that's usually a pretty bad sign that someone really is probably not a great candidate for collision contact sports if they're starting to basically get concussed with very low mechanisms. So in comparison to what they used to do. Okay, other questions in the audience? Yes.
Do you just take patients that have had injuries, or do you also take patients that might have learning disabilities and learning disorders?
Yes.
You take both?
Yes.
Okay.
When you look at there's concussions, and we talked about all the variations for injury with that and symptoms. But also when you look at learning related issues, 3/4 of children with ADHD and learning related issues have visual problems. 3/4. And the beauty is there's so much that we can do to rehab that system and make them stronger, right? Without medication.
Okay, other questions from the audience? Yes.
Kind of more logistics questions. One was, is this video shot, do you guys see adolescents and children? Because I know Randy said you know 18 over and more involved with like college.
You guys do all ages, right?
Predominantly all ages. I would say that we would probably limit it to probably 10 to 12 and above. But for specific issues, if someone was to call us up, let's say that Dr. Mo says, hey, Jason, we've got this kiddo with this specific issue. Can you help us out? We would absolutely do that. I think that there is a lot of very skilled pediatric physical therapists in Tucson. I would tell you that they have a specific expertise that a lot of general clinicians or sports clinicians or orthopedic clinicians may not have. And so when you get into those younger ages, kiddos may be better suited with those therapists or in a collaborative approach. Again, multidisciplinary is a great thing. Collaboration is a great thing. Happy to give you names of people around town too.
And then to refer to you guys as like primary care providers to refer to SPARK. I know you have on your pamphlet the appointments number, but is it best to just tell patients just call, or do referrals kind of easier and helpful?
Yeah, I think I'm not sure, but I think the simple process is generally clinics will fax a referral in, but sometimes they have patients call. So we have a mix of things. I'm happy to give you some information to help you with that question. Yeah, because I don't know the exact best way to do it, but I think we try to keep it so you can do it multiple ways. So, other questions from the group here? Okay, so I think I'm going to move into what we have on the chat, and then we can always come back to the group for any final questions. So Dr. De Leon, are you still there?
Yes, I am right
Okay,
here
perfect.
listening in.
we're gonna go with the question that's directed at you here.
Mhm.
Can she see the screen or? Okay,
Yes,
so
I
number
can.
one, there it is. So I'll just have you,
I'm also going to email this to everybody, so
Okay.
that way they can also just send me back the answers and I'll send it out to everybody.
okay, perfect. And I think that the room can all see the question. So it has to do with seizures and EEG. So Dr. De Leon, go ahead.
So, so the question goes to this issue that I think I briefly mentioned in my talk, right? If we don't happen to do a routine EEG, which would be the first type of a study that would ever be done, can we later on still detect abnormalities in brain waves or possibly even signs of seizures that may have happened? And the answer is maybe. So you don't know until you actually do the test, would be my best answer to you. Now, we're not only looking for seizures, we're looking for focal slowing, we're intermittent slowing in different parts of the brain, which can be very, very telling. We're looking at amplitude changes. We're looking at various things that, are not just a full-blown seizure, which I clinically know that probably somebody did not have a grand mal. Sometimes we can see evidence lingering of a grand mal that may have happened previously though. So a lot of times what happens is we get these non-specific changes when we do routine studies later on. And then my standard of care is probably more than other people would actually do. I usually send or have patients do something called the brain holder. We call it a brain holder in colloquial English. It's an ambulatory EEG. And this is equipment that's just like a routine EEG. It's smaller. We hook people up and we send them home and they sleep with it for 4 nights and 4 days. And they wear it during the day. And then I get, 90 to 100 hours worth of information when they come back and we take the equipment off. And that is a that affords me a much better opportunity to really elucidate what may have happened during the time of injury. What are the consequences still in terms of brainwave abnormalities, albeit seizures or not? And it tells me an incredible amount about sleep. Although I don't have the information about apnea, obviously that's not part of that test. So I find that tool incredibly useful and I use it all the time. And I hope I've answered that question adequately. And there was a number 2 there, right? Something about negative side effects of injections for the phenotypic migrainous type of persistent post-traumatic headache. And I would assume that whoever asked the question is referring to various nerve blocks or cervical facet injections or something like that. Immediately we get side effects of soreness and, some pain at the injection, and you could have possibly some steroid, very temporary side effects. Long term, I don't know of any negative side effects if these things are done correctly. I have seen them done incorrectly and too frequently, too often, and obviously that can have potentially bad side effects long term.
Thank you. Thank you,
I'm
Dr.
sorry?
De Leon. Thank you for the answer.
I was wondering if I could, I've been listening in to the discussion and the questions for quite a while now. I was wondering if I could make a comment about access to care and these gaps and how quickly people can get into clinics and so forth. So I, for the first time, didn't actively participate, but I was in the audience last year at this concussion conference. And, just since then, I think Spark and our clinic have probably shared upwards of 70 patients. Now, that's not an incredible amount of people, but it's, I think, still quite a few people, right? And I think that there's a lot of gaps because of access to care, the way it is in our state or even in our town. But you know, a lot of time, so then people kind of get word of mouth out, is what I found by experience in this last year. And just because other people have had with brain injuries have been at my clinic, self-refer friends or whoever they know with TBI or a possible concussion. So I've actually seen folks that came to our clinic and were not appropriate and needed other types of therapies that, for example, Spark offers, but we don't. So I try to sort of triage if I see people like that and get them into the clinics that are appropriate. And then I think by building these relationships, I don't know that I've ever had a case where we couldn't get people in. So that's just been my experience over the last year. When we get a call for somebody that is post-concussion, you know, concern for seizure possibly, or anything to do with headaches, I can tell you that we get them in within a week.
Yeah, and that's, you know, these are some of the things that we've seen in terms of evolution with respect to care for this. You know, to be able to get into a neurologist that quickly was always a challenge for us. But as we've been able to build our community and our understanding around the importance of timely care for this, we've got more and more folks that like Dr. DeLeon said, that can get patients in quickly. And really, you know, the means are probably there for most people. There are going to be some situations where it's going to be really difficult. And we've run into those from time to time, but we're moving in a very good direction, and I think we have a lot of promise. We are only a couple of minutes away from 3:30, and I want to stay true to, you know, the timeline that we gave. There's some questions here for Dr. Combs and Dr. Snyder that I think we will save for them and then post them for you guys. And I will end by answering any other, I think we got maybe 1 minute. So any other questions? General question. All right, so let's see. I have a client with a history of multiple TBIs, one adult who is now seeing someone for injections, one adolescent who I do not believe has been evaluated. Who can I refer the adolescent to? So we're happy to see any age. So, as you've heard from all the other presenters, you know, whoever asked that question, I think we can hopefully facilitate their needs. And just feel free to, you know, reach out to any of us and we can sort of go from there. Any other questions in the audience? Okay, thank you guys all for being here. We appreciate it, and I'm glad we finished on time. Thank you. Thank you.
Thank you.
All right, thank you guys. All of you guys.
Thank you.
I should have came up with that.